presenting the new Seltos. Now with 6 airbags as standard.
Kia, movement.
क्यों ना एक काम किया जाए, मरने के बाद भी जिया जाए, अंगों को अपने दान किया जाए, ज़िंदगी को फिर से जिया जाए। आओ मिलकर कुछ काम करते हैं, आओ मिलकर कुछ काम करते हैं, जीवन में कुछ अच्छा नाम करते हैं। अंगदान है महादान, इस बात को अब हम समझते हैं। खाक तो सबको होना है एक दिन, खाक तो सबको होना है एक दिन, फिर क्यों मौत से हम इतना डरते हैं। मरने के बाद भी अगर जीना चाहते हो, मरने के बाद भी अगर जीना चाहते हो, तो फिर अंगदान से क्यों डरते हो।
A very good morning to one and all present here. I am Ruchi and she is Shivani. On behalf of organizing team, we welcome you wholeheartedly to this program on transplant coordinator training come master class on organ transplantation 2022. I request all our guests, Professor Dr. Vipin Kaushal, Professor Dr. Ashish T.S. Mahant, Dr. Ashish Bhatia, please come on the stage. We would like to present a token of appreciation for getting time out of your busy schedule and gracing our occasion. Dr. T.S. Mahant, please come on the stage, sir.
हर एक बात में आई रिक्वेस्ट कुर्सी का भी नाम रखा है। I request Dr. Naveen Pandit sir to please come on the stage and please accept our gratitude towards you. Thank you, sir.
I request Dr. Ranjan, please come on the stage. Dr. Ranjana, sorry. कहते हैं ख्वाहिशों से नहीं गिरते फल झोली में, कहते हैं ख्वाहिशों से नहीं गिरते फल झोली में, वक्त की शाखा को ए दोस्त हिलाना होगा। कुछ नहीं होगा अंधेरे को बुरा कहने से, कुछ नहीं होगा अंधेरे को बुरा कहने से, अपने हिस्से का दिया खुद से जलाना होगा। With this positive approach, let's begin the program with lamp lighting. I request all our guests to please come on the stage and light the lamp to spread the sparkling positivity all around.
I request Mr. Ashish Bhatia sir to please present a bouquet to Mr. Sudhir Dhiman, who is the director of Mohan Foundation. Thank you so much, sir. Thank you. I request Dr. Vipin Kaushal sir and Mr. Ashish Bhatia, Dr. T.S. Mahant and Dr. Gurbeer Singh to please sit on the dais so we can proceed to our program further. Please, sir.
Thank you so much, sir. So here's the moment has come to invite Dr. Priyadashri Ranjan on the stage. So please come on the stage and brief about the program layout and what value this program is going to add in people's life. Please, sir.
A very good morning to all of you, all our esteemed guests, respected Professor Vipin Kaushal sir, our esteemed guest, Dr. Mahant sir, Mr. Bhatia sir, Dr. Gurbeer sir, Mr. Diwan sir, Naveen, Ranjana, Dr. Vikram, all our nursing staff, and all the delegates who have come from far off places. I welcome, on behalf of Fortis, I welcome all of you here. And first of all, it is really heartening to see so many people turning up for the cause of transplant. Because organ donation is a field which is much less talked about field till now. लोगों को organ donation के बारे में पता नहीं है. और अब धीरे धीरे जैसे PGI चंडीगढ़ ने लीड ली है, डॉक्टर विपिन कौशल सर हैज़ बीन इंस्ट्रूमेंटल इन डेवलपिंग द cadaver deceased organ transplant program in PGI, and almost in the entire country, PGI Chandigarh is currently the most leading center in organ transplant. आज रात में भी I think 3 donations हुई हैं, तो thanks to them that despite their overnight stay, they have come here to grace our function. So for people who are here, we have divided this course into 4 to 5 days period. So first day we would be talking all about the Human Organ Transplant Act. ये act कैसे बना, organ transplant की जो activities होती हैं उसके लिए law की क्यों ज़रूरत थी, कैसे बना, क्या क्या उसकी policies हैं, और हम लोग अगर transplant करते हैं तो उसमें कौन कौन से laws important होते हैं. So transplant is one field where the other professionals apart from the surgeons are very important. They are called as, if you go see globally, in most of the centers they are called as allied health professionals, and 90% of people in the transplant program are from non-surgical background. So they are non-surgeons. So these people play a lot of role in making this entire program a big success. Even in best institutions across the globe, if you see Johns Hopkins, Mayo Clinic, European institutions, Australian institutions, everywhere the transplant coordinators play a major role in developing, initiating the program. They are the ones who are getting in touch with the family. There's a need of a lot of soft skills, how to speak, how to talk to the family, how to talk about organ donation. So we would be covering all these aspects in this conference. So we have really worked hard to design a scientific program in such a way so that everybody benefits to the maximum. So day one would be entire discussion on Human Organ Transplant Act of India, which is applicable to all of us. Day two would be what is a brain death, how do we define brain death, how do we take organs from people who die in the hospital. Day three is entirely about kidney transplant, both living, deceased kidney transplant, pancreas transplant. Day 4 would be lung transplant, heart transplant, and other organs apart from kidneys. And day 5, we'll conduct an evaluation, which will be, the program is basically skeletized, designed by Mohan Foundation. So Mohan Foundation stands for Multi-Organ Harvest Aid Network. So this is the largest and the most prominent foundation in the country, which is working for developing the cause of organ donation. And we are really fortunate to have 2 very prominent persons from Mohan Foundation. Mr. Sudhir Diwan sir is here. He's the director of North Zone of Mohan Foundation. And Ms. Sujata Suryamurthy, who has flown all the way from Chennai. I welcome you, Sujata. And she would be the master tutor for the training program entire. So they will conduct a pre-training evaluation also, so that they can check what background knowledge about organ transplant you have. And then on day 5, since it's a certification course, we will conduct a post-training evaluation. How much you have learned out of this course, so that you can give your inputs, improve your knowledge, and then the certification will be done. Also, there's a feedback form which will be given to you after each day's session, so that you can give your feedback regarding the sessions. आपको क्या समझ में आया, क्या नहीं समझ में आया, कहाँ difficulty है. And this program should be an interactive program. So I request all of you to interact with the faculty, whosoever is coming. There are very prominent people coming from PGI, from Mohan Foundation, from our organization, from different hospitals, who will be trying to clear your doubts. So don't hesitate. And with these words, I welcome you all. And thank you so much for being here.
Thank you so much, sir. Now let's move toward the next segment of the program. So So it's time to understand the importance of organ transplant, why organ donation is important, and why it is talked so much.
Every year, around 6 lakhs people die in India due to shortage of organ. This could be due to accident or the failure of the specific organ. There are many people who are in need for the organ donations, but we have very less number of donors available. Organ transplant can help saving the life of the people who've been fighting to survive. Many lives could be saved and significant deaths could be avoided if organ donation is done at the right time. I would like to say that death cannot be avoided and no one can run away from death. Organ donation is a noble act so that could give a ray of hope to another person's life who is suffering through many years because of failure of particular organs. Be the part of the noble act and be a donor.
वो आए हमारे घर में, खुदा की कुदरत है. वो आए हमारे घर में, खुदा की कुदरत है. कभी हम अपने घर को देखते हैं. Sir, I would like to welcome our guest, Dr. Gurbir Singh, who was the former medical director, Fortis Hospital, Mohali. Please, sir, come on the stage.
Good morning, all. And at times, I mean, this is the first time I have really felt at a loss of words. This is one time when I feel the memories of my being with Fortis for a little over 17 years, being associated with this transplant program, being associated with the authorization committee as the chairman for many, many years. I wish to commend and compliment the entire team, surgical, non-surgical, as well as the administrative team of this very wonderful institute, who have, you know, in all humility, we have partnered with so many other people to keep alive this one major facet which can still give life to another person. I do feel very humbled when I recall Ranjan meeting me in the corridor and saying, "There's no way you're not coming for the inaugural session. You have to be here, sir." I mean, I really felt that I was still on the rolls, which I think I will remain to be till I go on some other role. I mean, the tempo of the entire day has to now be geared up by the professionals who would be taking you through, navigating you through this wonderfully orchestrated program which Ranjan had just outlined. I think every aspect, every facet is being addressed, and addressed to the extent that it would be actually an ab initio becoming a counselor at the end of it. I mean, that's a wonderful thing. With these words, I congratulate, I pay my deepest respect to the organizers and to the participants who have come here to gain from this valuable experience. Thank you very much.
Thank you so much, sir. Thank you so much for your inspirational word and enlightening us with your wisdom. So moving forward, we would like to invite Ms. Kompal a staff nurse in Fortis Hospital, Mohali, to present a Saraswati Vandana.
So in the meantime, as Dr. Gurbir has rightly pointed out, transplant counseling is a very, very important aspect of transplantation. And except the surgeons, rest everybody has to do this task in deceased organ donation. So that is the entire ethos of this program. So I think Kompal is here. You can begin.
Kompal.
शिशु है अज्ञानी माता, इन चरणों का प्यार दे। वीरा पानी तार दे, तार दे, तार दे। माँ सरस्वती शारदे, माँ सरस्वती शारदे।
Thank you so much, Kompal. So I would like to welcome our esteemed guest, Professor Dr. Vipin Kaushal. Sir is the Regional Director of Regional Organ and Tissue Transplant Organization for North India. Sir is also the Head of Department of Hospital Administration and Medical Superintendent of PGI Chandigarh. Under his able leadership, the diseased organ transplant program at PGI has made a path-breaking success, which is exemplary for all of us who are passionately working toward the field of organ transplantation. Sir, we are privileged and honored to have you our guest of honor and would like you to address the audience.
Thank you. Good morning, all. Dignitaries on the dais, I am saying my senior faculty from PGI, Professor De Vera, who started the lung transplant program in PGI. It was started and we have done one lung transplant since then, and we have shared many organs down south with Tamil Nadu, lungs. Only yesterday we have shared heart because we didn't have a matching recipient here in PGI, and it was allocated by Noto to RML hospital, and just now I got the information patient is out of the OT and doing well in the ICU. That and kidneys and liver has been done in the PGI itself, and we have one more potential donor. And all this is being possible because of transplant coordinators, who are the pivotal in any program like this, the diseased organ transplant program. As already highlighted, there is acute shortage of the organs, lifestyle diseases are increasing, end stage kidney failures, heart failures, liver failures. The requirement is too much, but we meet very less demand. And it is a diseased organ donation program where we can match and fill that gap. Fortis Hospital, Mohan Foundation, Chandigarh Kidney Foundation has taken this responsibility of conducting the program for the transplant coordinators. As already highlighted, there is one surgical team and other is the non-surgical. If the non-surgical team does the good work, we get the very good results. The transplant coordinators, okay, everybody wants to be, but it is a very challenging task. Our transplant coordinator, one of them was working for last 36 hours in the hospital for making this to happen. So it's a very, very challenging. You need to have passion for that. And most of the time you have all, that's why you are choosing this kind of profession. And then you have to be professionally very, very sound. You need to have the medical, the legal, the ethical knowledge of everything. And more importantly, the communication skills. How to communicate with the next of the kins. Who's the next? A very important person is going to be, you have to declare that he's no more. So that skill is very, very important, the grief counseling. So this kind of program is very, very important to hone your skills. So this is 5 days program. I think you will learn so much in this program. And I look forward towards the Fortis Hospital to start the diseased organ donation program. Dr. Priya Ranjan is very, very active. And once we shared one kidney from there, there are issues in Punjab itself, sir. We have created the SOTO. It was created way back in 2016. But still, yet it has not that kind of activated. As Rajasthan, we being the Roto North, we have 7 states, and everywhere the SOTOs have been created. The main objective is to create awareness in the public and enhance the disease organ donation program. You should also put efforts from the Fortis Hospital, because you are the leading corporate hospital in this part of the country, to motivate the authorities in Punjab. I am putting all my efforts. So this program should pick up, and there is a lot of potential. Many lives can be saved if we promote disease organ donation program. I wish this program a great success. Thank you, Dr. Priya Ranjan, giving me this chance to come here. Thanks, organizers. And as when the program started, she said, कि लेके क्या जाना है साथ में, एक दिन सभी ने मरना है, लेके क्या जाना है साथ में, क्यों ना organ donate करें. So I just asked, how many of you sitting here have pledged your organs? So many of you, but those who have not pledged, please pledge and motivate others. So that this is a gesture, and we need to take a lead so that the gap which has been highlighted is decreased. Thank you. I wish a great success to this. Thank you very much. Thank you, organizers.
Abhijit sir, I would just request you to please welcome Dr. Behra sir. Sir is here. Also, our master tutor of the course, Ms. Sujata Surimurthy, please come.
Thank you so much, sir. गिर गिर के यारो मुझे खूब संभलना आता है, गिर गिर के यारो मुझे खूब संभलना आता है, जलकर बुझना आता है, बुझकर जलना आता है. अपने ही किस्मत लिखता हूँ खुद अपने ही हाथों, अपनी ही किस्मत लिखता हूँ खुद अपने ही हाथों, मुझको सारी महफिल के अंदाज बदलना आता है. Let us now welcome the man who is known among all of us for his wisdom and his knowledge, Mr. Ashish Bhatia, Chief Operating Officer at Fortis Hospital, Mohali. Under his leadership, we received many accreditation and the highest national recognition for quality, patient care and safety. Sir, we would like to request you, please come on the stage and say a few words.
Very good morning to all of you. A very warm welcome to Fortis Mohali for this wonderful program that is being organized today. Dr. Vipin, Mr. Diwan, esteemed guests, participants, first and foremost, Ranjan, wonderful to have taken on this initiative and planned this. I'm sure the next 5 days are going to be very interesting for all of you. There's going to be a great learning for all of you. And once you go back to your respective hospitals, you will find that you have gone back richer with knowledge that you have acquired in these 5 days. A lot of wonderful things have been said about organ transplant, the need for organ transplant, what we need to do, especially in the state of Punjab, which is lagging far behind other states in organ transplant. As coordinators, as nurses, you are going to be doing a wonderful job by helping people who have come to us for an organ transplant. So there is this one side, which is the medical side, which is going to be about saving lives, about doing the transplant. And your job is going to be, as I understand it, at least the coordinators, in terms of coordinating and motivating people to donate organs. Now, there is a third facet to all of this, and that is the legality of what is being done. And as administrators, what comes to our knowledge more often than other aspects stage. And very often you keep hearing about some kind of a scandal somewhere or the other, and people are coming up with more and more innovative ideas by which they can hoodwink people to go in for a transplant. So you will have to be ever vigilant when you do this job, because you have to make sure that whatever we do is overboard. I wish you all great learning in the next 5 days. Don't hesitate to ask questions where you need to ask questions. You must go back satisfied of having spent 5 days in a great atmosphere with friends, with colleagues, with people who are learned, and imbibe from them what you need to. Thank you very much, and all the very best, Ranjan. And before I leave, Ji, my gratitude to the PGI for participating, for Mohan Foundation for helping with the course content, and this collaboration is what it is all about. We must look at more and more ways of collaborating as we go forward. Thank you very much, Vipin sir.
थैंक यू सो मच सर, इट वाज ग्रेट टू हेयर यू. मिलते तो बहुत लोग हैं राहों में, मिलते तो बहुत लोग हैं राहों में, मगर हर किसी में आप जैसी बात नहीं होती, मगर हर किसी पे आप जैसी बात नहीं होती. वी आर टॉकिंग अबाउट डॉक्टर T.S. महंत, whose names need no introduction to all of us, as one of the most eminent cardiac surgeon in the country and the Fortis Hospital, Mohali. Sir has been keenly involved in initiating heart transplant program at our hospital. We sincerely thank you, sir, for sparing time today, and also request you to come on the stage and say, please address the gathering. Please, sir.
से बोला जाएगा. Good morning, everyone. I think Ranjan didn't ask me to that I had to speak here, because to come in front and talk something is the most embarrassing to me. I find doing cardiac surgery much more comfortable than coming onto the stage. So I'm not going to make a lecture, but I think we are delighted to have Dr. Kaushal, our administrator, Mr. Bhatia, Dr. Our friend, and I'm you must ask. The part of thing which Dr. Kaushal said, so many organs were transported to the other part of the country. I think these are the things which hurts me the most, because why I am saying we have so many needy patients in this area requiring heart transplant, kidney transplant, liver transplant, and whenever I read in the newspaper that the organ were transported to Bombay, Calcutta, to some other places, I must tell you, it hurts me. I many a time don't see this type of a news, that why in the north we have been lagging behind. Why in the north, where this organ transplant program is so successful started with the Chennai, but lately in last few years it has picked up even in the small states also, and throughout the country the organ transplant has become now a routine procedures. It started with the kidney, but nowadays, being a cardiac surgeon, I must say the cardiac transplantation has picked up so much in the country that even in a small place, it is being done. I must tell you, the theme of today's here, this 5 days meeting is to train the paramedical staff. It's a good idea. When Ranjan came to me and we discussed it, I thought this is a very good idea to train the manpower in this area, because I think you will all agree with me, barring liver transplant, the other types of transplants, they're technically much easier, and the cardiac transplant would be the easiest to do, even easier to do than a kidney transplant. This is from my own experience. I've seen it's only a 1 hour job, but I think the main job starts from all of you, for which this program is being organized. It is the coordinators, it is the administrative staffs and the other people who makes this transplant program to happen. I came back long time back from overseas, and there also it used to be a coordination. We used to take hearts from Melbourne, from Perth, and being transplanted in Sydney also. That time I used to say it is not the transplant surgeon who is doing a marvelous job. It is the coordination, it is the people involved in making this program successful. And I think the successful story in India has been the Mohan Foundation, which made this program successful in the South also. And I'm sure with your help here, we may be able to do good in the future. Dr. Ranjan, I congratulate him for organizing this program. And I think Dr. Ranjan, he also needs to know, he's been such a, he's not that senior, I would call him my junior to junior students, but he's done so much, made his name and fame, and the work he does in this area is, I think, kidney transplant is the one program which Fortis can boast that we are doing here. The other, we are still, he said that I started this program in Mali, but we have not done a single case here in the cardiac transplantation, and I don't know whom to blame. Myself to blame this place. And this has been my desire also, to do a cardiac transplant, lung transplant in this hospital. This is the only wish I have left in this area. I have been here for 17 years. Like, we do lots of other cardiac surgery here with good results, but the cardiac transplant, heart lung transplant has been my desire to start in this area. And with this, again, I request Dr. Kaushal and Mohan Foundation to help us. And I know in the beginning it will be your organization which will be helping us to start this program. And I know I have few interaction, and the people from PGI, they have been very helpful. Even your coordination people, they have been all the time saying that we are going to help you, because that is the nearest for us to get, and we can start our cardiac transplantation. Meanwhile, I wish Dr. Ranjan for making this program, and it will be a very useful, and I have even asked him that from cardiac team also we will nominate few people who will attend this function wholeheartedly and help us in future. I hope we get the certification. It hurts me again, Mr. Bhatia, that you can do a transplant in Alchemist, but you can't do a transplant in Mohali. I don't know what is the cause. Whereas center government, all other government, they give this certification without even going into the detail of it. So this is the question. I think I'm not going to embarrass you by saying that we have not been very successful in getting registration here, but I wish future things will change, and one day you will definitely hear. This is my last wish to do a lung transplant, heart lung transplant in this area, and we seek that is. And I tell you, this organ transplantation nowadays, it's not confined. It is a team of transplant team which goes renal surgeons, cardiac surgeons, and the GI people. Everybody coordinates it, and you know how we take it, these organs one by one. It is the one which we give them permission to take kidney and the liver, then we take the heart at the end. Thank you very much. I wish you have all the useful 5 days in this and go home with some wisdom. Thank you.
Mr. Ashish Bhatia, sir. Sir Vikramjit, sir. Dr. T.S. Mahant. Lena. Dr. Digambar Behra. Dr. Gurbir Singh. Dr. Naveen Pandey. Dr. Ranjana Singh. Dr. Sudhir Diwan. Miss Sujata. Mr. Abhijit Singh. Thank you so much, sir. Thank you.
So with this, I would like to start the proceedings of the program. First, the introduction to the course would be done by the course director, Madam Sujata. So Sujata, I would just request you to briefly outline about the course and let everybody know how they are going to sail through all these 5 days. So first, Mr. Sudhir Diwan, who is the director of the Mohan Foundation of the North area, he will give a brief orientation and overview about the program.
Good morning. I'll start from the main point which has been brought up by Fortis directors, Dr. Mahanta, that the authorization committee of Fortis has not been able to yield results so far as cadaveric donation is concerned. In fact, there has been a recent breakthrough. In 2021 High Court judgment, and that judgment is copy is with Dr. Pradesh Ranjan also. In that judgment, it is very clearly given the verdict that all committee members have to be local from the hospital, and the local members from the government have to be from within the district. So far as whenever there was a cadaver donation, possible cadaver donation in Fortis, thrice I was called by Dr. Abhijit here that we have a donation and possibly it can be converted. And even the family, when they were willing to donate, the two committee members who were from Patiala were not willing to come and certify. So that was the basic problem of hindrance in Fortis for cadaver donation. We will approach the medical director, Punjab, for changing this. They have to put two members of the committee from either Civil Hospital Mohali or any hospital from within the district. Once that is done, you will not have any issue, or we will not have any issue. Mohan Foundation will always be with you, day and night, of course, whenever required. Mohan Foundation doesn't need much introduction. Multi-organ harvesting aid network, Dr. Ranjan has already spoken. It is one NGO which is solely responsible for over 12,000 organ donations all over India. There is one organization which has done more than 12,000 organ donations all over India. And this is one organization when during the course of the day I speak about the awareness programs, has done over 100,000 organ donation awareness programs all over India. So this is an organization which has been in existence for the last 25 years. Today, I mean, this year is the 25th year of Mohan Foundation. And coming to the Transplant Coordinators Training Program, this program is 90th training program being conducted by Mohan Foundation in association with other organizations. And here it is being done by. Out of these 90 training programs, 28 have been conducted under the aegis of NOTO, ROTO or SOTO. Even this time we were trying, Dr. Vipin Kaushal tried his best. Hopefully, maybe during this week, we will get that collaboration, and hopefully you will get a certificate. We are trying at Delhi level, but then there are some hindrance from the ministry. But then over 3,000 transplant coordinators working in India are trained by Mohan Foundation, and they are doing a wonderful job. Many of you are in the threshold of their completing the degree and then considering this as a career. I can tell you this is a wonderful career to pick up in the coming years and decades, because every hospital is going to require 2 to 3 transplant coordinators, and transplants are going to increase. You know, if I go back by 40, 50 years, the heart surgery, which is Dr. Mahant is a master of that. For that, people had to go to Chennai for coronary bypass. Today, at every district level, we have more than one cardiac surgeons, and they are being successfully done. Same is going to be the fate of transplants. Every district is going to have the transplants. There will be cadaver donations or live donation transplants. and the need for transplant coordinators is going to increase, and increase to the extent that you can't even imagine, that we will not be able to fulfill the need of every hospital in the north. Okay? Transplant coordinators are given various names. I'll close my address by just one line. World over, they are called angels of night. You know, the angels of night of PGI, they were busy last night for cadaver donations, and that resulted into 3 donations and multiple organs. So you people are going to become those real angels, okay, in the life of many, to whom you will give a new lease of life after transplantation. Thank you so much. I'll call upon Sujata to give you little insight to the training program.
A very good morning to all of you. First and foremost, would like to express our heartfelt thanks to Fortis Hospital Mughali for making this event possible, and especially to the management and organizers for this wonderful inaugural program. Also would like to thank Dr. Vipin Kaushal from Roto Chandigarh for being here and expressing his support towards this initiative. So without much delay, as everyone said, the transplant coordinators play a very pivotal role in this transplant program, be it living donor, be it disease donation program. They are the ones who are in the middle of the program, mingle with different facets of the whole donation and transplant activities. So this profession has to be dealt with a lot of knowledge and compassion. So we request you to be attentive of this training program for all 5 days. This is not something like a free conference, or we'll just decide which session to attend or not to attend. Please keep this in your mind, that this is a very, very structured training program, and this training program demands all of us to attend all 5 days of the course. So that only, as everyone said, this training has been set out to address the medical aspects, legal aspects, counseling, and transplant coordination. So everything will be dealt over the 5 days, and we have faculty coming from within the institution as well as from the other institutions to discuss about the various nuances. So with that note, would like to make some announcements regarding the structure to be followed. Dr. Ranjan had already mentioned quite a few of them. So just to repeat, there is a formal registration form. Hope you guys have filled it out. If not, please ensure that you are filling it out and giving it to us before the tea break. And the participant kit that had been given to you will have 2 manuals. One is the training manual, which is like a compilation of important aspects of the whole training program, and also another manual which talks about the whole law, the legal aspects. If you ask any of us, everyone will tell us that's the Bible, because whatever we do in this program, it has to be under the provisions of the Transplantation of Human Organs Act. So please keep that always, you refer to that book whenever you are in need. And as said, participants are expected to attend all 5 days. There will be a final evaluation on day 5, and both are mandatory. Attendance of 5 days and appearing for the final examination, both are mandatory for you to qualify to get the final certification. A feedback form will be shared, preferably in the soft copy, at the end of the day. So we request you to be very open about the curriculum, the teaching methodology, so that it's examination for us to know how best it can be improvised in the future. And also, as Dr. Ranjan said, please don't think that this is a small question or silly question or right or wrong. This is the place where we can get ourselves equipped with adequate knowledge. So please do come forward with your questions and get it clarified with the experts. Other than that, I think we are done with all the instructions. I'm going to be here for the first 3 days, and the Chandigarh team, Mr. Divan and Ms. Neha will be there. So anytime you can be in touch with us during the 5 days, regarding anything related to the training information. So with that note, we'll conclude my talk and leave it to Dr. Ranjan. Thank you.
Thank you, Sujata. Thank you so much. So we'll take a short break of 15 minutes. So in the meantime, those of you who have not yet registered, please register yourself, take your kits. There could be some books which are missing in the kits because we have prepared it in a very short period of time. So don't worry, we'll provide all of you with all the teaching material. So don't worry if you don't get any, if anything is missing in your bag. So in the meantime, 15 minutes complete your registration. It's 10:30 by my watch. We assemble here again at 10:45. Thank you so much. I would request the dignitaries to please proceed for high tea and
Okay, the next speaker for the next topic, that is corneal donation and transplantation. The speaker will be Dr. Naveen Pandey, who is the assistant professor and hospital administration in PGI Chandigarh. He has been taking care of the eye donation program in PGI MER Chandigarh. I request Dr. Naveen Pandey sir to please begin the program, sir. Please.
Hello. Good morning. Dr. Mahant, I think he said the things that he was embarrassed and frightened to speak in front of the public. And he was not joking. Sometimes fear of public speaking is considered to be greater than the fear of death. That means, suppose you're going to a funeral, people would rather prefer to be on the funeral pyre or the casket rather than giving the eulogy. That is how frightening public speaking is. But it's important that we speak. It's important that people share their experiences so that knowledge increases, so that people come to know what others are doing. So I have been given this task now, and it is speaking at the end of a conference is much better because half the people are sleeping. To be the curtain raiser, so it is a little bit difficult, but I'll try to convey my message in the most non-boring type of way. First of all, I'd like to tell you that I'm Dr. Naveen. I'm from PGI Chandigarh. I will not be speaking about corneal transplantation for the simple fact that I do not know anything about corneal transplantation. I am not an eye surgeon. What I'll be speaking about is how to increase the corneal donations from the perspective of nurses, from the perspective of transplant coordinators. Right? That is this big question in the world, pehle anda ya pehle murgi, but in this case, there is no confusion. There are enough number of surgeons in India. There are enough number of facilities in this country. What we lack is the availability of cornea. So I'll try to go through my presentation in a way wherein I'll try to show you why we need to do it and how it can be done through my personal example. Okay, so we start with the first slide. These are some of the basic things we see in life, right? These are some of the basic things we enjoy in life. Imagine, just imagine this is all you see in your life all throughout. This is what you will see all throughout, and this is what people with blindness suffer from, right? Imagine this is what you are seeing all throughout your life, 24 hours a day. You cannot see your food, you cannot see your loved ones, and just a small effort from your side, from our side, can bring back the light in these people's lives. It is that simple, right? So these are some facts wherein this will just show you why we need to do this. This is a slide which has been taken from the NPCB, the National Blindness Control Program of India. The prevalence of blindness in India is 0.36. Now, statistics is a little tricky thing because I think Aaron Levinstein said, statistics are like bikinis. What they reveal is very suggestive, but what they hide is very vital. 0.36% of an Indian population, population of India is 1 billion. 0.36% of 1 billion, you can imagine the number of blind people in this country. The number of people who cannot see anything all throughout their life. And out of that, corneal opacity is 8.2%. A completely treatable, completely curable thing, which can be cured by a simple eye donation, but these people are still blind in our country. Right? Now, Indian death rate is again 7.38 per thousand. You can imagine 7.38 per thousand in a country of billion people. In a year, there are lakhs, almost 70 to 80 lakhs of deaths which are taking place in this country. If out of this, even a small fraction of people donate their corneas, we won't have any corneal blindness in this country, right? You see those beggars on the streets, you see those people in blind schools. All these people are suffering because nobody is giving them a cornea. With these many deaths in our country, we actually shouldn't have a problem of corneal blindness in our country, but we do have, right? This is the story of our country. 75% of the people, corneal blind people, lose out on vision restoration surgery every year. 75% out of 100 people, only 25 get corneas every year. Remaining 75 have to continue their life in darkness. Why? Just because, not because we don't have the facilities, we don't have the surgeons, we don't have the capacity. It's just because we do not donate our corneas. Right? So the question is, can it be done? Right? It has been a long, long time. The story has been, if you see the charts of the National Blindness Control Program, for years they have been trying to achieve a certain target, and India has not been able to achieve even half of that target. So question is, can it be done? I say it, yes, it can be done. Now you might ask, how do I know? How can I say it can be done? You see a lot of theoretical people who come and prophesize that this can be done, that can be done. But the best thing is to lead by example. You know, I heard a story from one of my seniors one day. He told me that एक बाबाजी थे कि a mother and his son tries to go up to Babaji, who sits on a big mountain, huge mountain. So when the mother reaches there after a huge horrendous travel through the slopes, she says, Babaji, इसको बोलो कि ये मोटापा कम करने के लिए चीनी खाना कम करे. The Babaji says, you go back and come back after a week, right? They go back down the mountain, they come back after a week. And then he says, Babaji says, अच्छा आप कल से चीनी खाना बंद कर दो. So the mother and son, they ask Babaji कि आप यही बात पहले भी बोल सकते थे, हमें इतना बड़ा जर्नी फिर से क्यों कराया? So that is because he said कि पहले मैं तो बंद करूं, इसलिए पिछले हफ्ते से मैंने बंद कर दिया. Now I am in a position to tell you that you also stop it, right? So that is the reason when I am telling you this, it can be done. It is because we have done it in PGI and we had published it in international journals with a glaring result that it can be done very easily with no additional in terms of infrastructure requirement, money requirement. It's just the attitude of all of us working in a hospital. Right, so the three things which we felt in our hospital, I was given this task when I started my senior residency. That was almost around 7 to 8 years ago. So we had almost 10 to 15 corneas per month. That is 2 or 3. In 3 days we used to get 1 cornea. We have an eye bank. We have the transplant coordinator, the cornea transplant coordinators. But for a very long time, this was going on its own pace, because it was not a very, it's sad to say, but it was not a very glamorous thing in an institute like PGI when you're doing high-tech surgeries and when you're treating, when you're doing transplants of heart and cancer, treating cancer. Cornea donation, which is a very old and a very simple technique, did not receive that much of an attention. But what we did, what the management of PGI decided was, if we have to start with a successful organ donation, we have to first start with cornea donation. Because cornea is the simplest organ that can be transplanted. Right? For all other organs, for most of the other organs, you have to be with a person who is actually very sick in the hospital. You have to be counseling the patient. This is one organ which can be taken after the death of the patient. Right? This is the easiest one which you can start with. This is the easiest one where you can develop the culture in your organization, where you start the process of organ donation. And that is what we did in PGI. Right? What we did, I'll talk about it in my papers. Second is the altruism. And third, the most important thing is putting words into action. Right? I'll talk about each of them. Beliefs is when we started the program, we did a survey amongst the nurses, amongst the patients, attendants. So facts and beliefs are something in psychological terms. Beliefs have no basis, but they are stronger than facts. Right? If a group of people believe in something, you can present them with a mountain of facts and they'll not agree with you. So the challenge is you have to circumvent these beliefs. You have to improve upon these beliefs. You go and tell them scientific facts, right? Even amongst us, how many of us believe what we do after death? What does happen to us after death, right? From one extreme where you believe in reincarnation to the other extreme where you believe everything ends in here. But there are a lot of beliefs which all these beliefs you cannot counter with your scientific facts, right? It is said that religion begins where science ends. This is where your transplant coordinators, your nurses, your residents who are with the patient and with the attendants 24/7, they come into picture. You have to change these beliefs. If you can change the beliefs, your work becomes much, much easier. This was a small video on altruism. We cannot play it. It's a TED talk. What is altruism? Altruism is doing something good without consideration of any benefit for yourself, right? If you're donating the cornea or any organ for that matter of your loved ones, you're not gonna get anything, right? You are spending your time, you are spending your energy, and the clear thing is that you are getting no benefit out of it. But you still need to do it for the simple fact that humans are altruistic beings, right? We are social beings, right? This altruism is what takes us to a higher level. If we have to start with this program in our organization, in an institution, in a country, this culture of altruism has to first be incorporated, right? There are two ways. Either you can force it legally or you can do it through altruism. Forcing it legally is not an option. It never succeeds in the long run. So this is the true way you can start your program in your institute. Next is your actions. You will hear a lot of people saying that we have pledged our organs, they'll come and say on televisions and radios and talk shows that we'll be donating our organs. But if you actually see how many of them actually go through the process, right? Especially consider the plight of a attendant of a patient who has been in hospital for 2-3 days, going through the ICUs, the emergencies, the OTs, and then after the death of this patient, they have to make this very, very difficult decisions. So actions is something which proves who someone is. Words just prove who they want to be. All of you sitting here want to be excellent mascots of organ donation in this society. But what it takes is actions. Words simply do not prove anything, right? If, like Professor Vipin said, day before yesterday, we had a brain death committee. We had an organ donation in PGI. I had to go for that brain death committee. I had to go in the night. The neurosurgeons had to come in the night. Just saying words that organ donation should be promoted, everybody should do this, that is not how a program gets launched. It is you who has to do it. Everyone in your capacity, in your little way, has to promote this. And you can do it, which I'll be proving it now. So this is some of the papers which I had. This was actually my thesis. We started with the nurses because nurses are the people who are the most with the patients, right? See, cornea donation can be done at home also. Eye banks do it. But one of the major sources where you can get cornea is the hospitals. It's called the HRCP, the Hospital Cornea Retrieval Program, which has been launched by the Government of India. Now, for the HRCP to be successful, a doctor going and counseling a patient after his death is not a very good method because it is not a good method because the nurses are the ones who are with the patient 24/7. Doctors come, they take their rounds, they advise, and they go back. But nurses are with the patient 24/7. Transplant coordinators, yes, but they are in limited number. For a hospital, for an institution of big size, they cannot reach every sick patient. Nurses are the ones who are with the patient. They can bring about a change in this. So we started with this. So what we did was we did a survey. We tried to find out what were the factors which influenced the nurses to put in that extra effort. This is not something which they have been told to do, which they have been hired to do, which they are paid to do. But some nurses did it, some did not. So what we tried to find out was what motivates them to do it. So we took a lot of factors into consideration, right? We took the nursing grade, we took the qualification, whether MSc, diploma, BSc, or the knowledge score or the experience. We tried to find out what is the thing which leads these nurses to motivate the patients to actually do it, so that we can inculcate those things in the other nurses. And we found that none of these matter. The designation, the education qualification, the experience, none of these mattered. What mattered was the willingness of the nurse herself to donate her own cornea. Right? Though when you yourself are convinced, then only you can go and convince someone else. Right? You say, main to karunga nahi, and I'll tell the entire world to do it. It never works that way. That hypocrisy is seen very easily by everyone. Right? Lead by example. You are the ones who first need to be convinced that cornea donation should be done. Then only you can go and convince someone. Right? The next, after finding out these factors, we went to the next. We set up a program in PGI, wherein it was basically a managerial idea, an administrative task, wherein we tried to increase the cornea donation rate in PGI. So what we did was we empowered these transplant coordinators. Now the fact is, transplant coordinators in the current scenario, they are not considered to be at the highest echelons of any hospital setup. For years that has been the ritual in hospitals, because for obvious reasons, treatment was always the first thing to be done, and transplant has come up now. So they were not given the respect, for the efforts they used to put in counseling the patients. And that is why they were a very, very demotivated lot in PGI. For years and years, we had the same corneal donation rate. What we did in this is we set up a system wherein we set up a committee of nurses and the transplant coordinators. And every day they used to sit and discuss, give feedback to each other, how they helped each other in ensuring that a corneal donation takes place. Right? We put in a transplant coordinator round the clock. Nurses were asked to convey to the transplant coordinators the death of any patient in the hospital at any given time of the day. Sometimes the nurses had an excuse that they were quite busy with it and with other patients, and they could not do it. So what we did was we did a small change in our software also in the hospital information system, wherein as soon as the nurse entered the death of any patient in the HIS, an automatic message, SMS, used to go to the transplant coordinators indicating the death of a patient in this area, so that they could go and counsel the patient's attendants at leisure. And most importantly, every day a feedback was taken from all these stakeholders who were responsible for cornea donation. And this is what we did. This is what we got, right? I'll again not concentrate on the statistics, because as I told you, statistics can be very deceptive. I'll tell you the frank numbers. We increased the cornea donation rate by 68%, right? In the pre-intervention period, we received almost 324, and the post-intervention period, we received almost 510 corneas per year. We almost doubled it by this simple intervention. So what I mean to say is, just by your small initiative, your own leadership positions in your specific areas, you can bring about a change. Every donation counts, right? Just imagine that you are the one who is bringing light into the life of some person who is blind, right? And so this has been published in the Public Health journal. So to conclude now, things to remember as nurses or as transplant coordinators. first thing is the Standards of Eye Banking in India, 2020. This is given by the DGHS, the Ministry of Health and Family Welfare. This book tells you everything, right? What are the requirements, how your eye bank should be, who should be the director of the eye bank, who can do the corneal removal and corneal transplantation. So lack of knowledge is not the problem, right? If you want to do it, you can start it today. And the government has made it very, very simple. In fact, in this 2020 modification, they have made a transplant, the person who can do the corneal enucleation can be a 12th pass out who is trained in corneal transplantation, right? So you don't have the deficiency of manpower. If you have the will to do it, you can do it. The only thing lacking is the will, the attitude to get it done. Next is the most important thing is forming the culture. Since we increased about 4 or 5 years a year, the rate in PGIMR increased by almost 68%, and since then it has been constant at that level, right? Because now it has become a habit. It has become a habit among the nurses, it has become a habit among the transplant coordinators, among the residents, that cornea donation has to be done, right? This is you can say a good thing or a bad thing about habits. You should be very careful about habits, good or bad habits. If you form those habits, they are difficult to form, but if you form those, you cannot get rid of them, right? If you try, a bit of it still remains. Try still further, bit still remains, and at the end of the day you try again and it is still there. So be very careful with forming habits in yourself and your institution. Develop good habits. Bad habits are equally hard to lose. So it's all about your culture which you develop, and as leaders in your particular areas, in your organizations and institutions, how you can bring about this cultural change in your organization. Thank you. So we can help in bringing light in the life of the people through our very small efforts. As nurses, as transplant coordinators, the only thing you have to look for in your institution is that corneal donation can be done within 6 hours after death. That is the golden hour. You have to ensure that that information reaches the team as early as possible so that the transplant coordinators have enough time to counsel the attendants of the patients. Other things, there are a lot of contraindications. There are quite a few contraindications, and but as what we did in our organization, when you give it up to the nurses, to the transplant coordinators to decide, so people can come up with excuses. There will always be people who will come up with excuses. So what we did in our organization was that every death, irrespective of whatever is the condition, has to be 100% notified to the transplant coordinators, right? And a feedback was taken regarding every death the next day, whether the corneal donation counseling was attempted or not. So these are the two simple things which you have to try in your organization. Make an attempt, that is all. Rest, all the facilities, infrastructure, capabilities are all available in all organizations. Thank you so much.
Thank you, sir. Thank you so much for enlightening the topic about the eye donation. Now I request Ms. Sujata Suryamurthy, she is the master tutor, and she will do the pre-training evaluation and will lead the program further. Ma'am, I request you to please come next.
So hope we all set for the next session. Before we move on to the next session, each one of you will be given a pre-training evaluation form. This would have about 30 questions with multiple choices, true or false, and match the following. That's the pattern of the question paper. So please take up the evaluation. It says 30 minutes, but it would be nice if you guys could finish it in 20 minutes because we're really running out of time. So please take up this form individually and read those instructions carefully. Okay, this is just to assess how much you know already about organ donation and also to compare with the post training evaluation, right? So please take up this. And this is individual evaluation, so please write whatever you know. Okay, Neha, you can pass it on to the each row so that. So it is 11:25. Let's finish it at 11:45. Okay, it's fairly an easy question paper. Neha, do you need any help? Please write your name and your institution name on the top of the question paper. And for the choose the best answer, which is multiple choices, section 1, please do not put tick mark. Please circle the answer. In case if you put a tick mark between A and B, we will not know what you have actually opted for. So please circle your answer, okay, for section 1. As I said, please write your name and your institution's name on top of the question paper. Please write your name. Do we have enough papers? As you finish, you can give your papers back to Neha, but we should close by 11:45. Okay? How is it going? Simple, difficult, most difficult? As said, this is individual assessment, not the group discussion. I could get to see some discussions happening. If one makes mistake, and everybody will be making the same mistake, so please make it as an individual assessments. Another 5 minutes, should we get done? Those who are finished, please give back your sheets to Neha. answers. Okay, like if you haven't given your answer sheets yet, please write your contact number as well. I think your registration forms have been given out somewhere, so please write your contact number as well in the paper. Nega, whoever has given, can you please give it back to them and ask them to write? Write three things. Your preferably the number which you are using for WhatsApp, because we are trying to make it as a WhatsApp group and the link will be shared in that WhatsApp group. So write your name, your institution name, and your number, contact number, whichever is being used for WhatsApp. If anybody is not particularly using WhatsApp, please come and let me know. We'll give an alternate for that, right?
So did any one of you notice the selfie point we have made? Do you like it? So you must find time to get yourself clicked there. Okay?
Okay, please start giving back your answer sheets. We are running out of time, so hardly 2-3 minutes. Please. answer sheets. Please. Neha, do you need any help? Udaini, where are you? Sorry, I could not see you. Okay, Simran has come. Okay, I guess pretty much all of you have given except a very few. Let's just get started. Meanwhile, those who haven't finished, please finish your sheets and give it to Neha. Before we get into the session, I just want to know how many of you are from Fortis. Can you please put your hands up? From Fortis, from the very same organization. Okay, I really could not see your hands. Could you please put them straight? Okay, around 10, I guess. I think there's also a big contingent from PGI MER. Can you please put your hands up? Oh my gosh, okay. A lot more from PGI MER, right. Any other institutions, hospitals you are from? Sorry? Delhi Artemis, okay, right. Yeah. Faridabad. Okay, so you all have registered through the site, I guess, right? Like pre-registration. Ah, right. Okay. Sorry, you are from? Shimla. Oh, okay. And you are from? Paris Hospital, Delhi. Okay, right. Okay. And yeah, we have Udaini from Imphal. Anybody else from other stations? Yeah. Sorry? Okay, Jalandhar. Okay, India Kidney Hospital. Okay, you are from? Same in Punjab, Mohali. Okay, right. So anybody from any other institutions? Okay, you are from? Max Mohali.
Hello.
Okay, so we have Max, we have Artemis, we have India Kidney Hospital, we have a nursing college. Sorry, I forgot your hospital. Asian Institute of Medical Science, and you said Paris, somebody from Mohan Foundation. The rest all from Fortis and Mohali. Fortis and PGI MER, I guess, right? Okay. I just want to know how many of you know about, apart from, you just know about organ donation and transplant, but really do not know much about the nuances of the topic, because it's a combined group of nurses, paramedics, even doctors. So I just want to understand how many of you is very new to this forte, like very new. I just heard about organ donation and transplant, nothing more that I know. How many of you are like that? No? Everybody know about organ donation and transplant. In that case, I have to skip my first session. That's why I'm asking. Okay, there are still a few who do not know much about organ donation and very basic concepts, right? Okay, fine. Oh, all the nurses are nursing students from PGI MER, right? Okay. BSc, okay, MSc nursing students, right? Okay, so apart from evaluation that we are doing, there will be one final evaluation which we said in the beginning itself on day 5. There is also an informal evaluation which is like, at least you need to remember the 10 participants' name of your fellow people, right? Not from the very next one who's sitting next to you. Okay, so because this is the place where you can network, so please take the time and effort to go out to people, talk to them, get to know about them. That is another, like day 5, we will ask you to give at least 10 names of your fellow participants. So keep that in your mind, okay? So please don't stick with the same group, because this is the learning platform. You need to make it to the fullest advantage, right? So, okay, let's just get started with our session. Can you please connect it? Yeah. Right, so I'm just going to talk about basic concepts of organ donation and transplant for the first 30 to 40 minutes. Let me keep it very simple, because many of you know already quite a lot of it. Okay, so organ donation is nothing but, 1 minute. Oh, it's not connected. So to play this video, you can just click this. Okay, I just want you to see this video before we get started with the session.
धन्यवाद नंदू
मन्नी
Yeah, so this is what all about we are going to talk in various aspects for the over the next 5 days, and we all going to be facilitators in some way or the other. Okay, so moving on with the okay, so organ donation, it's nothing but a process where an organ or multiple organs are removed from a person, and that person could be either a living person or a deceased. So very basic. It's just we are taking away a particular organ from a living person or multiple organs from a deceased person for the sake of transplant. So what is the transplant? It is again a surgical procedure where a damaged organ or a missing organ, instead of a missing organ, a healthy organ is put into a patient to save his or her life. It's a transplant, right? Okay. So moving on to the other aspect, like whatever we do, as I said in the morning itself, whether it is donation or transplant or getting license or like whatever the aspects, is it even legal? And do we have any legal provisions under our constitution? Yes, the government of India has passed a law called the Transplantation of Human Organs Act. And as I said, this is going to be the Bible for those who are going to work in this program. We need to have a complete knowledge and understanding of these legal provisions. Okay, so we will see in detail what the law talks about and its various provisions in the next session. And coming to why are we talking? There are so many other aspects of health, right? Like, but why are we talking again now about organ donation? Why we need to have a training, formal training? Why are we stressing the need and all those stuff? As you could see, all of you still remember tsunami, right? Like, like North India was never affected by this, right? But still, all of us remember this natural calamity because it just caused casualty of like 250,000 people in just one day, right? It was so huge that all of us, even after 20 years almost, we still remember, and we could continue to remember because of the effect of the disaster. It is the similar when we talk about organ failure. Why are we talking about organ donation now? Why are we stressing about transplant now? Because this is the burden of end-stage organ failure is simply similar to a tsunami, which is very silent, which has been often neglected, which is often unknown to even the professionals like us. That's a sad part, and that's a reason we are talking about organ donation and transplant, right? Coming to the need versus availability, in the inauguration itself, somebody was saying like there are lakhs and lakhs of people waiting for transplant. Yes. See, look at the numbers on your left side. People waiting for kidney transplant, about 2 lakh people. Liver, pretty much the same. Heart and lung, about 50,000 each. Remember, it's only the number of people who have managed to get into the wait list. We all know the health system of our country. Not everyone has the feasibility of going to a nephrologist straight, right? Look at our rural population. They won't have easy access to a nephrologist or a hepatologist or a cardiologist. So only people who reach out to the hospitals, who reach out to the specialists, and then ending up at this stage itself is these many numbers. Imagine the numbers which are going unrecorded. They are not even identified. So the need is so huge. Whereas you look at the other side of the transplants performed numbers, kidneys, hardly about 10,000 versus 2 lakh of requirement. Liver about 1,000. Heart and lung about 400 to 500 transplants. So even in kidney and liver, if you look at it, though the numbers are in thousands or multiples of thousands, remember the majority of them are coming from living donor transplants because we have 2 kidneys. Again, liver donation by a living donor is possible because of those factors, the kidney and liver numbers are looking little bigger, whereas heart and lung, apart from deceased donation, we have no other source, and look at the numbers, right? So this is the state of our country. I do not want to use the word demand and supply because it sounds like a commodity, where we are not talking about commodity, we are talking about organ and a life. So the need versus availability is so huge. I mean, there is so much of disparity between the need versus availability, and that is the reason we all here to learn, to understand, to go out, perform, educate the public on the ground, and put together a good system in the country. Coming back to subject again, who can be donors? Who can be a donor? I am alive today. Can I be a donor today? Yes. So there are two categories. One is living donation. The other one is deceased organ donation, right? So again, living donation can be divided into two. One is related, the other one is unrelated. Coming to deceased, donation after circulatory death, meaning for any reason a person's heart has stopped beating, basically there is no circulation, and any donation after that such kind of death is called circulatory donation after circulatory death. The other one is donation after brain death. So there are four sources how we can get our donors: living related donors, living unrelated donors, donation after circulatory death, donation after brainstem death. Okay, going back to one by one. Living donation, right? So my mother's brother's son, basically my first cousin, is he related to me? Can I donate my organ to him? Can someone answer? Is he related to me? Can I donate to him easily? Right. So let's see what the law says. Okay. So according to the law, the Transplantation of Human Organs Act, it's only within the family, which means our grandparents, parents, spouse, children, grandchildren, then sibling. Okay, so this is, see, because you talk grandparents, parents, sibling, children or grandchildren, apart from spouse, which is husband and wife, they all within the family, whereas the spouse is coming from another family, but we still close because of the relationship, right? So the law defines these are the related category. Okay, so my mother's brother's son, who's my first cousin, is not a near relative to me. Okay, according to the law, he is not a near relative to me, because there are two reasons. One, when I donate to my own family member, if I donate to my mother or my son donates his organ to me, obviously this is for my loved one, and obviously there will not be any expectations, any monetary exchanges between me and the donor, right? Because obviously my mother is not going to expect anything for her to donate her kidney to me. I'm not going to expect anything for me if I have to donate my kidney to my husband, because it's just within the family. That's one. Second, you can prove the relationship medically, scientifically, that I'm related to her as a sister. She is related to me as my mother. So whatever the relationship, except the spouse, which can be again established through the children or through evidence-based documents, but other relationships we can prove medically, scientifically. So these two reasons, for these reasons, the law has a provision, and the provisions are fairly simple. You establish the relationship, you provide all the documents, then you are good to go with the transplant. Whereas my first cousin, for example, right, or like somebody who studied with me in my undergraduate, it's been like 15 years. Obviously, she's not related to me. In case if she requires a kidney transplant, can the law prohibit me from being a donor? Exactly. So the law says you still can donate to someone. It could be distant relative, your colleague, your employer, employee, neighbor, friend, whoever it is. You still can donate to someone by the reason of affection and attachment, or any special reason towards the recipient. So basically, the law has given this provision with a good intention, right? Like, because just because somebody is not related to me, Just because someone is not within the family, you can't stop me from being a donor to that person. So the law has given that provision with a very good intention. But unfortunately, as in the inaugural talk someone mentioned, we still keep hearing about organ rackets, people being exploited, institutions being banned. This is because somebody is doing some mistake knowingly or unknowingly, but otherwise this what. So as transplant coordinator, again, I think the medical director of the hospital mentioned in the talk, like you need to be absolutely crystal clear about the legal provisions. Can I prove it? Do I have all the provisions? And all this depends upon all this work is given to the transplant coordinator, because we are the ones who work very closely with the patients and the relatives and often spend more time with them. So that's the reason it's very important for us to understand the subject and the requirements of the legal provisions, right? Coming to, okay, in that, like if I'm a living donor, what are the organs and tissues that can be donated? Obviously, I have only one heart. I can't donate my heart, but organs like blood, for example. How many of you are regular blood donors here? Yeah. So blood, again, we donate during our lifetime. Bone marrow, uterus, kidney, because we have 2 kidneys, one still can be donated. Portion of liver. We only have 1 liver, but still we can donate portion of the liver because it's a beautiful organ which can regenerate, regrow. So that is again possible. Portion of lung and pancreas, not happening in our country, but possible. Coming to donations after circulatory death. So we said, right, like for whatever the reason, a person's heart stops beating, basically there is no circulation, and the person is dead for all purposes means. So in that case, organ donation is possible? Yes, it is possible. Do we have legal okay? Yes, we have. But we do not do it much in India except one institution, which is PGIMER. Organ donation after circulatory death is not happening because it needs a lot of systems, lot of regulations. So to my knowledge, no other institutions have been doing this donation after circulatory death, whereas we all do tissue donation after circulatory death, because it's fairly simple nowadays. People are more aware about tissue donations like cornea, skin and bone, right? So as we said, after this training, not sure how many of us are going to be exactly working in disease donation program, especially brain death or into the transplant thing. But all of us, right, like some way or the other, will keep hearing about death in our wherever we go, like in the institution that we work, or like in our own family, or like neighborhood. So at least this is the first step that we can take informally, because when there is a death in the family, obviously they would not be able to take, they would not have the time, mind frame of thinking about donation and transplants. So as professionals, we should come forward and talk about this to them. Unless somebody tell them there is an option like this, would you like to consider? We can't expect them to take a decision, right? So tissue donation is something where all of us can start practicing, because grief counseling is not an easy job. As we go along, we will hear about it. So this would help you how to talk to a grieving family. This will help you how to talk to someone when there is a death in the family. So this would be your primary step. And coming to brainstem death, again, the whole day tomorrow is dedicated for brainstem death. So I'm not going to go in detail. I just want to introduce the definition alone. This is what the law says. The law says, what is brainstem death? A stage at which all functions of brainstem have permanently and irreversibly ceased. Meaning the damage is permanent and that cannot be reversed. So when that stage happens, it is called brainstem death. Please, please remember that brain dead patient is no more a patient, he is dead. Okay? All means and purposes that is medically proven, and our law has accepted that form of death as death. Because we still see this in the community, like our own professionals telling the family, he's more critical, or like there is no, he is 99% dead. Brain death is death. The person is 100%. There can't be 99% dead and 1% alive, because if there is 1%, if it is my relative, I would give all chances. I would like to try, because for me, that 1% is equivalent to 100%. So we should not have any miscommunication when we talk about, when we introduce this subject to the family members. When we say brain dead, it's not like patient is still critical. No, the patient is dead. Medically, legally, that's what we need to understand. We need to put it in that language to make them understand the patient is dead. He is hooked up to this ventilator, which gives them the oxygen and other medications to keep the organs going. Otherwise, the patient is dead. He is no more. Would you like to So this is how we need to be very clear when we talk about organ donation. If we say he is still critical, then why are you talking about organ donation? He is not dead yet again. If you say 99%, again there is 1%, I would go to another planet, bring in someone, take him to some other experts to save him. So all that bargaining will happen within the family members. So we need to be absolutely clear in what we talk about. Unless we have the clarity, unless we have this conviction, we would not be able to speak to the family. So that is one, brainstem death, knowing about brainstem death, right? So we have a whole day dedicated, so I'm not going into much into this. Yeah, so what are the most commonest causes of brainstem death? Sorry. Moving back. Trauma, tumors, ischemia, and okay. I'm so sorry, I do not know the local language, either Hindi. In case if you would like to have the translation in the local language or Hindi, please do let us know. We'll try and give our best to make it complete learning.
जहाँ भी आपको लगे कि कहीं क्लैरिटी नहीं हो रही है, सो यू कैन जस्ट रेज योर हैंड, सो वील क्लैरिफाई. अगर हिंदी में बताना है, थोड़ी बहुत पंजाबी भी आती है हमें, तो आप पूछ सकते हैं, डोंट हेजिटेट. ठीक है, आइडिया इज़ जो भी कॉन्सेप्ट्स हम लोग डिस्कस कर रहे हैं, इट शुड गो थ्रू, इट शुड सिंक इन थ्रू. अगर आप उस चीज़ को समझ नहीं पाए तो फिर हमारा सारा पर्पज़ ही डिफीट हो जाएगा. So whenever you are not understanding, you can simply raise your hand. We have enough time. We have one-to-one interaction. तो जहाँ आपको नहीं समझ में आ रहा, आप हाथ उठा लें, हम लोग डिस्कस कर सकते हैं. So because Sujata is from Chennai, so she won't be able to speak in Hindi, लेकिन मैं हिंदी में समझा लूँगा. ठीक है? So but don't hesitate.
Yeah, please let us know. Otherwise, there's no point in doing this session if you don't understand at the end of the day. Okay? Right. Common causes of brainstem death: tumor, trauma, any unnatural incidents, for example, road traffic accidents or falling from height, or like somebody hitting, all those are unnatural, right? Trauma. And then intracerebral hemorrhage. You all know, intra means within, cerebral means brain, hemorrhage. There is bleeding within the brain, whatsoever the reason, which finally ends up in brainstem death. Ischemia. Can anyone tell me what ischemia is? Yes. Sorry? One person, please.
Just keep on rotating the mic. जिसको आंसर मालूम हो वो हाथ उठा लो.
Cessation of brain blood supply.
Cessation of.
So is that the definition of ischemia? I'm not talking about brain ischemia. Ischemia शब्द का अर्थ क्या होता है?
Yeah, like lack of blood supply and due to.
So lack of oxygenated blood supply to any organ is called as ischemia. Perfect.
Exactly. So similarly, if there is no oxygenated blood going to brain, the brain will damage, right? And that could be because of any reason. So ischemic brain injury is one of the reasons why a person could land up in this situation, right? So these are the commonest causes. However, the most common causes road traffic accidents, right? So if you look at India statistics, If there are 100 people donating, around 75 to 80 people are because of road accidents, and most of them are in their productive age, like between 20 to 50, right? So this is where the transplant coordinators face a major challenge, because accidents are unexpected and they are very young. Families are like in a very, devastated situation. So there we as counselor need to step in and provide all those counseling service.
So, आप लोगों में से किसी ने देखा है brain dead patient? Just raise your hand. And एक बार mic pass on करो. Somebody should tell me in what situation you have seen a brain dead patient, और किस वजह से brain dead हुआ था और कैसे पता चला brain death है?
Sir, accident के कारण, and then he was on ventilator and oxygen ventilator, and then there are a lot of inotropic agents going on that, and GCS is M1, E1 and VT. Yeah, something like that.
So GCS कौन बताएगा मुझे? Somebody who can tell me the complete GCS. कोई बता सकता है? GCS के बारे में किसी ने ICU में काम किया हो?
Yes.
Neurosurgery ICU, neurology ICU. What is GCS?
Glasgow Coma Scale.
Okay, so Glasgow Coma Scale, इसका क्या use होता है? What is it used for? एक आदमी, please raise your hand and mic will come to you automatically. नहीं, महेंद्र को नहीं, इसको तो सब पता है. So Glasgow Coma Scales का क्या use होता है?
So to assess the consciousness level of the patient.
Very good. So जब भी हम किसी व्यक्ति की ब्रेन की स्थिति को जानने की कोशिश करते हैं, we know whether how is the brain functioning of that patient, we use a scale which is called as Glasgow Coma Scale. और इसमें जो सबसे कम स्कोर होता है वो होता है EVM111. इसका मतलब है कि कोई पूरी GCS स्केल बता सकता है? Can anybody tell the entire GCS scale? Yes, the lady in blue.
Sir, it has 3 components: best eye response, best verbal response, and best motor response. So in best eye response, we have 4-1. That is, if the eye opening response is spontaneous, to voice, to pain, or no eye opening response. Then is verbal response. In that we can see if the patient is oriented, confused, or incomprehensible words or incomprehensible sounds are there, or there is no response. Matlab 5-1 is there in verbal. And in motor response, it's from 6-1. That is the patient is obeying command, or localizes pain, or withdraws from pain, or there is decalibration, decortication.
Excellent, excellent. What is your name?
Sir, Aarti.
And Aarti, you are from?
Sir, PGI.
Excellent, wonderful. So all of you, if you are trying to enter into the field of transplants, everybody should remember it by heart. GCS सभी को देखना आना चाहिए. आपको डॉक्टर पे डिपेंडेंट नहीं होना है GCS देखने के लिए. You should be able to know what is the GCS of the patient and tell the doctor when he comes on the round कि सर इसका GCS ये है, कल शाम को इसका GCS ये था, लेकिन आज सुबह इसका GCS ये है. So this is what is expected out of you. Okay? So carry on, Sujat.
Yeah, so thank you, Aarti, again for putting it very clearly. I know that others also would know. Again, the manual which was given to you, that has all those definitions, what is GCS, how it is being measured, and all those things. It's in the manual that can help you as a reference point as well, right? Yes. So as said, like the brainstem death patient, I mean, they will be definitely in the intensive care units, because like, see, especially people working in public sector hospital, you will all of a sudden get a call, ma'am, there is a patient in this ward. Okay, which ward? It will be like one of the common wards, and people will not be on ventilator, but they will say like the patient is not responding, probably is brain death. But that's not the condition, right? Like, because if the patient is not on ventilator, meaning the patient is breathing on his own, that means his brainstem is alive. So those people we should be never talking about. So we used to get all those false information, that kind of thing. So we as professionals need to know where are these brain dead donors found, usually be in. So these patients are in ICU, only in the intensive care units. They will definitely be on ventilator. As I said, like the whole day tomorrow, if I go in detail, then tomorrow will be a repetition. That's the reason I'm not just going into too much of the subject. There are a lot of videos and talks on brainstem death which will address you with adequate information, right? So the patients will be in the ICU, they will be on ventilators, and obviously they will be on a lot of external medications as well. Again, in the natural or like circulatory death, how death is certified? By how many doctors? In the natural case, how many certify a death? Just one doctor, right? When there is a death, whether it is at home or on the road or in a clinic or in the hospital, just one doctor comes, checks the parameters and then certifies the death. Whereas in brainstem death, it's not the same. The law says the brainstem death certification has to be done by a panel of 4 doctors. It's not just one person or 2 person. There are 4 people. We will talk about who those 4 are in the future sessions, next session. And again, these certifications are done twice. The tests are done twice. For example, I got admitted to the ICU after an RTA like 2 days back. 2 days I am in the ICU. I have been operated. Craniotomy was done, whatever the reason, but nothing could save my life. After 2 days, doctors suspect me as brain dead. So they perform all these tests as prescribed in the law, which will be again talked tomorrow. So the first certification is done. They'll say like, okay, Sujata is brain dead, 10 o'clock in the morning. That's not enough. The law says wait for 6 more hours for adults. People above 18 years of old, please wait for 6 more hours. Come back again, do those tests again and again do this, right? Only the second certification, second brainstem death certification becomes the death time of the patient, okay? So it doesn't mean, again, here we need to understand one important thing. I'm dead 10 o'clock in the morning, right? And again, they have to repeat all the tests 4 o'clock, minimum 6 hours. So anytime after 4 o'clock, they have to repeat the test and certify, right? So from the family point of thing I'm saying, it's not like Sujata is dead 10 o'clock in the morning and 6 hours not know what is happening, again 4 o'clock. No, once I'm dead for all purposes and means, right? So when we talk to the family, this 6 hours of wait is not to give any false hope, right? They should not think, oh, there is still hope. I need to still wait for the second test. Once the patient is dead, he is dead. Just the legal requirement that we need to wait for another 6 more hours to complete the formality. Because sometimes when we go and tell the family, the first brainstem death certification is done, your patient seems to be brain dead. However, we have to repeat it after 6 hours. Sometimes this will give the families a positive hope. Oh, I still have 6 more hours. No, that shouldn't be there. We have to tell them this is for the legal purpose and that's what the law says. Because in between, if the family has accepted the death, understood the concept of brain death, we can go and talk about organ donation. But in case, if the family doesn't understand, then they are having the hope still, right, till you do the second test. So we shouldn't be confusing the family. Once the patient is dead, dead. We have to wait for 6 more hours to complete the legal formalities. In between, if the families are in term to talk to you, then talk about organ donation or you wait till. Legally, we have to wait till the second test and then talk about organ donation. But in case of the family, because now a lot of awareness is there, sometimes people, when we go and tell them, they themselves will come and talk to, oh, is he brain dead? Then should we think about something else? So in that case, we will be obviously talking about organ donation. So be very clear on this. This is not to give time for any positive hope, okay? Right. So what organs and tissues can be donated after someone is brain dead? It's pretty much you can recycle yourself. From your head to toe, every part of the body can be donated. However, in India, we do mostly the kidneys, corneas, liver, heart, lungs, pancreas. Nowadays, we have done hands as well, right? Right. So here, you guys said about ischemia, right? Lack of oxygenated blood. Once we remove the organ, obviously how the organs are until then, the patient is brain dead, but we have put him on ventilator. We do a lot of things to do the oxygen and circulation keep going, right? Right. So, but once the retrieval is done, once the organs are removed from the body, there is no blood and oxygen supply, right? So, can we keep those organs somewhere, wait till our duty to get over, or like duty to start? Can we do the transplant later? Can we do it that way? We have done all the procedures, removed it, just put it in the freezer box and do it tomorrow or like whenever you get the recipient. Can we do that? No. So again, as you all know, each organ has got a specific ischemic time within which it has to be transplanted. For tissues, we have to do the basic things and we have to put them in the bank. Okay. First, like heart lung, it is 4 to 6 hours. And Dr. Vipin Kaushal was talking about transporting most of the organs, heart and lung nowadays from Chandigarh to Chennai. Remember the flying time itself 3 hours, right? And then going from PGI to the airport to the other airport 3 hours. In between we have to do a lot of check-in formalities. And then from that airport to the recipient hospital. So put together your ischemic time of 4 hours is already lost, right? Like you have so that's the reason as transplant coordinators, I think that the heart transplant sir was saying, the surgeons do the surgery, the physicians tell how the patient is, or like whether the patients require or fit for transplant, but this entire drill, make sure this organ is correctly transported on time it is the fullest responsibility of the transplant coordinator. So every minute, every second becomes our responsibility. We can't afford to make even a simplest mistake, right? So that's where we say, like Dr. Naveen was saying, right? Like you need to have a system and protocol. Of course, see, right, especially when we talk about heart-lung transportation, everybody in your hospital is primarily sharing equal responsibility, starting from the ambulance driver. He needs to know the importance of what job he is doing. The gatekeeper to keep the door open, the lift operator, everybody should be equally sensitized. Only then these kind of transplants could happen in a very smoothing way. And for that, transplant coordinators need to have a lot of in-house sensitization, need to have a lot of things in our place, right? Okay, the subject experts will talk about it a lot. Again, heart 4 to 6 hours, liver 8 to 12 hours, pancreas again about 8 to 12 hours, small bowel about 12 hours, and kidneys about 24 hours. See, for example, kidneys, it looks like it has a longer ischemic time. But however, we know the more the ischemic time, the quality will decrease. It will come down. Already we are giving second chance to someone. So why should we take that risk? So as transplant coordinators, as transplant professionals, we always look up for immediate transplant. So unless otherwise there are situations we shouldn't be delaying this ischemic time, right? Okay, coming to types of transplant. For example, I have a bad burn injury in my hand and doctors feel probably my skin from my thigh or back should be sufficient. So I become donor to myself. What transplant is it called? Sorry? Auto transplant. Yes, it is self. I am donating to myself, right? So in that case, do we need immunosuppressants? No, because it is my own tissue, my own organ, whatever it is. So we are not even talking about immunosuppressants. Again, now I have a twin sister who's like a photocopy of me, just like me. Okay, so if I donate her kidney to, if she donates her kidney to me or I donate to her, what is it called? Exactly, isograft or such transplant is called isotransplant. Again, immunosuppressions is not much important because she's just like me, right? So immunogenically, it could be well accepted because we both are same genetically. Coming to like in the usual brainstem death donation, somebody is brain dead, kidney is donated to someone. What is it called? Allograft or allotransplant. Basically, one person donate to another person, and they both belong to same species. Obviously, they both are human beings, right? That is called allotransplant. In case we get organ from some other species, what is it called? Xenotransplant. Exactly. Anybody heard about the xenotransplant recently done? Can you tell me? Sorry? A heart was transplanted from a pig, genetically mutated pig. A lot of genetic engineering was done, and then the heart pig was donated and transplanted to a human being. Unfortunately, I mean, it was success in the sense he lived for, I think, pretty much about a month and a half, and then he died. So this is the future. So xenotransplant, okay, between two different species. Any other mythological story for xenotransplant? Ganesha, Lord Ganesha, obviously, right? He got elephant head and the human body, xenotransplant, right? Moving on to split transplants, this is often in the liver, like, you know, like in living donation, like a portion is left to me and the remaining portion is given to someone, right? Whereas when we have a deceased donor, there is one liver in that donor, right? And if the surgeons and the physicians feel this liver can be split into two and can be given to two people, so from one donation, basically two recipients are getting benefited, and usually it will be shared between the adult and the child, so that, you know, the proportion is adequate for the recipients. Split transplant. Swap. What is swap? Anybody can explain to me what is swap donation or transplant? For some reason, Dr. Ranjan said no to you. I don't know what the reason, but I would like to know the reason why you are exempted from answering. Are you working in the transplant field? Sorry? He's not in the transplant program. No, for some reason, Dr. Ranjan said not to get your answer. I don't know why. I mean, like, I just want to know, like, are you a transplant physician or doctor or coordinator? Okay, fine, right. Right. So what is swap transplant? Can someone tell me?
For example, there is a relative of mine and I want to donate my kidney to that person. But we don't cross match actually. And there is another person who wants to donate kidney to their relative. But my kidney matches to their relative. So I can donate my organ to them.
I mean, the concept is right, the swap transplant, but usually it will be between the incompatible blood donors. For example, like me and my husband, I mean, blood groups. Me and my husband, I am A and he is B. There is another pair where the mother is A and the daughter is B. There are now the incompatible transplants are done, but still it's much more superior to the, compatible transplants are much more superior, right? So for that reason, if we are willing, we can exchange the donor. So I become donor to the daughter and the mother becomes the donor to my husband. Basically, this is what happens in the swap transplant, okay? Because of incompatibility within the family, where I am physically healthy and I would like to be a donor, but just that we are incompatible, I can be a donor to someone and someone else in that family can become a donor to my husband. So that's the swap transplant, right? We are basically swapping, right? Next one is domino transplant. What is domino transplant? What is domino game? Can someone explain? Domino? Domino transplant. Okay. So basically, domino transplant is, for example, you have a deceased donor, okay, and the heart and lungs are being donated. Whereas you have one recipient who needs the lung transplant, whereas his heart is marginally okay. He doesn't need any heart transplant, but he needs lung transplant. But as somebody said in the morning, like sometimes it's much more easier or required to do a en-bloc transplant. You transplant the heart and lung together as a block, right? So you do that way. So from the deceased donor, we take the heart and lung, we give it to the patient number 1 who requires a lung transplant. But we said his heart is fairly okay, right? So we can't throw that heart. So that heart is given to somebody who requires a heart transplant. So the recipient himself becomes the donor. It's like the domino game where you keep the card, you touch one card, it keeps falling, right? Similarly, one patient becomes the donor to the other patient. So that's called domino transplant. This is often done in heart, lung, sometimes in the liver as well, where like we take organ from the deceased donor, put it, and this patient becomes a donor to somebody else. That's called domino transplant, okay? Orthotopic transplant, again, for example, in liver transplants, my damaged liver is removed and the new liver is kept in the same anatomical position, right? It's just kept in the same position. So it's called orthotopic. They remove the organ and put the organ back in the same position, place and position. Whereas in case of heterotopic, for example, often in the kidney transplant, because unless otherwise it is harm to remove my native kidney, the doctors will leave the kidney within me, right? Like unless it is going to harm my health, they won't take away the organ. So the two kidneys are left to me, with me. So where do they put the new kidney? They'll put sometime in right iliac fossa. They'll start from somewhere else, right? So basically it is transplanting in an anatomically different location where it was supposed to be. So this is called heterotopic transplant, and one of the examples is kidney transplant. So that's a ortho is in the same position, hetero is different position. Why are we talking about all this? Because see, when the transplant patient comes, when they come for counseling, whether patient or the recipient or the family members, they will have a numerous number of doubts. And they would like, where will you put it? Like, how do you do this? What will be the surgical thing? So obviously the doctors will explain, but also they will come to you because they often see you as the first point of contact, right? So you also need to know all this information so that you will be on the same page with the doctors in terms of explaining to them. You couldn't be saying something else apart from what the doctors have said. And composite tissue, we have been, as I said, like we have been doing hand successfully. We have also done uterine transplant in the world. Very few countries have been doing uterus transplants. India must be proud because we have done successful uterus transplants. Babies have born after uterus transplants. This has happened in Maharashtra, one of the hospitals in Pune. Again, milestone for India. Last section, myths and facts about organ donation. Doctors' work. See, why are we talking about it? Again, Dr. Naveen said, right, like when the public come to us, they want us to address all the queries. The other day, I went to a medical college for a talk, and most of you were like students like you, and one student asked, like, what if I pledge my organs today, I take a donor card, just in case if something happens to me, if they find the card in my bag, doctors may not try their best to save me. They will let me to become brain dead for the sake of organs. And this came from a paramedical student. This was a doubt. And imagine how the public will think about the same. We may think it's silly or we may think it's relevant, but it's not, because public has a lot of apprehensions about organ donation and transplant, and it's our responsibility. For that, we need to know the fact. So it's not like, you know, like always, it's not like in medicine, 1 + 1 is equal to 2. Like we can't let someone to become brain dead. It's a physiological damage which happens on its own. So it's not like, okay, I leave this patient for 2 hours and he'll become brain dead. Nothing. Or I'll do this to this patient, he will become brain dead. No, it happens, and then only we talk about organ donation. And organ donation will disfigure the body. Again, we have a retrieval class tomorrow. It's especially when we talk about internal organs, it's a neat surgical procedure. It's like as in any major surgery, how we treat a patient. Similarly, the diseased body is treated, the organs are removed with respect, and then body is sutured and given back. Obviously, when it comes to external, like composite tissues like hands, we are going to take away the hands, but they will put prosthetics and all this stuff. So that has to be informed to the families. My family will be charged if I donate my organs. See, for example, as I said, I get admitted to the ICU for whatsoever the reason. Immediately, you are not taking me as organ donor, right? Your first intention is to save me. So you do whatever. I mean, like the family agrees, and whatever measures are taken for first 24 hours or 48 hours, whatever it is all for doctors and family to save myself. So for that, the family obviously has to pay. But the moment I become brain dead, the family says yes for organ donation. Whatever happens in the ICU, not for the sake of me, because I'm dead. And family has said yes for organ donation. So the remaining hours of ICU maintenance, the OT cost, the transportation is not for the family. It is for somebody. So that has to be taken care by others, right? And religion, again, this is one of the major hurdles that we still keep facing in our society, that my religion, my faith does not agree for organ donation. For example, Hinduism, if we look for scriptures, there would not be anything written directly about organ donation and transplant, whereas Lord Ganesha is an embodiment which talks indirectly. Every religion talks about saving the fellow human being, right? So that has to be there, and we need to take, for example, we need to take all those measures. In case if you live in a locality where there is a prominent faith following people, you need to have that knowledge, what this faith talks about. In case if there is a donor, to be honest, in my experience, once when we were not able to get the consent purely because of the religious faith, we had taken the help of the priest, and he understood, and he came to the hospital and he explained, and then family. Otherwise they were okay, but they just wanted to have this one consultation. Is it really allowed in their religion? So we had to go those extra miles. And I'm too old, or like I have blood pressure, I'm diabetic, I'm not fit, all this irrelevance, because at the time of death, it is up to the physicians and the surgeons to decide whether this organ is suitable for transplant. Do we have a suitable recipient? So all those criteria are going to decide about the donation factor. Rich and famous will jump the queue. Again, public point of view, we need to ensure that there is a system in place, and this system is transparent. People should have the access to the system. We keep talking like we have done 1,000 transplants, 100 donations, but how these organs are donated, how it is distributed, first we need to understand the system. We can't just say donate. Because like, especially I do not know, if you work in the public hospital, people will be like very demanding to know how these organs are donated. How do you ensure that you are not giving to a private hospital, rather selling the organ? So we need to make them understand, no, it's not in deceased donation. There is a system in every state that has to be strictly followed. I can't randomly call out a recipient and give the organ. So we need to have that understanding as well, okay? And coming to the last section, consent point of view, right? What system is India following? Any idea? In India, if you want to be an organ donor, what system are we following? What system are we following? Worldwide, there are 2 consent processes. Can anyone tell me what are those? Yes. Exactly, opt-in and opt-out. Can you, if possible, can you please explain what is opt-in and what is opt-out?
Ma'am, opt-in, you have wished to organ donor after death. In opt-out, you wish not wish to organ donor.
Exactly, exactly. So India, we follow something called opt-in. There is nobody donor here. So if I want to be an organ donor, I register myself, I go into the registry. That's what he said. I wish to be an organ donor. So India is something following something called opt-in, right? So I go into the registry by pledging my organ. Dr. Kaushal was saying, right, like how many of you have pledged organ donors? So this is what, I'm opting in to be an organ donor. The other concept system is opt-out. For example, most of the European countries follow something called opt-out. In those countries, every citizen is considered automatically an organ donor. If you are a citizen of that country, you are by law an organ donor. Unless otherwise, as he said, I don't want to be an organ donor. You are putting yourself out of the registry. So that is why it's called opt-out. You are coming. Thank you. Sir, your name?
Naresh.
Naresh. Thank you, Mr. Naresh. So you are opting out. You are keeping yourself out of the system. So this is what most of the European countries follow, something called opt-out system. Okay. So India follows opt-in, and there is another consent called opt-out.
So ये concept समझ में आया, opt-in, opt-out, ये बहुत important concept है और इसको समझना बहुत ज़रूरी है. सो इस कॉन्सेप्ट के पीछे का इथॉस क्या है? इथॉस ये है कि जैसे स्पेन है, स्पेन इज़ अ वेरी वेरी प्रोग्रेसिव नेशन. ऑप्ट इन ऑप्ट आउट का मतलब है स्पेन में जितने भी उसके सिटीजन्स हैं तो गवर्नमेंट पेज फॉर देयर हेल्थ इंश्योरेंस, उनका सबका ट्रीटमेंट फ्री होता है अस्पताल में. कोई भी जितने भी गवर्नमेंट उनको फैसिलिटीज़ देती है उसके बदले में, जैसे उनका अगर ड्राइविंग लाइसेंस बनना है, उनका पासपोर्ट बनना है, तो उनका गवर्नमेंट के कागज़ तभी बन सकते हैं जिसमें कि वो मैंडेटरीली ऑर्गन डोनर्स हैं. मतलब किसी की डेथ होती है अगर एक्सीडेंट में या किसी ऐसे कॉज से जो कि अनएक्सपेक्टेड है, तो वो इंसान ऑर्गन डोनर, दैट ऑर्गन बिकम्स अ नेशनल प्रॉपर्टी. हमारे यहाँ अगर किसी की डेथ होती है तो उसकी बॉडी उसकी फैमिली को दे दी जाती है, उसकी फैमिली की प्रॉपर्टी हो जाती है, उसके परिवार जैसा चाहता है वो करता है. लेकिन अगर डेवलप्ड देशों की बात करें या स्पेशली यूरोपियन नेशंस की बात करें तो वहाँ अगर किसी की डेथ होती है तो वो ऑटोमेटिकली दैट इज़ कंसिडर्ड एज अ नेशनल रिसोर्स. तो अगर किसी परिवार को या किसी इंडिविजुअल को अपने ऑर्गन्स नहीं डोनेट करने उसके लिए, तो उसको अपना नाम उससे हटवाना पड़ता है रजिस्ट्री से, और उसके सारे बेनिफिट्स गवर्नमेंट से जो मिलते हैं वो ख़त्म हो जाते हैं. So everybody is an organ donor unless proved otherwise, unless he has opted out. And in India जो हमारे देश में सिस्टम है कि अगर किसी की डेथ होती है तो वो बॉडी फैमिली के पास जाती है और फैमिली मेम्बर से हमें बताना पड़ता है, उन्हें सेंसिटाइज करना पड़ता है कि अब तो ये आपका मरीज़ रहा नहीं है और इसके ऑर्गन्स जो हैं अभी यूज़ किए जा सकते हैं. सो इंडिया इज़ एन ऑप्ट इन सिस्टम जिसमें कि हमको एज ट्रांसप्लांट कोऑर्डिनेटर्स, एज ट्रांसप्लांट टीम मेंबर्स, वी हैव टू अप्रोच द फैमिली. उनकी ग्रीफ काउंसलिंग करनी पड़ती है, उनको सेंसिटाइज करना पड़ता है कि आपका मरीज़ तो चला गया लेकिन उसके ऑर्गन्स अभी ज़िंदा हैं और इतने लोग हैं जिनको कि ऑर्गन्स की ज़रूरत है, तो प्लीज़ गिव अस योर ऑर्गन्स, वी हैव टू रिक्वेस्ट देम. सो दिस इज़ एन ऑप्टिंग इन सिस्टम. Whereas countries like Spain, Catalonia, Germans, they have an opt-out system. So this concept is very, very important to understand. Thank you. It is not the government decides, it is the medical professionals decide. So हर organ का जब transplant होता है तो कोई भी donor आता है, उसकी एक लंबी सी checklist होती है जिसमें देखा जाता है कि क्या क्या बीमारियां हैं. अगर किसी donor को HIV है तो वो automatically उसके organs नहीं लिए जाएंगे. So HIV to HIV organ transplant is possible. So अब होने लगे हैं HIV जो पॉजिटिव इंडिविजुअल्स होते हैं उनके भी ऑर्गन ट्रांसप्लांट होने लगे हैं. सिमिलरली कई ऐसी बीमारियां हैं जो कि पहले लाइलाज थी, जैसे कि हेपेटाइटिस सी. तो हेपेटाइटिस सी डोनर हेपेटाइटिस सी रिसिपिएंट को दे सकता है ऑर्गन्स. हेपेटाइटिस सी इज़ नाउ कंसिडर्ड एज अ क्योरेबल डिजीज़. सो अगर कोई रिसिपिएंट ऐसा है जिसमें कि डिकॉम्पनसेशन नहीं हुआ है तो वो पॉजिटिव डोनर का ऑर्गन उसको दिया जा सकता है. सो दीज आर स्पेशल अलॉटीज़, ये अलग से इनकी लिस्ट बनती है हर जगह.
I mean, I guess it was about indications, contraindications are like that for transplant. So like each organ class, you could get it clarified with the faculty, like because it keeps changing. Some conditions are strictly contraindications, whereas some are like relative contraindications. So that can be checked with the expert faculty whenever they come, right? So coming to the consent process again, one last thing. As we said, India follows opt-in system, right? Like, yes, we take donor card. So for example, I have my donor card. If something happens to me, will I become an automatic donor? Still no. Because the law also says, it says, the final consent has to come from the legal position, which is like my near relative. So it's not just that we take the donor card. It is very important that we go back and tell the family about our wishes, because that's what the legal requirement in our country is, right? So if in case, because obviously I can't wake up and tell like, hey, I am a registered organ donor, take my organ. No, my family has to represent. For that, unless otherwise I have told them, they would not even think about it, especially in the mid of, when they are in the grief, it is very difficult to process. So when we go and talk to the people about, when you are involved in public education, it's not just how many people have taken the donor card. You have to make sure that whoever is taking the donor card, please go back. Tell your wish to your family, your friends, your workplace, wherever it is, so that they would be able to act upon your wish. Otherwise, there is no point in taking the donor card. That is again very important, right? So with that, let's just close this session. And what is? Yes, please, if you have any queries, let's just clarify it. Deceased unknown, basically unclaimed bodies, right? Okay, can I cover it in the legal class? There is a provision. Is it okay? Right. Any other questions? With the basic concepts?
If there are no questions from you, we will start asking questions. So it's better that you come up with your questions. So your lecture was very clear, it seems.
I don't know whether it was clear to them.
There's one slide in which he said that domino transplant. So you're saying that we take organs from one recipient A and we're transferring to recipient B. So I just want to say that you said that we have to take lung and heart from the one donor and then give it to the recipient A, and then we have to take a heart of the recipient A. So why we are like, if the recipient A have a very healthy heart, so why there is a point of doing this transplant?
See, there are that's purely with the heart-lung program. For example, as I said, surgical wise, it's much more easier when you do it as an en bloc, okay? End of the day, you are going to transplant to two recipients. One patient is going to get the lungs, the other patient is going to get the heart. And if you talk about the immunosuppressants wise, whether I'm taking one organ, two organ, it's all the same amount, okay? So that's all medical part. But the surgical point of view, it's much more easier when it is planted as a en bloc, meaning together. As I said, because heart and lung, it's just easy for the surgeons to transplant. So you just transplant both the organs, okay, and you remove the native heart of the patient. Because it is marginally doing okay or fairly doing okay, that goes to the second patient. For example, this often happens in the liver transplant patients as well, because for example, in metabolic liver diseases where the liver is not working, it's not because the liver is damaged, it's purely because of the metabolic reason the liver is not working in me. So the deceased donor's liver is given to me, whereas my liver given to another patient, it will work perfectly fine because that person does not have that metabolic disease. So that person can still do well with my liver. So I become donor to someone. So this is the medical explanation.
So there are many genetic diseases such as hyperoxaluria. So many a times we do simultaneous liver kidney transplant. किडनी जैसे जिन लोगों को डायबिटीज़ है बचपन से, उनका डायबिटीज़ की वजह से किडनी ख़राब हो गई तो उनको सिमल्टेनियस किडनी पैंक्रियास ट्रांसप्लांट किया जाता है. उसी तरह से कुछ ऐसी बीमारियां होती हैं जिसमें कि कुछ मेटाबॉलिक फैक्टर्स ऐसे होते हैं ब्लड में जिससे लिवर ख़राब हुआ. जैसे किसी को स्टोन बनता है किडनी में. फॉर एग्जांपल, लेट मी मेक इट मोर सिंपल फॉर यू. इफ़ समबडी इज़ फॉर्मिंग अ किडनी स्टोन, तो उस व्यक्ति के ब्लड में कुछ ऐसे मेटाबॉलिक, देयर आर सम फैक्टर्स विच आर प्रेजेंट इन द ब्लड, देयर आर सम फैक्टर्स विच आर एक्सटर्नल इन द एनवायरनमेंट. वो आदमी कम पानी पीता हो, गर्मी में रहता हो, पसीना ज़्यादा आता हो. सो देयर आर सर्टेन एनवायरमेंटल फैक्टर्स, सर्टेन जेनेटिक फैक्टर्स. कई बार ऐसे डोनर्स होते हैं जिनकी किडनी हम लोग निकालते हैं, उनकी किडनी में स्टोन होता है, स्टोन निकाल के रिसिपिएंट को लगा देते हैं, उनको कभी स्टोन बनता ही नहीं, जबकि डोनर को स्टोन बनता रहता है. So there are so many metabolic possibilities which are present in one individual which can cause harm to that organ in that particular individual. So when that organ is explanted and transplanted into somebody else, that organ works perfectly all right. So that's the concept of a domino. So domino is a very, very nascent program in India. It is not a very well developed program. So नॉर्मली ये बहुत, जैसे यूएस के कई सेंटर्स में जहाँ पर कि बहुत ज़्यादा मेटाबॉलिक स्टडीज़ होती हैं, लैब्स बहुत एडवांस्ड हैं, जेनेटिक डिजीज़ हैं, मेटाबॉलिक डिसीज़ हैं, उसमें होता है. इंडिया में इट इज़ नॉट सो पॉपुलर एज येट. ओके, मोर इम्पॉर्टेंट इज़ अल्ट्रूस्टिक डोनेशन, इस तरह की चीज़ें हैं, वो अभी सुजाता विल टेल यू. ऑल राइट, स्टिल कन्फ्यूज्ड? बताओ.
में ट्रांसफ़र कर रहे हैं, नो इट्स फाइन। सो हमें मतलब हम
नहीं, जो बेसिकली रिजेक्शन की चीज़ है ना, रिजेक्शन इज़ अ टोटल फिनोमिना इन द बॉडी। इट इज़ नॉट जस्ट द ऑर्गन। जो भी हम दवाएं रिजेक्शन के लिए देंगे उसकी डोज वही रहेगी, चाहे एक ऑर्गन का ट्रांसप्लांट हो चाहे और 4 ऑर्गन का हो। ऐसा नहीं कि डोज बढ़ जाएगी। कई बार टेक्निकली, जैसे हार्ट लंग ट्रांसप्लांट में क्या होता है, इट इज़ टेक्निकली वेरी चैलेंजिंग टू रिसीव ओनली द लंग ट्रांसप्लांट और द हार्ट ट्रांसप्लांट सेपरेटली, बिकॉज उनकी आर्टरीज वेन्स इतनी ज़्यादा कनेक्टेड होती हैं। तो कई दफ़े हार्ट लंग ट्रांसप्लांट एक साथ ही कर दिया जाता है कई इंडिविजुअल्स में। सपोज़ किसी का हार्ट जो है थोड़ा सा कम फंक्शनिंग है, उसका लंग में भी इंटरस्टिशियल लंग डिजीज़ है, तो पूरा ऑर्गन उसको मिल जाता है और उसका हार्ट किसी और को यूज़ हो जाता है। दिस इज़ द कॉन्सेप्ट ऑफ डोमिनो। इट्स अ वेरी लिमिटेड कॉन्सेप्ट, इट्स नॉट अ वेरी रोबस्ट कॉन्सेप्ट स्टिल इन आवर कंट्री। इट डिपेंड्स अपॉन द सर्जिकल चैलेंजेस, क्योंकि सर्जिकली लंग को भी ब्लड सप्लाई बंद करना और हार्ट को भी, इनकी जो इस्कीमिया टाइम होता है वो बड़ा कम होता है, बहुत तेज़ी से काम करना पड़ता है, लॉजिस्टिक्स हम नहीं अरेंज कर पाते। लंग अहमदाबाद में जाना है, हार्ट चेन्नई में जाना है, सो ट्रांसपोर्टेशन, दे आर सो मेनी थिंग्स विच आर लॉजिस्टिकली नॉट पॉसिबल। कि कहीं से मान लो पीजीआई चंडीगढ़ में कोई डेथ हुई, वहाँ से ऑर्गन शिफ्ट होना है, हार्ट अलग जाएगा, लंग अलग जाएगा, दोनों की वाइबिलिटी अफेक्ट हो जाएगी। सो दे आर सम सिचुएशंस इन विच we are forced to do such kind of transplants. This is not a routine thing and it is still not very upmark in India as yet.
Are we clear or any more questions? Yeah.
There is a black smiling face.
Yes sir.
Behind you. हाँ please.
सर एक नोटो, रोटो एंड सोटो में कोई लोकल कोई ट्रांसप्लांट लिस्ट होता है, वेटिंग लिस्ट, जिसमें पता कर सकते हैं कौन से स्टेट का कितना वेटिंग लिस्ट है? जैसे पीजीआई में बहुत सारा वेटिंग है, गुजरात में जाएंगे तो कम आएगा, तो ऐसा कोई ट्रांसप्लांट वेटिंग लिस्ट?
जो हमारे देश में अब देर इज़ अ नेशनल प्रोग्राम ऑर्गन, जैसे नेशनल मलेरिया इरेडिकेशन प्रोग्राम, नेशनल लेप्रेसी इरेडिकेशन प्रोग्राम, वैसे ही अब नया प्रोग्राम हमारे देश में स्टार्ट हुआ है जिसको कहते हैं NOTP. So this is called as National Organ Transplant Program. So National Organ Transplant Program के अंतर्गत जितनी भी देश में हमारी ट्रांसप्लांट एक्टिविटीज़ हैं उनको एक गवर्नमेंट की बॉडी बनाई गई जिसको कहा गया नोटो. So this is called as National Organ and Tissue Transplant Organization, which is located in Delhi. At present the head office is at Safdarjung Hospital. उसके बाद देश को 4 हिस्सों में डिवाइड किया गया, ईस्ट वेस्ट नॉर्थ साउथ. तो ये 4 रीजन्स हो गए जिसको कहा गया रोटो, रीजनल ऑर्गन टिश्यू ट्रांसप्लांट ऑर्गेनाइजेशंस. उसके बाद हर रीजन में एक स्टेट में अलग अलग स्टेट ऑर्गेनाइजेशन बनी. सो बाय वर्च्यू ऑफ मैंडेट एवरी सेंटर हैज़ टू डिस्प्ले अ वेटिंग लिस्ट. जब भी ऑर्गन एलोकेशन होती है देयर इज़ ऑर्गन एलोकेशन पॉलिसी. पॉलिसी का मतलब होता है देयर इज़ अ पॉइंट सिस्टम. जैसे अगर हम अमेरिकन पॉइंट सिस्टम को देखें, विच इज़ द मोस्ट डेवलप्ड पॉइंट सिस्टम फॉर एलोकेशन ऑफ ऑर्गन्स, दैट इज़ कॉल्ड एज यूनॉस, यूनाइटेड नेशंस ऑर्गन शेयरिंग. सो व्हाट डज दैट मीन? इट मीन्स कोई भी ऑर्गन, सपोज एक किडनी मिली, सो किडनी इज़ अ नेशनल ऑर्गन, वेयर विल इट गो? सो देयर इज़ अ पॉइंट वाइज सिस्टम, देयर इज़ अ स्केलिंग सिस्टम. पेशेंट की एज कितनी है, कितने समय से डायलिसिस पे है, टॉलरेट कर रहा है कि नहीं कर रहा है डायलिसिस प्रॉपर्ली, कितने डिस्टेंस पे वो किडनी ट्रैवल करनी है. सो दे आर मल्टीपल फैक्टर्स जिसके बेसिस पे पॉइंट किया जाता है और ऑर्गन को एलोकेट किया जाता है. दैट्स अ वेरी वेरी ट्रांसपेरेंट सिस्टम. अंडर द ह्यूमन ऑर्गन ट्रांसप्लांट एक्ट एवरी हॉस्पिटल इज सपोज टू डिस्प्ले अ लिस्ट ऑफ रिसिपिएंट्स वेटिंग फॉर एन ऑर्गन. तो जो ट्रांसप्लांट के रजिस्टर्ड हॉस्पिटल्स हैं वो अपनी अपनी लिस्ट, उनके पास जो डिसीज लिस्ट होती है, जिस मरीज़ के पास कोई डोनर नहीं होता, वो अपनी लिस्ट डिस्प्ले करते हैं. So this should be present on the website. Yes, your question please.
सर जैसे आपने बोला कि कुछ मेटाबॉलिक डिजीजेस होते हैं, जैसे आपने एक एग्जांपल दिया कि स्टोन्स किसी को हो रहे हैं तो मतलब किडनी ट्रांसप्लांट किसी और को कर देते हैं, बट एटियोलॉजिकल फैक्टर द कॉज इज स्टिल देयर ना
In the donor.
इन द डोनर.
हाँ, डोनर्स ब्लड.
तो सर अगर किडनी उसमें दे दिया तो कॉज फिर से हो सकते हैं ना स्टोन्स?
नहीं बेटा, जो हम रिसिपिएंट की बात कर रहे हैं जिसकी किडनी स्टोन से ख़राब हुई है, उसमें दोबारा से ज़रूर हो सकते हैं स्टोन, क्योंकि उसमें मेटाबॉलिक फैक्टर्स हैं. लेकिन सबसे इम्पॉर्टेंट चीज़ है ये जानना कि सर्वाइवल, पहले तो उस आदमी को ज़िंदा रहना चाहिए ना. जब हम लोग MBBS में पढ़ते थे तो हमारे सर यही बता देते कि लिविंग पेशेंट इज़ बेटर, लिविंग प्रॉब्लम इज़ बेटर देन अ डेड सॉल्यूशन. सो पहले तो हमें उस आदमी को ज़िंदा रखना है किसी तरह. अगर हम उसको किडनी ट्रांसप्लांट नहीं करेंगे तो वो वैसे ही मर जाएगा. जब स्टोन बनेगा उस किडनी में, 10 साल में बने, 5 साल में बने, तो उसको निकालने के लिए तरीके बहुत हैं. जैसे नॉर्मल आदमी का किडनी का स्टोन निकालते हैं वैसे ही उसका निकाल देंगे, बट एटलीस्ट ही इज़ लिविंग. सो अ डेड लिविंग प्रॉब्लम इज़ बेटर देन अ डेड सॉल्यूशन.
देन सेम कॉन्सेप्ट इज वर्क फॉर कि इतना अगर किसी में एकदम ही लीवर डैमेज है तो वो कम परसेंटेज में अगर उसका लीवर डैमेज तो वो आप उसमें कर दे रहे हैं.
बेटा आई एम नॉट एन एक्सपर्ट ऑन लिवर बिकॉज मैं तो किडनी का देखता हूँ, बट लिवर में बहुत सी मेटाबॉलिक डिजीजेज होती हैं. ग्लाइकोजन स्टोरेज डिजीज़ होती है, जेनेटिक डिजीजेज होती हैं, हाइपर ऑक्सिलूरिया है जिसमें लिवर और किडनी दोनों में ऑक्सिलेट का डिपोजिशन हो जाता है. सो देयर आर नंबर ऑफ मेटाबॉलिक डिजीजेज विच लीड टू सच काइंड ऑफ सिचुएशंस.
थैंक यू.
Yes, please. Please introduce yourself. Please tell your name and from where you are.
Sure, sir. Very good afternoon to all. My name is Sakshi and I'm from PGIMR, student of MSc first year, 9 Chandigarh. So, sir, my question is, in our waiting list, how does the waiting list criteria is set? Is it first come, first serve, or we look at the age and comorbidities and other things also?
So, as I told, there's a point system which is decided by the ROTO. रीजनल ऑर्गन टिश्यू ट्रांसप्लांट और मे बी एवरी हॉस्पिटल उसकी एक्सेसिबिलिटी कैसी है. तो देर इज़ अ पॉइंट सिस्टम ऑन विच द पॉइंट इज़ अलॉटेड टू अ पर्टिकुलर पेशेंट. सपोज दे आर 100 पेशेंट्स इन द लिस्ट हु आर वेटिंग. उसमें से 2 पॉइंट होते हैं कि कौन 6 महीने से रजिस्टर्ड है, कौन 3 साल से रजिस्टर्ड है, कौन 10 साल से रजिस्टर्ड है. 2 पॉइंट होते हैं कि उसने कभी अपनी किडनी डोनेट की है किसी को, इज़ ही एन ऑर्गन डोनर. इसी तरह से कौन सी बीमारी की वजह से किडनी ख़राब हुई है, उसकी बाकी कोमॉर्बिडिटीज़ कैसी हैं. सो आइडिया इज़ ये पॉइंट सिस्टम डेवलप किया जाता है जो कि हर इंस्टीट्यूशनल प्रोटोकॉल के अंतर्गत हर इंस्टीट्यूशन में होता है. एंड इट्स अ क्राइटेरिया विच इज़ डेवलप्ड बाय द सर्जन्स एंड अदर डॉक्टर्स ऑफ दोज पर्टिकुलर हॉस्पिटल. सो एवरी हॉस्पिटल हैज़ अ क्राइटेरिया जिसके बेसिस पे एलोकेशन होती है ऑर्गन की, एंड इट हैज़ टू बी वेरी वेरी ट्रांसपेरेंट. सो दिस एलोकेशन इज़ नॉट डन बाय द सर्जन्स, दिस इज़ डन बाय नॉन ट्रांसप्लांट टीम मेंबर्स. This is managed by either transplant coordinators or hospital administrators, and it is a very very transparent system. It has to be transparent.
Okay. And so my second question is, what if I am an organ donor, a registered one, but my family is not aware of it, and I am in the hospital brain dead, and now the physicians and the team members are ready to transplant my or take out my organs, but my family is not in support of that decision, right? So in that case, do we get the legal bodies involved in this, or what? How
so
do
there's
we?
a concept of donor advocacy which is yet not prevalent in India.
Yeah.
But coming back to the situation in which you are talking, suppose you have signed, you wish to donate. It's a very personalized decision whether I want to donate my organs or not.
Yes.
So if you wish to donate your organs and you are a legitimate 18 years and above major citizen of the country,
Right.
first thing is that you must go back and tell your family members that I have registered, and if there is any unfortunate event, this should be done. Suppose your family members, they do not wish to donate, then there is by no way that we can take the organs. So next of kin, जब भी कोई body आती है तो next of kin जो उसका position में होता है body को, until and unless they are sensitized and they are ready to donate, nobody can force them. It's such a grief-struck situation for the family. The family's emotional metabolism is entirely altered. So you can't force somebody. You can just sensitize. One of the grief counselors or one of the transplant coordinators approaches the family. He or she sensitizes that your child has wished this. What is your stake? So if they refuse, full stop. It finishes thereof.
Okay. Thank you so much, sir.
माइक दे दीजिए इनको.
सर मैं दिल्ली से आर्टेमिस हॉस्पिटल से हूँ. मेरे छोटे 2 क्वेश्चंस हैं. मैं फर्स्ट टाइम आया हूँ तो मेरा पहले ये पूछना था कि जो भी अगर हार्ट फेलियर पेशेंट हमारे हॉस्पिटल में आता है तो उसका रजिस्ट्रेशन नोटो में करना कंपलसरी है, अदरवाइज़ नहीं. पहला क्वेश्चन ये है. सेकंड क्वेश्चन ये है कि हमने हार्ट ट्रांसप्लांट होते हुए भी देखा है, पेशेंट एडमिट हुआ और एकदम से कॉल आ गई कि हमारे हॉस्पिटल में कि भाई आप हार्ट लेके आ सकते हैं यहाँ पे, तो हमने उनका ट्रांसप्लांट भी कर दिया 1 महीने के अंदर अंदर. तो ये किस तरह का मतलब है कि अगर हम सीरियस वाइज चलेंगे नोटो से या वैसे भी डायरेक्टली भी हम ले सकते हैं?
नोटो जो है, नोटो इज जस्ट अ मॉनिटरिंग बॉडी. ही इज सेइंग दैट वेदर ऑल द रिसिपिएंट्स आर टू बी रजिस्टर्ड विद नोटो, द वेटिंग रिसिपिएंट्स. सो एवरी हॉस्पिटल मेंटेन्स इट्स ओन वेटिंग लिस्ट. जब किसी भी हॉस्पिटल का रजिस्ट्रेशन होता है ट्रांसप्लांट के लिए, तो उसमें उनको बताया जाता है कि आपको ये फॉलो करना है. आपको अपनी लिस्ट अपडेट करनी है जो कि आपकी डिसीज्ड वेटिंग लिस्ट है. सपोज लिविंग ट्रांसप्लांट बिल्कुल अलग है. ये जितनी भी बातें हम कर रहे हैं ये सिर्फ डिसीज ट्रांसप्लांट के लिए हैं, जो आफ्टर डेथ ऑर्गन्स मिलते हैं. सो सपोज एवरी हॉस्पिटल हैज़ इट्स ओन लिस्ट. अगर होता क्या है कि नॉर्मली हॉस्पिटल्स के पास डिसीज प्रोग्राम नॉर्थ इंडिया में तो बिल्कुल ही नहीं डेवलप्ड है. इट्स वेरी वेरी इन्फेंटाइल स्टेज. सो हॉस्पिटल्स यूजुअली हैव 1 or 2 पेशेंट्स इन द वेटिंग लिस्ट. 2-4 मरीज से ज़्यादा किसी हॉस्पिटल के पास नहीं होते. बट बिकॉज ऑफ द इंटरवेंशन ऑफ रोटो और नोटो का रोल ये है कि सपोज मेरा अस्पताल है, मेरे यहाँ पे एक कैडेवर हुआ, मैंने किडनी का ऑपरेशन तो कर दिया, मेरे पास किडनी वाले मरीज थे, हार्ट उसका बचा हुआ है, अब मैं हार्ट कहाँ भेजूँ? तो मेरी जिम्मेदारी है कि मैं अपने रोटो को इन्फॉर्म करूँ कि सर मेरे पास ये ऑर्गन अवेलेबल है, हमारे पास कोई रिसिपिएंट नहीं है, आप नियर बाई हॉस्पिटल्स में, नियर बाई हॉस्पिटल्स का मतलब है जहाँ कनेक्टिविटी अच्छी है, कि हमें 8 घंटे के अंदर अंदर हार्ट यहाँ से दिल्ली पहुँचाना है आर्टेमिस अस्पताल में, तो वो लॉजिस्टिकली फीजिबल है. अगर हमें भागलपुर पहुँचाना हुआ तो हम नहीं पहुँचा सकते, या हमें जो है पौंडीचेरी पहुँचाना हुआ तो शायद नहीं पहुँचा पाएंगे. तो लॉजिस्टिक्स भी बहुत इंपॉर्टेंट है कि किस जगह वो ऑर्गन मिनिमम पॉसिबल टाइम में पहुँच सकता है, उस इंस्टीट्यूशन को प्रायोरिटी मिलेगी. ये निर्णय जो होता है ये रोटो या नोटो लेता है कि किस जगह वो ऑर्गन जाएगा. ये उनकी वो है कि आपकी परिधि में कौन सा सेंटर है जो कि सबसे करीब है. हो सकता है मैक्स मोहाली में हो कोई रिसिपिएंट, तो वहाँ पे ऑर्गन शिफ्ट हो सकता है. बट दैट इज मीडिएटेड थ्रू द गवर्नमेंट. यू डू नॉट नीड टू रजिस्टर योर रिसिपिएंट्स ऑन द नोटो वेबसाइट. दे आर रजिस्टर्ड ऑन योर ओन हॉस्पिटल्स वेबसाइट.
ओके, थैंक यू.
वेलकम.
Add to your point, because you're from Delhi, again, see, NOTO is the national organization, but to far Delhi, that is the SOTO, correct? That is where the differentiation has to be understood. Because when there is organ available within Delhi, then the allocation is done by the NOTO in the place of SOTO. It's not just doing the work of NOTO. So for that purpose, they may ask you to, for example, if there is a organ donor in Paris hospital, or like whichever hospital in Delhi, then if the hospital is not using the heart within their own recipients, then who allocates? Who will allocate for Delhi? It will be by NOTO, because NOTO does the job of SOTO in your state, in your place. That is the difference. That's the reason they may ask you, okay, because if that is not utilized for your own patient, then it has to go out. For example, if it is Tamil Nadu, then our state will allocate, right? Like I don't necessarily need to go to NOTO. Whereas for you, the basic allocation is done by them only. So that's the difference between the other states and Delhi.
हॉस्पिटल को नोटो से रजिस्टर नहीं होना है. हॉस्पिटल को अकॉर्डिंग टू द ह्यूमन ऑर्गन ट्रांसप्लांट एक्ट विल बी कवरिंग. सो एवरी हॉस्पिटल नीड्स टू रजिस्टर इटसेल्फ टू इट्स स्टेट्स अप्रोप्रिएट अथॉरिटी. जैसे अगर हम पंजाब में हैं तो हमारी अथॉरिटीज़ DRME पंजाब, और मे बी हेल्थ सेक्रेटरी, प्रिंसिपल सेक्रेटरी का ऑफिस इन पंजाब. सो ही रेगुलेट्स द लाइसेंसिंग ऑफ ऑल दोज हॉस्पिटल्स. टू बी known as a transplanting hospital, I should have the license for doing a transplant from my state authority. There is no role of NOTO in that. NOTO is only for allocation of deceased transplant.
Are there any questions?
So you must ask them some questions.
I think all of them are hungry, so I don't know. Should we break for lunch or should we do a lighter session? We are much beyond the time schedule. Otherwise, Divan sir, can we do the public awareness session? Or like, should I start with my law session in case if lunch is not ready? The post-noon will be law sessions and public awareness. In case if lunch is not ready, should we do the public awareness now and break for lunch and then we'll do the law? Meaning?
So we have 15-20 minutes before we break for lunch. So let's do a one-to-one questionnaire. अब किसी के कोई डाउट्स हो तो बताओ, फिर मैं पूछना शुरू करता हूँ आप लोगों से. So I'll pick up somebody right X, Y, Z. Yes, please come.
I have lost my card.
हाँ.
And my family, they are also willing that let her donate her organs. So is that necessary to that the card should be located? No, no.
ये कहा जाता है कि ऑर्गन डोनर कार्ड जो होता है आप अपनी जेब में रखिए हमेशा. नॉर्मली क्या होता है, जितनी बार भी मैक्सिमम केसेस आर रोड ट्रैफिक एक्सीडेंट. 90% ऑफ डोनर्स, ब्रेन डेड डोनर्स आर रोड ट्रैफिक एक्सीडेंट. सो इट इज़ सेड दैट यू शुड कीप योर डोनर कार्ड इन योर पॉकेट. And now we are introducing, once you get your driving license, so driving license mentions, yes, I am an organ donor. So there is a special section when you are filling up your form for license in which you tick. So once your driving license comes, it will have a heart made on it. So that means you are an organ donor. So that means you are a registered organ donor. So card is just a formality. More important is the family's wish. If the family is willing, nobody can stop it.
This is what the road ministry has recently introduced. I'll just show it. Can you please show the project? See now, like I don't know whether anybody had recently applied for your driving license or renewal of driving license. Now when you go, there will be a question in your, there will be a clause in the driving license application, whether it's a new application or the renewal. I am willing to donate my organs in case of accidental death. So you have to say, it's up to you. You want to say yes or no, it's up to you. But this clause is mandatory to be filled. Without filling it up, your application will not even be accepted by them. So this is a mandatory clause and you can say yes or no. If you say yes, as Dr. Ranjan said, you will get this heart symbol, okay? Again, it doesn't mean that once you have a driving license, you will become an organ donor. No, your family still be asked, because I decide today, go for my licensing process, and after a few years, if I change my mind, it takes a lot more energy to go and change in my driving license. Rather, I would tell my family, no, I don't want to be an organ donor. So they become voice of my representative, my wish. So all said and done, as we said, the next of the kin will be the one who will be signing the consent form in the event of brain death, right?
So let me put up a question. So, Human Organ Transplant Act of India कब पास हुआ था? All of you know that. 19? एक्ट की ज़रूरत क्यों पड़ी? काम कर रहे हैं डॉक्टर, अपना काम कर रहे हैं, एक्ट की ज़रूरत क्यों पड़ी? What is traffic? एक आदमी, please raise your hand and explain it. What is the need for a act in the country? हमें ऐसी ट्रांसप्लांट कर लें, एक्ट की क्या ज़रूरत है? राशि के पास माइक ले जाओ.
Sir, otherwise people would do commercial business with organs.
कैसे बिजनेस कैसे करेंगे?
Like kidneys बेचेंगे, खून बेचेंगे, और there are like children kidnap हो जाते हैं, और beggars वगैरह सब लोगों का trafficking, organ trafficking.
कोई देश जानते हो जहाँ पे ऐसा काम भी होता है? So I'm asking them, what is the need of the act in the country? Why do we have an act? Okay, so you're partly correct. So there's a lot of even after the act, there are many times when we are in difficult situation. जो आजकल की नई जनरेशन है, ये एडोब फोटोशॉप के देखिए वाइफ है, अपने हस्बैंड को डोनेट करना चाहती है, दे हैड सम commercial angle in between. She was not the true wife. All the legal workup done, and they got their case cleared from the authorization committee of Amritsar Medical College, which is one of the most difficult authorization committees because it's a state authorization committee. But then somehow one of our coordinators picked it up. Sir, this is a photoshopped photo. So then we had to go back, check those documents, and actually it was a photoshopped photo. So people do a lot of hanky-panky even despite the act. So the purpose of act is to protect the donor. डोनर की सेफ्टी, लोग क्या होता था कि किसी के घर में कोई सर्वेंट है, 20 साल से काम कर रहा है, उसकी फैमिली को पाला हुआ है, होता ही है, बहुत से लोगों के घरों में कोई सर्वेंट हेल्पर है, काम कर रहा है 20 साल से, उसको कह दिया कि भाई तू कर दे, तेरा तो घर मैंने बनाया. सो देयर इज़ अ कोहर्शन, देयर इज़ अ फोर्स, देयर इज़ सेल्फिशनेस. अगर वो नौकर खुद ही कहता है कि नहीं मैं साहब को अपनी किडनी देना चाहता हूँ या अपना लिवर देना चाहता हूँ, देन दैट्स अ डिफरेंट थिंग. बट मोस्ट ऑफ द टाइम्स ऐसा होता नहीं है. सो एक्ट का पर्पज़ है कि डोनर का नुकसान ना हो, डोनर के साथ जोर ज़बरदस्ती ना की गई हो, स्पेशली लिविंग डोनर के साथ. उसमें एक्ट के प्रावधान में कमिटीज़ बनी हैं जिसमें कि गवर्नमेंट के अधिकारी होते हैं, डॉक्टर्स होते हैं, और भी बहुत से पुलिस के पर्सनल होते हैं. सो एक्ट का पर्पस सिर्फ और सिर्फ ये है कि हम डोनर को बचा लें. नहीं तो क्या होता था, लोग किसी की फैमिली को किडनैप कर लिया, किसी के बीवी बच्चे को किडनैप कर लिया, उसको कहा कि तुम जाओ कहो कि एफिडेविट बना के दो, मैं अपनी किडनी देना चाहता हूँ. सो दीज थिंग्स वर वेरी कॉमन. सो दैट इज़ वाई देयर वॉज अ नीड ऑफ द एक्ट, एंड एक्ट हैज़ लेड डाउन प्रोसीजर्स एज वेल एज पेनल्टीज़ कि अगर गलती हुई तो किसकी क्या सज़ा है. तो वो सज़ा जो है ट्रांसप्लांट कोऑर्डिनेटर्स को भी हो सकती है. इसलिए बहुत इंपॉर्टेंट है इस एक्ट को जानना हम सभी लोगों के लिए, एज सर्जन्स, एज फिजिशियंस, एज ट्रांसप्लांट कोऑर्डिनेटर्स, एज हेल्थ केयर प्रोफेशनल्स, एज एडमिनिस्ट्रेटर्स. एवरीबडी इज इन्वॉल्व्ड इन दिस प्रोग्राम. सो एक्ट इज़ वेरी वेरी इंपॉर्टेंट टू बी नोन बाई हार्ट. कौन से फॉर्म्स होते हैं, कौन से किस रिश्ते में कौन से फॉर्म भरे जाते हैं, डिसीज डोनेशन में क्या क्या फॉर्म भरे जाते हैं, मेडिको लीगल केस है, नॉन मेडिको लीगल केस है. So this is very important to understand the act. So you should put a lot of time in understanding the act, and the relevant sections of the act should be remembered by heart if you want to go in the field of transplant. Okay, so any other question? What's an altruistic donation? Any idea? What do we mean? Have you heard of this term, altruistic donation? Altruism, what does that mean? On a mic.
To do good for others without expecting anything for ourselves.
So she's asking, when the wife is donating an organ to her husband, is it an altruistic donation? Is it altruism? वो बिल्कुल अपना बिना किसी उसके दे रही है अपना ऑर्गन, या उसका कुछ मोह है अपने पति से इसलिए दे रही है?
मोह है उसका तो.
Selfish है. So you
Still
mean
it is.
she's selfish?
No, she cannot be called selfish at least, but not altruistic as well.
Why not selfish? अगर husband की death होगी तो सबसे ज़्यादा नुकसान किसका होगा?
पर सर उसको भी तो रिस्क हो रहा है. Donor is also at a risk ना.
बताओ सोच के. It's not such a simple question to answer. So does anybody know any celebrity who has undergone a transplant? Who? Selena Gomez. Who gave her which organ? Her best friend. Good. So in US, best friends or friends are considered as living related donors. So friends can easily donate. American families में होता ही नहीं कोई. मियाँ बीवी होते हैं वो भी अलग हो जाते हैं कुछ साल में. So they are very nuclear families, very small families. So her best friend came for donation. That is a type of altruistic donation. Okay? Yeah.
So, like in India, you all heard V-Guard stabilizers? Stabilizers, one of the manufacturers is V-Guard. Have you heard of the company? Yes. The owner of the company, his name is Chittilapalli, Mr. Chittilapalli. Obviously, he's super rich, right? He has donated his kidney to someone who's very poor, no way connected to him, who's, I think it was some laborer kind of work. So those kind of donations, because obviously he was not at all related to him, and he's going to gain nothing out of this donation. So these are called altruistic, basically without any expectation. Altruism to the core, okay? So in India also, we have such donations. One of the priests in Kerala, he has donated his kidney to one of his, a person who comes to the church regularly. So these are the altruistic donations, right? Okay, I just want to ask you two more concepts. There is something called conditional donation. The other one is called directed donation. Anyone know about conditional donation or directed donation? There is something called conditional donation. Any guess? Conditional donation. Right? Okay, this is often seen most of the countries, especially in European countries. Like, see, for example, like there is a strict condition put by the family. For example, they'll say like, I want to donate my loved one's organs, but no organ should go to a particular religion. It has to go only to a particular religion, right? So they put a condition. So whether it is accepted or not accepted, again, in India, there is no such thing. Like, you know, like when you donate with altruism, especially in deceased donation, I'm saying. The donor families do not have any say. It has to go only to this person. It should not go to this person. No such conditions can be donated. So that is called conditional donation. There is another term called directed donation. Similar way, they'll say, for example, nowadays this keeps coming. When there is a deceased donor, the families would say, okay, take away all the organs, but we need one organ. I mean, if time permits, is it okay? I'll just go for 2 minutes. Okay. So there was a young patient in one of the public hospitals in down south, 5 years old, okay, the child. And she was hit by a milk van, admitted in the hospital, brain dead. Family was approached, and obviously only one child, and family was such a grieving, in such a devastated situation. Finally, they agreed for organ donation. The process was made, okay, contacting the state authorities, police, and all this stuff. As we were doing the procedure, somebody came from the family, not the parents, somebody from the family. The uncle came to the coordinator and said, just want to discuss about something. And it's like, okay, what is it about? And he said, the girl who died, her father is a chronic kidney failure patient. He's a CKD patient, but obviously not registered with that particular hospital or something. And the family he was on dialysis, and the family knows if someone like her becomes brain dead, and if such family donates only. So all these details the family knows, but they never put anything they never made it as a condition. You know, like they say, like, we just want to know if permissible, can her kidneys be donated to her father? Only if permissible. If not, even if you say no, we are still going to go ahead with donating the child's organs. So looking at the genuinity of the family, because like they know about it, right? Like, because family itself is suffering, but they never made it as a condition. So then it was brought to the state committee, and they said like such a genuine appeal from the family, and that has to be honored. So the child's because she was only 5 years and the kidneys were obviously very small, otherwise would have given 2 kidneys to 2 different recipients, right? But this case, both her kidneys were given to her own father, so where the child gave birth to the father, and that was a directed donation. Because like, you know, like now, like that was accepted. So there is no clause in the law. If you look at the law, there is no such clause. So as of now, it is dealt case by case. If there is genuinism, it's not like sometimes family will be like, make it as a demand. What if the organ doesn't match with you? There's no point. then they won't agree to you. No, only if you give me, I will give. But I can't give you because it doesn't even match with you. So those explanations will, so those conditions we won't agree to that. So law does not talk about conditional donation or directed donation. There is no provision. As of now, it is dealt only on case by case, because never knows, because when there is no provision in the law, you have to really sit and break your head how to take this forward. You have to go to your hospital, you have to go to your SOTO, you have to go to your ROTO, then go to NOTO, because you can't just simply give away the organ. So a lot of formalities are there involved. So we just need to understand this, right?
You must be surprised to know there are families which, जैसे कई बार बच्चे होते हैं पेट में, नियोनेटल या प्रीनेटल अल्ट्रासाउंड होता है. सो अल्ट्रासाउंड में कई बार बच्चों में ऐसी बीमारियां होती हैं विच इज़ इनकम्पैटिबल विद लाइफ. उस बच्चे को जीवन नहीं दिया जा सकता, लेकिन 20-24 वीक से ज़्यादा जेस्टेशन हो गया है तो वो अबॉर्ट भी नहीं कर सकते हैं फीटस में. सो मेनी अ टाइम्स फैमिलीज जस्ट are ready, they consent and they are ready and they carry out the pregnancy just for the purpose of organ donation. कि बच्चा जब वो पूरा अपना बर्थ हो जाए वो तो चलो उसको एनएनकेफेली है, वो तो इनकम्पैटिबल विद लाइफ है, बट आफ्टर बर्थ they will donate the organs, kidney, heart. So such poise incidents have also happened. Anyway, so lot of emotions. Let's go out for lunch. So we meet again in another half an hour or so at 2 o'clock.
Good afternoon to everyone. I thought everybody had their lunch. Everybody? So, okay, so we are going to start the next segment of our today's day one. We have Professor Dr. Pramod Kumar here with us. He's working in the Department of Skin, Department of Plastic Surgery in PGI MER. I would like to request Dr. Ranjan to please welcome Dr. Pramod Kumar for our today's programs. Thank you so much, sir. Now I will request sir to please come on the stage and please enlighten us about the skin donation and transplantation.
Surgeon in the Department of Plastic Surgery at PGI. So, you must be knowing about organ donation a lot. But what is tissue donation? How is it different from organ donation? And even in tissue donation, we'll be talking about skin donation, which is one of the type of tissue you know. So how is it different? First of all, I just want to give you an overall concept that in organ donation, you have the thing donated, it is immediately processed and then immediately used. But in case of tissue, you cannot use it immediately. You have to make sure whatever non-living thing that you are taking away from the body, you have to make sure that the body from which it is recovered is infection free and the tissue itself is infection free, and then it has to be made safe through processing so that its shelf life can be increased. We can store it for a time and use it as and when required. It's like in pharmaceutical industry, you prepare a drug, you store it and then you use it, and you have certain conditions for storage. Okay, and of course when you are storing something, you are processing something, you have to make sure that you have to retain the quality of that thing. The quality of anything can be based upon different parameters depending upon what type of tissue you are dealing with. So the quality parameters has to be ascertained. We have to make sure that these quality parameters are retained till the time when we are using it on the patient. And finally, after we have used it on the patient, how is the benefit to the patient that the patient has received after the use of that particular type of tissue? So that feedback is very important, especially for the tissue, because only then a tissue bank or any type of banking procedure can improve upon itself if there is a feedback. The second thing is, there is more important thing is biovigilance. I will elaborate on all these things through my lectures. So first of all, we should know, since I'm going to talk about the skin banking, we should know what is a normal skin look like. You can see this picture. In the topmost layer is the epidermis, the orangish part that you are seeing, and then there is a whitish layer down, that is the dermis part. Okay, so these are the two things which are of interest to us. Can I have, please? Okay, so you don't worry. So there is a orangish part that you are seeing, that is actually the epidermis, and the whitish part is dermis. These are the two things which are important to us when we are dealing with skin banking. So depending upon how much part epidermis you have to take, and depending upon how much part of the dermis you are taking, that is going to determine whether you are going to take a thick skin graft or you are going to take a thin skin graft. So that is the only difference that it is created, because dermis is quite thicker. what is skin important to us? We all know that skin is the largest sensory organs of our body. It is the cosmetic packaging of our body. Just imagine somebody, you have seen a mummy film, somebody is without a skin, so grotesque, horrifying. ठीक? So skin gives us a cosmetic package to our whole of the organ system and the body. Okay, and it prevents the invasion of microbacteria, all types of invading organisms. They cannot enter our skin because it is a barrier. And of course, it doesn't allow excessive amount of loss of fluids and proteins from our body because it is working like a barrier. And it is important for temperature regulation of our body. You know, we are not cold-blooded, we are warm-blooded. Our temperature remains same, 37 degree. But in lower animals, they can adjust their temperature according to the surrounding. And how this is achieved? Skin is playing a very important role in that, of thermoregulation. And of course, skin has got lot of immune cells which are important to prevent skin cancers, and because it is the entry point of any organisms, any infection. So immune system is there within the skin which can get activated any time whenever any microorganisms enter into our body through the skin. And it has got excretory function through our sweat. Lot of things are excreted. Vitamin D is metabolized in the skin, and of course the cosmetic packaging. So through these slides you must have understood that skin is very, very important for us. So what happens when there is skin loss, especially when you have burns in a patient? So there is first of all loss of that barrier of protection of infection. Our inner tissue or our vital tissue becomes directly in contact with the atmosphere. So any bacteria can just directly go into our system. It can cause infection. And of course, there is no barrier, you are losing a lot of proteins and important electrolytes from our body. So that will lead to malnutrition, a catabolic state in our body. Catabolic state is something when somebody is losing lot of proteins, carbohydrate, fat, and lot of nutrients from the body. So it is a state when our body goes into a negative balance. So that happens when there is a skin loss. And of course, immunosuppression. When there is burns, there are other factors due to which immunosuppression is there. But skin is, since it is an immune barrier to the infections, so loss of skin will lead to immunosuppression. And the disturbance of temperature regulation. So that's why we have to make sure that our burn patients are kept at particular temperature in the ICU setting, so that they should not lose too much of heat. And the possibility of deformity. You all have seen a lot of burn patients coming with a lot of deformities. Their neck, hands, face have deformities. So when the deep burns occur, they usually heal with deformities. So these are the problems when you have a loss of skin. In the initial slide, I told you that burns are also like superficial or deep, depending upon how much part of the skin is damaged. Suppose if it is only the epidermis and the most superficial layer or 1/3 of the dermis part that is gone. So these types of burns, they are called superficial burns. So these burns usually heal if you give them proper dressing and treatment. Like in this girl, she has got a hot liquid or hot water that spill over her face, and she healed in almost 13 or 14 days with proper dressing and treatment. So these burns usually heal because the skin has got a lot of reserve of cells in the deeper dermis through which automatic healing can happen. But what happens when it is deep burns? Means you have lost the epidermis and you have lost the dermis also. So in these cases, the deep burns, they cannot heal of their own. So we have to do some type of treatment, surgical treatment, dressings to make sure that they heal. Like in this picture, you can see the back of a person. The upper part of the back has healed after skin grafting. And in the lower picture, you can see that the shoulder of a person and the lower part of the chest, which has got deep burns. So that has healed after the skin grafting. So this is possible. But when we are dealing with the burns, say a burn of 20 or 30% area of the body, like the cases that I'm showing you, or less than 30% of the body. So in these cases, there is lot of donor area which is available in the patient itself. Means we can do the skin grafting by taking skin from their own body. So they can heal by their own skin. So this is what is achievable when it is less than 30% of the burns. Because we have got lot of donor area available. But what happens when you have a large deep burns like this? So there is lot of, it is almost involving the whole of the body. So there is no donor area. So how to heal this patient? What to do? How to save her life? So it is these cases when there is extensive and deep burns where the role of skin banking and skin donation and skin transplantation comes. So these are the patients which require. So in deep burns which are more than 40% of area, so they have got extensive burns. So there occur all the problems that you can see that are associated with the loss of skin. And plus, since they have got extensive burns, we cannot help them without a skin bank. So how we can help them with the help of skin bank, that I'm going to explain you. So what is the sources of skin? When we are using a skin for such type of patients, what can be the source? We can take the source from animals like pig skin. That these are known as xenografts. Xenografts, okay. So these can be used from the pig or other animals. But the problem with these things are that sometimes there are religious beliefs. So if we are giving a pig skin, say to a Muslim patient, it won't be accepted. There will be a religious problem. Or if you are using a beef skin or on a Hindu patient, then it will again a religious problem. And plus, animals also have a lot of diseases which are beyond our knowledge at still present, like Creutzfeldt-Jakob disease. It is one of a very rare disease, but it has been found that it can be transferred from animals to the human beings. But it is a very serious disease. It causes progressive dementia and deterioration of the brain function. So there is no treatment for this. So the xenografts are out of question because of lot of problems associated with them. So what is next option available? Of course, the same species, the humans, that we known as allografts or homografts. Okay. And the third thing that comes into picture is a biosynthetic skin. Sometimes we can process human skin or animal skin in a way so as to reduce the amount of antigenicity or problems that are going to happen with the animal skin or another human skin. And we can also do some type of synthesis by our biochemical mechanisms through which we can make artificial skin. But these are very, very costly things which are beyond the scope of our type of patients, because we are dealing in a developing country. We have got poor patients who sustain burns. So using these types of options are extremely impossible for us. So we are left with one option which is very good for us, that is human skin itself. Why the allografts are good for us? Because the human skin, like the patient's own skin, is taken on the wound. Taken on the wound means it heals on the wound. The skin of one human, when applied on the wound or burn wound of another patient, the skin get blood supply from that wound and it heals on that area. The wound is healed. Though it is temporary for 3 to 4 weeks, but the wound is healed. So there is no wound. There is no leaking of the proteins, electrolytes, fluids from the body. There is no pain to the patient. And the energy requirement of the patient, like the nutrition, because there is thermoregulation that is automatically happening. So patient is not consuming his energy to maintain his temperature in the absence of a normal skin. So all these things help, and moreover, when you have a barrier, though it is temporary and artificial, from a temporary barrier, but still it functions. It prevents the infection, it prevents the entry of bacteria into the body. And moreover, when you have got a barrier over a burn area and there are superficial burns underneath, they heal much faster. Like a burn, superficial burn, when dressed with a simple dressing or when dressed with a homograft, there is a significant difference of more than 2 times. A burn which is superficial will heal in say 7 days or 5 to 7 days under a homograft. So why this happens? Because the homograft is going to seal the wound. It won't allow any bacteria to grow on that surface. It forms a barrier. It won't allow further entry of bacteria into it. It allows so many advantages. The patient is not losing his nutritive proteins, fluids, electrolytes. There is no infection. A patient's thermoregulation is controlled. His general condition is improved. So all these things are advantage to the patient, and they heal much faster and much better. So how to obtain the skin? From where we can take the skin? We can take the skin from a human who is willing to donate altruistically. This word is very, very important. Altruistically means nobody is benefited out of it. Neither the donor, nor the recipient, nor the person who is intermediary taking the skin graft. So that part is very, very crucial in any type of organ or tissue donation program, which is very, very important. So we can take from the living donor. Say a child is born and the mother is there. We can take skin graft from the mother and use it for a child. And but legally this is not allowed in our country. So we cannot practice it legally. The law does not allow us. However, we can take skin graft from the cadavers or anybody who has died or a brain dead donor. So the concept of skin banking in our Indian scenario is, it gained popularity in 2010 or 11 with the, or 2009 when the first skin bank started in Mumbai in Sion Hospital, and later on further skin banking was established by Dr. Sunil Keswani in 2010 in National Burn Center, and after that lot of skin banks have developed. And so this is how the skin banking started. But the first thing started in US, Maryland, 1950, quite long back. So this is not a new concept. This is a very old concept which has been used in the Western countries for quite a long period of time, and they have benefited their patients significantly. Now they can save a burn who is 80 or 90% because they have got all these resources available. And plus, moreover, they have improved their setup also. So, skin, as we know, it is a precious source when you are using it for tissue donation. Why it is a precious? Because it provides living cells. It prevents the infection. It can be preserved. We can store the skin graft for long term. We can prevent disease transmission from donor to recipient, and we can regulate distribution of graft, which is very, very important, and to keep the record of traceability in case of unfavorable event, like biovigilance. This is a very important term that I would like that all of you should be aware of. How it is important? Say in our scenario, we are very much behind in tissue banking, but in the Western world, tissue bank includes not only skin, they include heart valves, they include ligaments, they include bones, they include tendons. Tendon is something which joins muscle with a bone, and ligament is something which joins bone with a bone at joint. These are the tissues and the heart valves. So all these types of tissues, they are being stored and processed in the tissue banks in the Western countries. So when there are so many tissues that are taken from one donor, and all these tissues are distributed to different recipients, and in Western countries, like in Europe, they are sent across to the other countries also. within the Europe only. So one donor's tissue is going to so many recipients. And suppose one donor has got one infection which was not detected in screening, and suppose we have used skin and we detect that infection in our patient first of all, but there are patients who have already received a heart valve, who have already received a bone, who have already received a ligament. So biovigilance is important in that sense, because when there are so many tissues which are going to so many different donors, the first recipient that develops the disease, we have to immediately inform the tissue bank, this is our patient, this disease has developed, we have ruled out all possible causes, except for that there is some reason that this has been transferred by the tissue. And when this happens, then it is very important to inform all the recipients by the tissue bank to all the recipients. So this is very important. We have to be vigilant in all the recipients that they are not developing any disease symptoms of that particular disease, or we can inform them at time, or we can do some treatment to them so as to prevent the development of disease. So all these things come under biovigilance. Sometimes certain tissues during processing, they develop some abnormal features or abnormal behavior that when they are used in patient, they cause some allergic reactions, or they cause some untoward outcome or results which are not good for the recipient. These are also should be informed to the tissue bank, so that other patients are benefited. The same tissue is not distributed to the other recipients. So this is the importance of biovigilance, which is important when you are dealing with this tissue banking or skin banking in particular. So what is the legal aspect? In our country, we are following the THOA rules, the transplantation of human organ, that is 2011. It has been amended in 2014, and National Organ Transplant Program has been started. Basically, right now we are dealing with lot of organ donation, but tissue donation is gradually picking up with the generation of awareness, and hopefully in future we'll be having lot of more tissue banks. And tissues which are allowed till now as per THOA rules, we can do tissue banking for heart valves, we can do tissue banking for bone, we can do tissue banking for ligament, tendons, we can do tissue banking for vascular grafts. Like if we say somebody is beating heart donor, we can take its blood vessels, and that can be processed and used as a graft for some another patient who needs. Otherwise, the vascular grafts are very costly. One vascular graft will cost in lakhs of rupees. So this is the difference, that a simple procedure of donation can make a difference to the recipient. It will give the same benefit, but at a much lesser cost. And it will be much, much better, because a graft that is taken from the human body will be accepted in the recipient, and it will heal there. Whereas other graft is always a foreign body. Synthesized graft is always a foreign body inside the other body. So it can have a potential of infection anytime. So it is a risk for the recipient. So these are the advantages that I want to stress upon, that a tissue bank can make to a recipient. So these are allowed. However, living donations are still not allowed. Means, like I told you before, if a child has got burned, we cannot take skin from his mother or his father or his relative. This is not allowed as per rules. So what is important, that comes as a transplant coordinators, as NGOs, the first thing, that is foremost thing, is to create awareness among the general public. Like if I tell you, just one question, what could be the donation rate in the European countries? Any answers? Any answers? Guess. Out of 100 deaths, how many are donated? Any rough guess? 60? Yeah, it is to the tune of 90 plus. In Spain and Italy, if there are 100 deaths, out of which more than 90 body donations happen. And they take all the tissues and possible all the organs whichever can be used for the benefit of the recipient. So this is the extent of awareness that those people have developed, and that has not happened overnight or a couple of weeks. It required a lot of efforts all over the country through various types of non-governmental organization, educational institution, professional bodies, and like you people as transplant coordinators, paramedical staff. That is, if you know what are the benefits, how is it going to help the patient, only then we can create awareness into the people, and that is going to make a difference. And that awareness can be done through lectures to the professional group, like today I am talking to you as a professional group to make you aware how is it going to help, or such type of lectures can be arranged for a particular, say, professional organization, say it's some sort of software company. We can arrange some short visit or short lectures to them. This is how it is going to happen. And this is not only can happen through the doctors, or it can be done through any paramedical helper, any transplant coordinator, or any non-government organization which is associated with tissue banking and donation. And we have to use print and audiovisual media as much as possible, because it has got a wider reach to the general public to create awareness. So what now we are going to shift to what is actually happening in the skin donation, and how the skin is donated and how it is received and how it is processed, how it is preserved, and then how we can use it for the patient. So this is how, so if you this triangle, the centermost thing is very, very important, the consent. First and foremost thing. We cannot take any tissue or anything from anybody if there is no consent. And that has to be altruistic. Altruistic means you are not paying anything to the donor. Donor is not getting any benefit out of it. Neither the recipient is getting benefit out of it, monetary benefit. Okay. So the donor family is not getting any benefit out of it, monetary benefit or some another type of benefit. So it has to be altruistic. The consent which is altruistic is very, very important. And then comes the role of medical and social history, which is very, very important. Like if you are seeing the lower part of the C, we say blood serology for HIV, HBS, anti-HCV. So these are the serious infections for which we don't have any cure. So we have to make sure that we take a thorough medical and social history of the patient to make sure that a donor from which the tissue is going to be received is not likely to be infected by anything which can cause a serious disease in the recipient. As I told you, in case of burns, when the skin is lost, there is immunosuppression, and that immunosuppression is very, very significant. A burn patient has got a more than 50% reduction in the immunity of the body. Suppose if we are giving a skin which is infected by HIV or HCV to a patient who is already having a low immunity, what is going to happen? It's a disaster, big disaster. You are going to kill the patient. You will save him for the time being, but in due course of time, he'll die of the other disease. So that is important. So a medical and social history, especially related to his sexual history, his social history, how he is performing in social life, his marital history, his marital status, all these things are very, very important. We need a crucial, thorough details from the relatives of the patient, the first degree relative, the spouse of the patient, the friends of the patient, if the spouse is not available, because this is going to create a much, much significant role when we are doing the tissue donation. And we have to screen the patient for all the diseases like HBS, HCV, HIV, and before the donation we have to do a thorough physical examination to rule out that we are not having anything which problematic to the tissue that we are going to take. Like in this case, we are having we are going to have the skin donation. So we have to make sure that any disease process which is involving the skin, that has to be taken care of. We have to be sure that we have screened that part. And second thing, we have to make sure that any disease process which is affecting the body in general, like HIV, HCV, HBs antigen positivity, these are the diseases which are general diseases, which can affect the body and they can transmit from one person to another person if the tissue is taken. So that is also a serious concern. The tissue specific criteria and the general criteria. In the tissues where we have to make sure that extremes of age has to be avoided when we are doing tissue donation, especially skin donation. Morbidly obese patients have to be avoided. Why? Because they have got lot of infection on the skin. Because there is lot of folds on the skin and there are a lot of hidden spaces which get infected, colonized by the bacteria. So we have to make sure that we don't avoid such patients. Any patient who has got any type of skin infection, bacterial, viral, fungal, ringworm, scabies, or patient is having say herpes zoster, all these things have to be clinical examination through physical examination, and we have to rule out. And we have to make sure patient is not having any type of diseases from the skin like psoriasis, eczema. These all have to be ruled out when we are doing physical examination. And we have to make sure the skin is not damaged due to trauma or wounds and any signs of previous radiation through which the skin has already been damaged. So we have to make sure that the skin is not having radiation damage beforehand, because this skin is not useful for the patient. And any conditions of the skin which is not diagnosed till date, means somebody has got a, say, a blackish spot on the skin, a black color or hyperpigmented spot, but it is not diagnosed. So when we do not know the diagnosis, it is better to avoid the tissue donation in such cases, because we may be transmitting a disease which may be a cancer, which is not good for the recipient. So these things are important when we are doing the considering the tissue specific criteria. And we have to make sure there are a lot of systemic diseases which can affect the skin also, like systemic sclerosis or collagen vascular diseases, lupus, autoimmune disorders like disseminated psoriasis, means the psoriasis which is involving the whole body, and disease affecting the dermis like dermal mucinosis, nephrogenic fibrosing neuropathy. These are the diseases which are general diseases that will damage the dermis. So which is our prime concern when we are taking the tissue. If the dermis is already diseased and damaged, we are not going to help the recipient. And if there are systemic infections, say septicemia is there in the patient, premature signs of body decomposition, some death has occurred, there are signs of decomposition in the body, we have to avoid. Don't take any disease, any cancer in the patient, we have to avoid. Then comes, after you have ruled out all these things, you have done the screening, then you have done your ruling out of all the contraindications, then second stage comes for the skin donation when you are actually retrieving the skin. The skin retrieval has to be done in a condition that is a clean room. Clean room is like a, it should be like a OT condition. So grossly saying, okay? So OT condition is something when you have air which is filtered with some specific criteria, one in which is ISO 1 in 10,000 criteria. It's a particle criteria which is important. So that should be the environment. Like in this picture you are seeing, the skin is the preparations have been made, and the identification of the donor is there. We have to make sure the consent is taken from the first of the kin, and the post-mortem interval has to be assessed. There are no signs of decomposition. We are well within time. Recovery environment, as I have already told you, equipments are working, they are ready, and our trained persons are available, which is very, very important. And this is how the skin is harvested. It is like a peeling. When you peel a potato, the skin is similarly harvested with the help of a electric dermatome. It is an instrument, like in the middle figure you can see that the dermatome is being used to peel the skin from the surface. And when we are peeling the skin from the surface, the most common problem is that we will feel it will bleed. This is the question that comes to the mind. Or it will ooze. In a dead body, this doesn't happen. There is no bleeding, there is no oozing. It is absolutely dry. So, which is important that we should know about it. So we have taken the skin. Now, what to do with the graft? So once you have received the graft, you have to make sure that you send a culture from the graft, which is bacterial, both aerobic, anaerobic, and fungal culture from the skin graft. So you have to take small pieces of the tissue, and rest of the tissue is processed in a temporary transport medium, because when you are harvesting skin, say if it is a dead donor and if we are doing a donation, sometimes it may not be possible in a hospital setting and the death has occurred at home. In our Indian scenario, we are also taking donations by visiting the home of the donor. But we have to make sure that the room is clean, the environment is clean, it is airy, it is not dirty, damp. We have to make sure all those things. This is happening and this is allowed, but ideal would be a OT condition. But in our scenario, if it is not possible, you cannot go to a place where the death has occurred, bring that body to the hospital. You will lose the precious time, which is only 6 to 12 hours in our weather conditions. So sometimes we have to take the skin graft at home also. So it is placed in a temporary transport medium, culture medium is there, and then we bring the tissue into the skin bank. And in the skin bank, what happens is that we do the preparation for manipulation of the graft, and then we preserve it, and then we, after preservation, you do the packaging of the graft. And once it is packaged, then we have to do proper record keeping. We have to give a unique donation number to the graft, and then it is distributed. So this is the setting of a skin bank. A restricted entry has to be there, because skin bank lab has to be like a OT lab, OT conditions. Like I have told you, ISO 1 in 10,000 has to be the particle count. You have to make sure there is no free entry and exit into that area. The restricted entry has to be there. And the second picture that you are seeing is actually the biosafety cabinet, where it has got a air which is HEPA filtered. So the person who is sitting is going to put a curtain which is made up of glass. He'll just put his hand into that thing and put the tissue there and then process the tissue into that. What is going to do with the tissue? So when we receive the skin, we have to make sure we standardize it. How do we standardize this? Like you see, this sheet of skin is lying there. We have to measure it. So when I am giving it to somebody for use, he should know what is the size of the skin I am giving him, or how much size of the skin he requires. Accordingly, I will distribute the skin. Say if somebody needs a 100 centimeter square of graft, so I should know where is my 100 centimeter square graft is there. So have to measure it, and we have to standardize it. We have to make sure whether it is a thick or a thin graft, because sometimes somebody is specifically asking for, I want a thick graft, or somebody is asking for, I want a thin graft, because there are different indications for their use. So these are the things that happens in the initial processing in a skin bank. So these are the definite terms that I want to make sure that, like, split thickness graft is thin when we are taking 1/3 of the dermis. When you are taking 2/3 of the dermis, it is thick graft. When we are taking whole of the dermis, then it is a full thickness graft. Or sometimes we only take the dermal tissue. We discard the epidermal tissue and we take the dermal tissue. That is also processed for some further usage as a tissue. So now, since we have measured it, now we have to preserve this thing. And in the meantime, when we are harvesting the skin, before preservation, you have to make sure that you have got the blood investigations report with you. The initial preparation can be done without the screening, but this final preservation, this should not happen unless until you are sure that the patient's blood investigations like HIV, HBS and TSCV, they are negative. Only then you will, till then time, 2 to 3 days, we keep the skin on hold. We don't process it. And in the same period, we also receive the culture pieces of the tissue. initial processing, we have taken the small pieces of skin, and that was sent for bacteria culture, that was sent for fungal culture. And in these 48 to 72 hours, we receive those culture report that skin is not infected, the tissue is not infected. Only then we are going to proceed for the preservation part. So how do we preserve it? We can do cold preservation in a simple refrigerator. But this is only possible for 21 days. We can preserve the skin at 2 to 8 degrees temperature in a simple refrigerator, but not in the freezer. Make sure this should not happen. Skin should never be put in a freezer. Otherwise, the skin will be damaged. The tissue will be damaged. It has to be put in the first and second shelf below the freezer at 2 to 8 degrees centigrade. Another way of preservation is through a cryopreservation. The cryopreservation happens when we are storing the skin at minus temperatures, means less than 0 or sub-zero temperatures. So that usually happens when we add 15 to 20% glycerol. Why do we add glycerol? As I told you, you should not put the skin into a freezer. But here again we are storing the skin below 0 degree centigrade. How is it possible? So we have to add glycerol to the skin to make sure the glycerol works in a way it prevents the skin graft from damage when it is taken below the sub-zero temperature. So it is a cryoprotectant in 15 to 20 degree, 20% concentration. And another way, in cryopreservation, what happens is the cells retain their viability in both the upper methods, the refrigeration and cryopreservation. Cell retain their viability. Means the cells remain living. Their metabolic rate is significantly reduced to the extent that they don't need so much amount of energy, but they will survive on the minimum amount of reserve that is there in the cell, and the cell remain living. What happens in the other bed, in the glycerolization method, in this the glycerol concentration is increased from 85 to 90% glycerol. So what happens in this is the skin becomes dead, but it is preserved. The architecture of the skin, like you have an epidermis, you have a dermis, all these things are retained. The skin as a structure of the skin will be retained when we are storing it in glycerol, but the cells will die. And moreover, the second advantage of glycerolization is it will kill all the bacteria, viruses, even HIV. It has been reported. At 85 to 90% concentration, the glycerol will kill all these infections, but the cells will die. Another thing is lyophilization, that is freeze drying. All of you must use the frozen peas. It's the same process that is being used here. The skin is freeze dried, but here also the cells will die, but we can use the lyophilized skin for a much longer period of time, say 8 to 10 years. And in glycerolization, we can use for maximum 5 to 8 years. Cryopreservation also gives us the advantage of using the skin for almost 5 to 8 years. But there are always certain advantages, I have told you through this. Cryopreservation, since we are storing at minus 70 to minus 190 degree, so you need a specific setup for that. You need liquid nitrogen, or a very costly refrigerators which are based on liquid nitrogen, and that has got a high cost input. And glycerolization only needs 85% glycerol, and that is stored at 4 to 8 degrees centigrades. So it has got less cost involved. And lyophilization, it is also a very technical procedure. It need a lot of inputs, and it is also a costly affair. But the storage is much longer. And then comes, once you have done the preservation of your skin, then it is very important to level it properly. In the Western world, what they do, they use 10-digit number, because their skin is, in the Europe, the skin is going from one country to other country. So the tissues are going from one country to another country. So what they are doing is, they give a unique code for the country, because a tissue bank in Germany may be sending a tissue to the Spain. A tissue bank in Spain may be sending a tissue to the Poland. So they have a specific country code, and then the region code, and then the particular tissue bank code, and then the donor code, and then the particular region from where the tissue has been received. Means skin graft can be harvested from left thigh, right thigh, upper limb, back, front. Okay, so many areas are there. But suppose some disease is there in the leg which was missed on the initial finding. So we should know if something is reported from the user that my patient was not benefited by the graft or something wrong happened to my patient. So when it comes back to the tissue bank, we should know that we are receiving this complaint regarding this donor only for this lower limb graft, but not for the upper limb graft or for the back graft. So that is where the vigilance is important. So a tissue packaging and labeling is very, very important. And of course, we have to mention how it has to be stored when it is traveling during the time when it leaves the tissue bank. So how it has to be preserved, what should be the storage temperature, and when it is reaching the hospital where the tissue is going to be used, how it has to be, say, we are using a skin which was stored at -60 or -190 degree. So how to bring it to lower temperature? What is the process? Even when the skin is lying in glycerol, which is 85 to 90%, it is very high concentration of glycerol. You cannot use that skin directly on patient wound. That will damage the patient or recipient. So it has to be properly processed before use. All those instructions should be part of the packaging and labeling. And of course, we have to mention the expiry date and how it has been preserved, whether in case of bone the antibiotic exposure is given so as to make sure that we are not transmitting infection. There are a lot of different types of procedure for different types of tissues. In some tissue you give an antibiotic exposure, means you dip the tissue into an antibiotic solution for a particular period of time. So that is very important that we have done this thing before sending the tissue. So how to use, once it is coming to a beneficiary or a hospital, then how the skin can be used? It can be used as a temporary biological dressing, temporary skin substitute, and dermal replacement. These are very technical terms, but I'll try to make it simple for you people. What is the temporary biological dressing? Temporary biological dressing is something which can be used on a wound for a short period of time in a way so as to give maximum benefit for the wound to recover or heal. Say, suppose a patient has got 40% burns and there is a 40% area of wound on the body. If this patient is just dressed with simple dressing, he will lose too much amount of protein, he will have failure of thermoregulation, he will have repeated infections through that wound, that he will die with that wound. But if we are going to use a skin graft which is donated or allograft on this wound, then it is going to help improve the wound conditions. How? Because as I have already explained you, it will close the wound. It won't allow any bacteria to go inside. It will work like a barrier to avoid the losses that is going to happen. And it will augment the immune response of the patient. And if there is minor infection in the wound, say a wound, a minor infection and a graft over it. So what happens, those bacteria get entrapped in that area. And the body's immune system is going to catch hold of those bacteria. Otherwise, if it is a simple wound, the bacteria keep on running. They form a biofilm on the wound. Biofilm is like a thick secretions that you see on the wound. The bacteria, for bacteria, it is like a shield. So if that is there, when there is a graft over it, the bacteria get entrapped into that. And the immune response can kill those bacteria much, much quicker. So the wound condition will improve. And this graft will stay on the wound, say, for 2 to 3 weeks. But during this time, patient won't have any pain, he won't require dressings, he won't have infection. he will have cure of the infection if it is there is infection is there in the minor amount. He will have better health in terms of nutrition because there is no loss of proteins, electrolytes from his body. So all these things, his immune system is augmented. So these are the temporary benefits which the patient will get. And during this time, when the patient wound is improving, we can arrange for the other methods to give him a proper wound closure, that is permanent wound closure. Sometimes a wound is there, say there is an ulcer on the leg, and somebody has operated him 3-4 times. Somebody has done a skin grafting on that. Skin grafting is he has taken a skin from his other thighs and it has applied on that wound. But that wound is infected by some bug which is not allowing that healing. So every time, 3 times he has been operated, the wound will have some infection and then the graft will be lost. The wound will remain. So the donated skin can be used. That wound can be thoroughly washed or cleaned surgically, and then we can, rather than using his own skin, which has the potential to be wasted because of that bug infection, what we can do, we can use this as a temporary dressing. We can apply that skin, donated skin, after thorough cleaning and surgical cleaning of the wound on that wound. It will be lost in 3 weeks. But if it is taken for 3 weeks, we are 100% sure that this wound is now going to take the patient's own skin. So we can do testing of the wound. As I've already told you, in case of superficial burns, when there are second degree burns, if we apply homograft, they heal much, much faster because the conditions are controlled. They are moist condition. There is no entry of bacteria from outside. Patient is not losing any proteins. His immune system is better now. So all these advantages will make those wounds heal faster. So this is how the temporary biological dressing is going to work. Sometimes a patient who has got say some important structures, like somebody has got an injury on the hand and his blood vessels, his tendons. Tendons are something which is joining muscle to the bone. So all these vital structures, say blood vessel, nerves, tendons, they are exposed. But patient condition is such that we cannot immediately do a surgery on him. The condition is not suitable. So what to do with that? If you leave an artery open, it will burst in another 48 hours. And patient will die and he will lose his limb. So what to do in that case? So here comes the role of biological dressings. We can just simply put one skin graft over it. It can tide over the condition for 48 to 72 hours. And this is how it is going to help. So in that time, patient's condition might improve, his infection might improve, or his anesthetic condition, which is not allowing the surgery initially, that might improve. And during this time, that structure is preserved with the graft, as a temporary biological dressing is there over it. Sometimes say there is a child who has got 40% burns. So children have very smaller thighs as compared to adults, and thigh is the major donor area for harvesting the skin. And to give you interesting information, if I take skin graft from one thigh, after 21 days, when it is healed, I can take again skin graft from the same thigh. But my initial area of wound is such a big wound. So I cannot take both the thighs simultaneously. I have to take only one thigh. So when I am taking one thigh, the rest of the area can be covered with a biological dressing. So the wound is closed with both autograft and homograft, and the patient is happy. He is without pain, he is without wound, he is in a much better condition. And this is how a skin is going to help us when you have reduced access to donor area. After 21 days, when you are about to lose your homograft, your donor area is healed. You can again take the patient to OT, remove that homograft, take another donor area graft and apply it on the wound. So after 21 days, patient is in a much, much better condition and he will heal faster. Sometimes patient is on OT table and we are doing surgery. Suppose something unfortunate happen and patient loses lot of blood, or patient vital parameters are not allowing, there is some anesthetic problem, and we cannot immediately close the patient wound with some definitive surgery. It's sort of a life-saving situation. So what to do in that case? You cannot do a long surgery. Anesthetist will say, okay, do something, close it, take the patient to ICU. I cannot allow you to operate. So those are the situations where a temporary skin substitute can be used, or a homograft can be used in a clinically unstable patient. If you see this diagram, sorry for that gray thing. If you see this diagram, it has got two nets. If you see, the lower surface, which is plain surface, is actually the wound area, and in the middle net is much wider, and the upper net is much closer. So what is this thing? When we use skin, we can do the meshing of the skin. Meshing means we can convert a skin into a mesh-like thing with the help of instrument that is known as mesher. Why do we need that? So from a small graft, which is 10 by 10 centimeter, we can do 2 times meshings, means it become 20 by 20 centimeter. So a 10 by 10 centimeter graft, when meshed, will increase in size to 20 by 20 centimeter. So small size graft can be used for a larger size area. So this is how it is going to help. But in children's, we do meshing which is to the tune of 1:6, because they do not have large amount of area. Donor area is very limited in certain patients, or if the burns are very large, so donor area is limited. So here we use a sandwich technique of grafting, where the autograft is widely meshed and we apply homograft, that is donated skin, over it. How it is going to help? The donated skin will allow the autograft, that is patient's own skin, to heal underneath it. It is like when we are dealing with superficial burns. There is a upper layer of donated skin, and below it is the healing wound. Here what we are doing, there is upper layer of donated skin and the lower layer of patient's own graft, which is widely meshed. And during the time when this healing of the autograft is happening, the upper layer will provide protection in the form of a barrier. And gradually the upper layer will be rejected after 21 days. By the time it is 21 days, the autograft below has healed. So this is how it happens. So the skin can also be used in this way. Dermal regeneration matrix. Sometimes you see patients who have got very bad scars, very ugly looking scars. So they are known as hypertrophic or keloid scars. In those types of patients, say somebody has got a bad scar on the face. If you operate a keloid, it will 100% again form a keloid. If you operate a hypertrophic scar in bad conditions, it will again form a hypertrophic scar. So how to avoid? There comes the role of dermal regeneration matrix. What is this? Actually, you remove the epidermis from the donated skin. The dermis that remains, that can be processed and used as a graft. So that dermis is not rejected by the body when it is processed and the epidermis is gone, because that epidermal cells, they are antigenic. They will stimulate the immune response from the patient's recipient body, and after 21 days that skin will be rejected. But the dermis which is there, that is not rejected. It is taken on that wound. So this is how it is used. When we are dealing with hypertrophic or keloid scar, we excise the scar and we apply dermal regeneration matrix over it, and after it is healed over it, we apply normal graft over it, patient's own graft. And once it is healed, it is less likely to form a hypertrophic scar or keloid scar. So this is how it is used. This is a newer concept, but still the skin bank can provide dermal regeneration matrix to us for this. Like we can use the decellularized dermis matrix. It can be used in lot more other conditions, but the dermis is something which is the center of research right now for lot of things, because keloid and hypertrophic scars, they are very mischievous things for which different types of treatment have been tried and none have been 100% successful. So use of dermal matrix in this is upcoming concept. And allogenic skin cell cultures means you have got a dermal regeneration matrix which can heal on the wound, and the cells from the epidermis, they can be processed and they can be made less antigenic, and they can be processed in a way that they will provide you a gun which can spray cell on a wound, which are less antigenic. You don't have to take a graft and apply a sheet on a wound. You can just have a solution of cells and spray it on the wound and dress it. After few days, those cells are going to survive on that wound. These are the upcoming concepts which will come in future course of time. And be an organ donor and tissue donor and give gift of life after you leave. Thank you very much. Any queries, please? I hope I made it quite clear. Thank you.
So skin is an organ which is organ donation or transplant. This is something very new, and I have learned so many things today, and I'm sure there must be some questions which are coming to your mind. So sir will not, you won't be able to catch hold of him again. So this is the best time. If there are any queries, जो भी मन में आ रहा है पूछना चाहते हो तो ज़रूर पूछ लो. Because you will not get in most of the.
It is good to ask a stupid question.
Yeah.
And to remain a stupid for rest of your life. This is what I believe. Yeah,
Mike.
Yeah, definitely. We avoid extremes of age. As I mentioned in one of the slides, we have to avoid more than 80 years of age. Though somebody has tried to take 80 years of skin, but the skin quality is not that good. And in very small young age, say less than 12 years of age, there you won't receive that much amount of graft. So it is not that quite effective to take graft from that children.
One question which I had, sir, when you spoke about the cryo and glycerol 85%, so in those conditions the skin is almost dead, the cells are dead. You said non-viable cells. So how actually are we able to use that kind of graft? And how does it function after the grafting?
Like I told you, it is working like a biological dressing in that scenario. Have I told you, the skin graft when applied on the wound, it can be taken, means it will get blood supply from the wound bed and it will heal the wound. Like I showed you few pictures of the patients where we have applied skin from their own body on their wound and it healed. In a similar way, if the cells are viable, they get vascularized and that it heals. But what is happening in case of a non-viable cell? It will just work like a biological dressing, but still it gives lot of advantages, even if it is working like a biological dressing. As I have told.
Thank you so much, sir. Indeed, when I was doing my PG Masters in Surgery, so we used to see burn patients. So whenever there was more than 30% burn patient, the mortality was almost certain. These patients would die. It is very difficult to, in those times, maybe 15, 17 years back, it was very difficult to save a patient who has sustained burns more than 30, 40%. So, but I'm sure with the advent of skin grafting and skin transplantation, lot of such lives have been, PGI had a specialized burn unit, I think it still has, and where they are doing some excellent work to save life of such patients who have lost a lot of skin from their, because of burns. Thank you so much, sir. Thank you for that insightful talk. It was really very energetic, and it was a lot educative and informative for all of us. I would request our nephrologist, Dr. Anna, please do the honors, give a memento, sir, as well as a certificate of appreciation.
Thank you so much, sir. Now I will request to Ma'am Sujata to please continue forward. ये वाली चलानी है. Everything is understandable to everybody. Are you getting bored? Yes. So, sir, will Dr. Sudhir Dhiwan will guide you according the public awareness, importance of public awareness. Okay.
Good afternoon. After such a exhaustive topic on skin donation, little lighter on public awareness, but very important, let me tell you. See, when a transplant coordinator is not coordinating or grief counseling, organ donation, which is not every day, which is, maybe once a week, all other times the time is utilized in the public awareness. Now, what is public awareness? When we say that India has opt-in, you remember from the morning presentation that it is opt-in policy, that a person has to opt in for organ donation. Why would anybody opt in? How would anybody come to know that what is organ donation? Why would anybody be convinced that I should donate organs unless they are made aware of this? Let me take you back in this region by about 1 decade, which is not a very long period. I started honorarily working for Mohan Foundation about a decade back, about 12 years back. 2010 end, or let's say 2011 beginning. So the first point was to do public awareness because there were no organ donations per se taking place in Chandigarh. The first organ donation, cadaver donation, which took place in PGI was in 2011. Now, how to spread awareness? Because nobody was aware of organ donation, that organs can be donated. Nobody was ready to accept the fact. Nobody was ready to listen to what is organ donation. So it was an uphill task. Icebreaker was given by armed forces and media, because once we did programs in armed forces, there were media coverage and that started spreading the awareness. And the next level came from the first donation that took place in PGI, because that time we did not know the laws so well. The donation propagation, right from the person who donated, the family who donated, everything was given out in the press conference next day, and it was covered by the media, and there was so much of awareness to people that there has been a organ donation where a young girl has given liver to a Muslim gentleman. She was from a Sikh family, and given a new lease of life to that particular patient. So this is what is public awareness, and all of you have a big role, a major role to play in the public awareness. Every organization, especially NGOs, they have to identify or they have to create the brand ambassadors. Like in Mohan Foundation, we have brand ambassadors like Ravina Tandon, we have Kapil Dev, which is very relevant ambassador for our part of country, because a hero in Punjab and Haryana. Then Amir Khan, the perfectionist actor is what he is called as, and his family. So these are the people who carry the message to their followers on the social media, on Twitter, on Instagram. Organ pledging. We have been talking about organ pledging since morning. Organ pledging is nothing but conveying your wishes through a donor card. This is our donor card. Similarly, Roto has a form to be filled in. This has no legality. This doesn't, once you have filled this in, signed it, kept it in your wallet, it only conveys your wish. Even a person who has filled in a donor card and has found a donor card in his wallet, but his next of kin, the attending person, refuses organ donation, no doctor will go proceed with the organ donation that this person has filled in the organ donor card. So most important organ donation pledging is that you fill in the card and you must discuss with your family. Because at that particular moment the family should consent to the transplant coordinator's counseling for organ donation. Now, awareness is to register as organ donor. One person who registers as organ donor, talks to his family, spreads the awareness to 4 to 5 people in the family. How will he spread? That he is made to understand what is organ donation. Which organ can he pledge or donate? What are solid organs? What are the organs which a living person can donate and what a cadaver person can donate? When can one donate? A living person to the family, to the blood relation, to the next of kin, while living, and cadaver donation after death. What is the process of organ donation and what is the process of organ allocation? All these questions are to be satisfied in the organ donation awareness programs and making the audience understand what is organ donation. Now, these are the awareness programs which are conducted very regularly. In Chandigarh, in our office, Mohan Foundation, me and Neha, my program officer who is sitting there, probably we do maximum number of awareness programs in Mohan Foundation all over India. And the main areas which are conducted, which are covered are will be conveyed to you later. In living organ donation, the patient must know, the person must know that what is the age for living donation, to whom we can donate. We can donate only to our own blood relation, that is grandparents to grandchildren, with an exception of spouse where the blood relation does not concern, all others have to be blood relation in this. Establishing relationship, especially couples, like Dr. Priyadarshi Ranjan was telling in the morning that he had a case where so well photoshopped wedding album that it was very difficult even to think that this couple is not married. So it is the role of a transplant coordinator to identify the false, such cases which are false, and bring it to the notice of the authorization committee in your hospital. You will find many such cases, especially when there are foreign donors. It's very difficult to identify whether it is related or unrelated. Donor fitness. Fitness of the living donor is very important. Both psychological, physical, both is very important. Approval of authorization committee of your hospital of a living donor. It is done by an interview of the donor, and then that interview is video recorded, and that video recording is kept, is preserved for at least 10 years in that particular hospital in case any such case arises in future. What are the ways of public awareness? That is face to face. Audio visual effect, like this, we have presentations. Our people go and address different audiences with PPT presentation. You assess the audience. Opening and closing is very important, and details on organ donation is conveyed to the audience. Which is the audience? Audience is picked up young audience from educational institutions, which are schools, senior classes, 11th, 12th, college going students. Red Cross is a very important area for public awareness in their first aid training programs. NCC, NSS, these are again very important institutions for public awareness. Social organizations like Rotary, Lions, religious gatherings. There are many religions which promote organ donation, like especially Bias, those who believe in that religion. After every religious congregation, they give a handout which says कि अपने अंग दान दो और केड़े अंग दान दिते जा सकते हैं. So the religion itself promotes organ donation. Police is very important because all MLC cases are handled by police. And then the corporates, again very good area for organ donation. Engagement of volunteers. The social organizations, they come forward to become an organ donor, to promote organ donation. They appoint their own ambassadors to spread awareness as a project in Rotary Club. Students, they spread it in their peer group once we address a school or college or any of these classes. Other NGOs which are not working for organ donation but maybe blood donation, we collaborate with them. Then Mohan Foundation has a very specialized program of organ donation ambassadors. These are the people who are given one-day training on organ donation, and they pick this as a project, the organ donation promotion in their area of specialization. We have 3 such ambassadors working in our area of Punjab and Haryana, including Chandigarh, and they are doing wonderful work. Now, peer group I was talking, this is a very sad but relevant example. Rachit Grover, he donated his organs, and his family donated his organ in 2017, I think. He was studying in Vivek High School, Chandigarh, must have heard of school. And our program officer Nilakshi, who is now working in PGI as transplant coordinator, went on a public awareness campaign to this particular school and addressed the students. Rachit was one of those students of 12th who attended that session. And he was very appreciative of this particular cause, went and talked to his family. He came to our office to pick up more donor cards for his parents or his grandparents. As the luck would have been, 7 months later, on his birthday eve, he had a skid on his bike. His head hit the pavement, rushed to PGI. He was declared brain dead. Before the PGI transplant coordinators even talked to his mother for the organ donation counseling, his mother said that he was so passionate about this cause that if we don't donate his organs, probably his soul will never be resting in peace. They immediately came forward and donated his organ. So this is the importance of public awareness at student level. Though it's a very sad thing, but then this is, the other students, they carried this on, discussed this with their peer group. Role of media. Media plays a very important role. In this particular region, every second, third day, whenever there is a donation, like yesterday there was an organ donation in PGI, tomorrow's paper will carry that article on who donated, which organs were donated, how many people got benefit out of those transplanted organs. That is a very big awareness tool. Besides that, YouTube, if you just type Mohan Foundation, you will have many videos on organ donation. Facebook pages, Mohan Foundation also has a Facebook page. Instagram, Reels, Twitter, and our own website is a very informative website for awareness. In print radio, see, we have radio programs, radio coverage on organ donations. Community radios now are very popular. You have regional radios, and such programs have very good effect on the local population. Cable TVs, and the very important is the national TV program. I hope you remember this. If those who see KBC, the person who is receiving this memento is Dr. Sunil Shroff. He is our managing trustee of Mohan Foundation. In 2021, he was invited by Kaun Banega Crorepati as a Karam Veer. Has anybody seen this particular program? So he won, and it was the biggest spreading of organ donation awareness. After that, our telephones won't stop ringing. Hundreds and hundreds of calls asking, pledging for organ donation. So this is the kind of effect that organ donation awareness has on people. Thank you. Anything you want to know? Any particular question?
Thank you, sir. Thank you for enlightening about the importance of social media or the public awareness related to the organ transplantation. So we will move towards with ma'am, with ma'am Sujata. Sorry.
Excuse me. Disconnected. Okay. So probably this will be the last session of the day, at a stretch I'll be covering. And let me admit it, even before I start the session, this could be little more dry subject, because I don't know how many of you like law. Have you ever liked reading laws? Okay, very few. Right. So it could be little dry, but I'll try to make it as simple as possible. That is number one. And number 2, if you have any queries in between, please do let me know in case if I'm speaking too fast, or like if you want any explanation in the local language, please do not hesitate, because this is something that we need to be absolutely clear about, right? Okay, so before moving on, I would like to express my acknowledgement towards Dr. Sumana Naveen, who was our former course director, and I'm using her presentations. Right. So in this talk, we are going to talk about the whole journey of the law, right? So the first question, you all cleared. When the law was passed, it was 1994. You guys answered it in the morning itself. So the government of India passed this act in 1994, followed by rules in 1995, okay, the next year. If you ask, okay, what is the act, what is the rules, what are they basically? You know, like for example, if I tell you to cross the road, I'm telling you to do something, cross the road, right? So that's what the law says, do this or do not do this, right? Whereas the rules, coming to the practical implementations, for example, stop at the zebra crossing line, check your right and left, ensure the light is turned right, and then you start crossing. So these are the practical guidelines, how you have to do this. Similarly, that's what being dealt in the rules. So the law tells you, do this or do not do this. If you do this, this is what the punishments are. Whereas the rules will tell you, you have to do these. These are the people who will be doing all this, right? Clear? So we can't just say like I'm following the act. Basically when we say we are following the act and the rules, because it's the two sides of the coin, right? Years later, in 2008, without touching the law, the experts felt some changes to be made only in the rules, some minor insertions and deletions, okay? So that was called 2008 rules. So what was 95 rules eventually turned out to be 2008 rules with minor modifications, right? After that, almost after 17 years, everybody, the medical experts, the legal experts, the NGO professionals, they all felt in spite of having the law in the country, we're still not achieving the goals, meaning the disease donation is not taking up to its potential. There are still a lot of unpleasant things happening when it comes to living donation. So what to do? Maybe the law has to go for complete revamping, okay, lot of changes. So the 94 Act was looked into, was looked in for much more details. So it was amended, and then it became 2011 Act. Eventually they have to amend the rules as well. So the 2008 rules became the 2014 rules. So this is the journey of the law. So originally the law was passed and the rules were passed. Subsequently they were amended in 2011 and 14, okay? So this is the first segment. Coming to the next one. In Punjab, what is the first language if you are studying in a state medium school? For us it is Tamil, right? Like I come from Tamil Nadu. The lessons that you read in history, that is completely different from what we read in our history. It talks about historical people and historical events which were famous in that part of the country, whereas it is different to you, right? Why it is? Because it is state subject, right? So there are certain things when we talk about the implementation, like education is a state subject. Your state decides what your students need to read. Similarly, health is a state subject. That is the difference. You guys asking, ma'am, this is not mentioned in the act, but my people are asking why, because that's a basic difference, okay? Because it is the state subject. Though the government of India passes something, it is up to the state government, oh, do I need this law in my state? Should I be implementing? Then they have to pass it in their local assembly, then it comes for the implementation. So that is the second thing that we need to understand, okay? Apart from that, the third thing is, without any contradiction to the, once I accept, for example, Tamil Nadu or Punjab, it accepts the law, whatever has been passed by the country, government of India, without contradictions, without violating the provisions of the Act, if the state government wants to put some more procedures in the place, for example, like it lists out 10 documents, the law, central law. If the Punjab government feels there should be 2 more papers to be added to make it much more easier, then it is asked by the state government, right? So you can't say, because they felt this is something that has to be there in the law without contradicting the major. They can't violate the major provisions of the Act. They can further do something to smoothen the process on the ground reality. Okay, for example, in Tamil Nadu, I'm sure this is not there in Punjab, where like you have to, any disease donation, you have to send the body to the PGIMER, right? Like for the autopsy, or to the government medical college for autopsy, correct? That's how you do. Whereas in Tamil Nadu, not necessarily, because we have further procedures which tells us you can do the postmortem even in the private hospital in the case of disease donation. So this is something we need to understand. Certain procedures differ from state to state because those become the state protocols without violating or without contradicting the major provisions of the Central Act. That's the difference. You can't say Tamil Nadu is doing, I will do. Definitely can't, because you are governed by the Central Act or by your state rules. Whereas we have something else. That understanding needs to be there, right? Okay, moving on. So, like Dr. Ranjan almost finished the introduction in the morning itself. Why do we have this law in place? Basically to protect the living donors. Whatever we do, whether it is donation or transplant or storage, meaning banking, whatever we do, it has to be done for the therapeutic purpose, not for research or not for any other purposes. And it has to be regulated. If it has to be like this, if it has to be like this. So that's what the first aim of the Act. Second, it says, obviously, preventing the commercial dealings. No organ trafficking should be happening. So these were the 2 major aims of the Act. Okay. Apart from that, obviously, until 1994, though brain death concept was, introduced much more in the world, we could not have certified anyone brain dead in our country before 94, because the law did not recognize brain death as a form of death. So only from 1994, brain death has been legally accepted as form of death, and henceforth organ donation from these donors became possible. So these are the aims. Okay, 1, everything has to be in a regulated manner. Second, should be completely preventing the organ trafficking. Third, organ donation from brain death is legally acceptable. It has to be done in a processed way. Okay, right. So like as I said, most of the states have now adopted the 2011 Act and the 2014 rules. But if you just take it and read it, I'm sure you will not be able to understand anything, because for us to understand the 2011 Act and the 2014 rules, we need to have the understanding of the original Act and the rules, because it's the byproduct. So that's the reason, if you ask, ma'am, we are following only the recent Act and the rules, why are you covering the old Act and the rules? Meaning, unless you understand that, you will not be able to understand this, okay? And that's the reason this talk will cover the entire journey and, like major provisions of all those aspects, right? Okay, so moving on to the original Act, like in our textbooks, like we will have lesson 1, lesson 2, lesson 3, right? Similarly, the Act has 7 chapters, okay? Chapter number 1 is very easy, just the definitions. For example, when I say brain dead, when I say near relative, when I say donor, when I say hospital, what it is, everything has been defined. Okay, so please go through your law book. It's all just definitions. You don't need to obviously by heart it, but you need to understand who it is or what it is, right? So chapter number 2, I'm just quickly moving so that you will have a better understanding. Okay, authority for the removal of human organs. Okay, when there is a removal of human organ, who has to give permission, how it happens? There are 3 aspects, right? One is living donation. Second, taking a pledge during the lifetime. Third, organ donation after death. 3 phases, correct? When it is living donation, who has to authorize? Obviously, nobody else, the donor. Okay, so the person, if I am the donor, I have to authorize, okay, take my kidney or part of my liver for transplant. Second class, I agree to organ donation, but I don't want to be a living organ donor. Probably after my death, you can take my organ. So what do? I take the pledge, what Mr. Diwan just said. Third is, as we said, if something happens to me, the family has to give the consent. So that's what the law says. Living donation, the individual gives. For deceased donation, the individual expresses the interest, whereas for implementation, the family gives the final consent. So without their authorization, we would not be able to move ahead with the organ retrieval, right? Okay. Remember we said, for brain death, it's not just one doctor, there are 4 doctors, correct? The law says, who are they, those 4 doctors? Can we randomly call 4 people and ask them to certify? No. The law clearly says who are those 4 doctors, okay? So for the easy understanding, I'll just finish 1 and 4. For example, Dr. RMP is nothing but registered medical practitioner, meaning a doctor, okay? So RMP in charge of the hospital is the first person, meaning whoever is the head of this institution. For example, this institution, if the medical superintendent is the head of this institution, he automatically becomes the part of the brain death committee. He doesn't require any special permission. He holds it by his position. Okay. Similarly, the 4th category, RMP treating the doctor. For example, if it is the anesthetist or critical care physician who is taking care of the brain dead patient, then again he becomes the automatic part of the brainstem death committee. Okay, doctor number 1, doctor number 4, they both are from your own institution, because one is the hospital head, the other one is treating the patient. So they do not require any special permission to be part of the brainstem death committee. Clear? Whereas doctor number 2 and doctor number 3, they are not so. Okay, so doctor number 2, which is RMP from the government panel. What is appropriate authority? I will explain to you little later as we go along. So this doctor, the second doctor, is the neutral doctor or an independent doctor who has nothing to do with transplant. It could be your general physician or any other specialty who does not have any role with the transplant. Because if I am part, for example, the nephrologist can't be part of the brains, because there is a conflict of interest, because I want my patient to get the kidney transplant, so I shouldn't be part of the brainstem death committee. So the second doctor is the independent doctor. Similarly, the third doctor, the neurologist or the neurosurgeon, in the recent amendment, they have also included the intensivist and anesthetist. So they could also be part of the brainstem death committee. But remember, the 2 and 3, these 2 are not like you can, okay, I'll take a general physician from my hospital and say, no. These 2 doctors have to be specially empaneled by appropriate authority. Again, I'll tell you who appropriate authority is little later. Okay. For example, if your center is a licensed transplant center, okay, you have to send them appropriate authority. See, I am a transplant center. This is a transplant center. We would like to recognize these doctors as part of the committee for doctor number 2 and doctor number 3. We have to send the list to them, and appropriate authority will go through the list, meaning basically their qualification, their experience and all those stuff, and then they will give them permission to be part of the brainstem death committee. Okay, clear? Again, here, this is where the check is. For Punjab, for example, I just heard from Dr. Ranjan, in Tamil Nadu, all 4 can be from the same hospital. Just that first and 4 does not need any permission. Whereas 2 and 4, I will send it to the authorization from my own general physician department, from my own neurosurgery department. I will send it to the appropriate authority. They will go through his papers and give the permission. I can use them whenever I have a brain death. Whereas this is not the same in Punjab. This is where your state rulings come. In Punjab, apparently you guys have a rule that doctor number 2 and doctor number 3 should always come from a government hospital in your own state. So definitely you can't do brainstem death certification without 2 government representations. So that is the difference between state to state. Whereas in Delhi, I'm sure it's the same. You can use all 4 doctors from your own institution. Okay. So for example, doctor number 1 and 4, today for example, I'm the medical superintendent of this hospital. You keep it. And I am moving from this hospital today to some other hospital. Doesn't mean that I automatically become the brainstem death committee of that, because I'm not the superintendent there. Okay, this is only because of the position that I hold here. I am part of this. Whereas doctor number 2 and 3, once they are permitted, wherever they go, they can part of the brainstem. They can, from X hospital, they can go to Y, certify brain death. From Y to Z, because that comes to me, not by my position. It comes to me based on my qualification and experience. The government has empaneled me as part of the brainstem death committee. So for example, in Punjab, if you have to call the doctors from the representative, not necessarily. If they have bunch of doctors certified, it's up to you, whoever is available, willing to come. You don't need to necessarily stick with number 1, number 2 like that. Okay, so this is the difference, and this is how it works. Obviously, like different places, different states, different hospitals have different protocols in maintaining, because some doctors, why should I be unnecessarily in trouble in the future? So they'll say, I will use 1 and 4 from my own hospital. For 2 and 3, probably I will take 1 from my hospital, 1 I will take from the government hospital. So they will use different combinations, just that so that they are in a safe place. Otherwise, the law does not say anything. You have to do only in-house. You have to do only from the outside. The law does not say anything in particular. It's all about how your state says. Okay, clear? Moving to the next one, medico-legal case. Remember, everybody said that most of the organ donors in our country are road traffic accident victims. So whenever there is a death, forget about organ donation. Whenever there is a death because of unnatural causes, when the cause is not natural, it automatically becomes what? When the cause is not natural, not by medical thing, medico-legal case, because there is not only a medical aspect, there is also a legal aspect. When someone gets admitted to a hospital stating it was a road traffic accident, how do you know that it was merely a road traffic accident? It could be something planned murder, somebody could have pushed him, somebody would have hit him with a wooden block, whatever it is. So there is always a legal aspect when there is an unnatural death. So eventually it becomes medico-legal case. In medico-legal cases, only the medical parts can be dealt by the doctors and the professionals, medical professionals. So how do we deal the legal part? So there comes the police. So when there is a brain death, which is a medico-legal case, it's not just the family stating yes for organ donation. We need to involve the police to ensure that the legal formalities are done, because the police has to go and represent go to the forensic. There are certain things. When the patient gets admitted, the first aim is to save the patient. If we are not able to save the patient, second thing is, what is second? Okay, I'm not able to save the patient and he's dead. What is the second responsibility? Sorry? What is the second responsibility? If it is a medico-legal case, exactly, not organ donation. The second focus is why this patient died. Okay, finding out the cause of the reason is the second most important. Only then organ donation comes into the place. So the forensic has to say, okay, you taking out the heart or liver or kidney is not going to alter my autopsy study, is not going to compromise my study in terms of finding out why the person has died. So he also has to give the approval for organ retrieval. So when it comes to medico-legal case, it's not only the family, it is also about the forensic medicine. In between, the police comes, because we don't directly go to the forensic usually. It has to be routed through the police, because end of the day, they are the ones going to appear in the court. Okay, so please ensure any medico-legal case, we can't just take away the organs without forensics approval. Chapter number 3, regulation of hospitals. Very simple. The law says whatever you do, whether it is donation or transplant or surgery. For example, this is a world-class hospital in this part of the country. Does it mean automatically this hospital can do anything? No, they need to have a special permission, which means license. They could be like super specialty, like, you know, whatever the hospital, but they need to have a special license to do whatever the activities. Again, as a doctor, for example, if I am a transplant surgeon, liver transplant surgeon with over 20 years of experience, worked in multiple countries in the world, and doesn't mean that I can come and just operate here. I have to ensure that this transplant center is licensed. Only then I can do the transplant services, right? And appropriate authority. We are, remember, like, I will be talking about 4 bodies. One is Brainstem Death Committee, which we finished. Second is the appropriate authority. To put it in one single sentence, a government body which deals with hospital license, that is appropriate authority. Okay? Most of the states, it will be Directorate of Medical Health Services. I guess it's the same in Punjab as well. Okay? So they are the ones, basically, if you want to do the license, go to them. Apply to them. If you want to do the renewal after 5 years, go to them. So it's all the appropriate authorities' job. Who appropriate authority is? DMS in Punjab as well. So these are the functions. Granting the license, renewal of license, suspend or cancel the license, enforce the standard of care. Okay, you come to me and I give you the license after 5 years. I mean, after the license, 5 years, nothing between the hospital and the no. As appropriate authority, we need to ensure that you are following the standards of care for all 5 years. Doctor number A resigns and goes and somebody comes very junior. No, it can't be. You have to come and tell me, see, when I got license, this was the person, he had moved. And this one. Or like when we got the license, we had this service in-house, now we closed it, so we are going to the outside lab. So all those changes to be kept communicated to the appropriate authority, the standards of care. It has to be, like continued even after the licensing process. In case if there is any complaint against any particular hospital or the doctors or the team, then who gets the complaint? Appropriate authority, because I was the one who granted you the permission, right? So the complaints come to us, so we have the power to come and inspect, investigate the complaints and take action against the particular individual or the institution. Follow up. So all these are appropriate authorities' functions. Clear? Basically, the body which oversees your licensing part, your permission part, right? So this is the second body. Number 5, chapter number 5, registration of hospitals. In the law book that we have given to you, if you look at form number 12, 13, 14, 15, all 4 forms, basically either as a transplant center or as a retrieval center or as a bank, whatever it is. If you just look at the application, it is hardly 2-page or 3 pages document. Okay, so is it that easy? No. Basically, whatever you say in that 3 pages, for example, if you say, I have a dialysis department, yes, no. You have to give these substantial documents, how many beds, how many dialysis machines, when they were purchased, their working conditions, what is the RO system, how many dialysis technicians you have, their training certificate. So every little detail that you put yes or no or number in that 3-page application has to be documented with evidences, with proofs. So when you just give back to appropriate authority, see, this is my application, it will be like some thick fat book like this, okay? And appropriate authority will receive that application. They'll go through it, just that they don't give you sanction immediately. They will form an inspection team. For example, if it is kidney transplant license, they will put experts accordingly, and they will send that expert team to your hospital to basically see whatever you have said in that book, is it there? Is the doctor there? Are the nurses trained? Do you have all the equipments? Do you have proper OTs? Do you have post-operative care nursing? Everything. So they'll come and inspect, and then they'll go back and submit their reports to the appropriate authorities. See, these are all things there, or these needs to be updated, or these are like completely not okay. So based on their recommendations, appropriate authority will come and tell you, see, we are not giving you the permission because of these reasons, or we are satisfactory with your application and we are giving you the permission. So whatever it is, they will do. Okay. So basically it is like, do you have a specialized services, you have manpower, you have equipments. If you look at the application, that's what it is. Do you have all this? And then you get the license. Once you get the license, it's valid for 5 years. However, this is the central law. Some states, for example, Gujarat, we heard it's like between 1 year and 3 years. So every year you have to go for renewal. Every 3 years you have to go for renewal. So again, it changes from state to state. But the central law says it should be valid for 5 years. Okay. Right. Chapter number 6. Remember again, Dr. Ranjan was saying in the morning, the law talks about offenses and penalties. For example, if someone is involved in organ trafficking in whatever the way, or like in malpractice, or like forging the papers, or forged relationship, whatever it is, if it is proven, the person is subjected to imprisonment of 2 to 7 years and or fine up to 10 to 20,000 rupees. Remember, this was made in 94. Obviously, it was not a big sum amount. 20,000 rupees, you pay it and you are out of the jail. Probably that's the reason it was like happening more in numbers. Okay, I'll just finish it. And penalties for doctors. For example, if whoever is convicted, found to be guilty, is found, is a doctor, first time if the person has been convicted, the punishment is his name is taken off from the state medical council for 2 years. So for example, if I am found guilty of operating on a person who's not actually the wife, but with forged document, then if I was the instrumental in that, then I can no longer practice here in Punjab for 2 years. So that's a punishment. Okay, after for 2 years, I can again come back into practice. But for some reason, again, if I continue to do the same thing, and again, if I get caught, then I can no longer practice in this state. Complete deregistration. So these are the punishments for the doctors. Okay. So any common is, it is 2 to 7 years and with or without fine of up to 20,000 rupees. For doctors, first time offense, 2 years of decancellation. Second offense, complete decancellation from the state medical council. Okay. Last chapter, miscellaneous, nothing but, see for example, we are talking about go and talk to the family, go and do the public awareness. You take Mohan Foundation. We are not a transplant center. We are not a government body. We are nothing. We are only an NGO, but we still do because we are doing something which has been said in that law with good faith, and we are not doing anything wrong. So that's the reason we keep telling you, go and keep doing public awareness. You don't need to have any special permission, even if you do it at an individual capacity, because the law says anything done in good faith without violating the law's provision, then that should be acceptable and that's not liable for prosecution. You are not subjected to any punishments or anything. Okay. So these are the 7 chapters. Definitions, authority, regulations of hospitals, appropriate authority. 5th one is registration of hospitals, offenses and penalties, and miscellaneous. So these are the major provisions in the original act. Okay. We are yet to talk about the rules, amended act and the amendment rules. I'll promise you that I'll finish in about 30 minutes max. But I think we have to go for a tea break. So let's go for tea break. We'll come back and finish that, and then we'll head towards the activity, right? Remember we said if it is related donation, we have to do the tissue typing and establish the relationship. So that comes in form number 5. So this form number 5 is filled by the head of the laboratory, not some technician or some other person. It has to be done in a NABL lab, National Accredited Board of Laboratory. They have to a certified lab, and it has to be signed by the head of the laboratory. Please remember that. State that yes, Sujata is on these evidences, she is related to this person, and it will be signed by the head of the laboratory. Form 5. Okay. Form 6. Do not ask me why this sequence is, because that's how the legal experts had put it. It's not our responsibility, but yes. Remember we said if it is spousal donation, who will give permission? If it is spousal donation and transplant, who will give permission? Appropriate authority or competent authority or authorization committee. Who gives permission? Sorry? Please be loud. Competent, yes. If it is spousal, it is competent authority, right? So that's what form 6 is. So basically your head of the institute says that yes, Sujata is related to this person as wife and she is willing to donate her kidney to. So basically form 6 is given by the competent authority in the case of living spousal donation. Okay. And then form 7, remember Mr. Divan was showing the donor card. It is very much the simplified form of form number 7. I can't be carrying this A4 size 2 pages sheet all the time with me. So that's been simplified into a small donor card. All the provisions are written there. I'll just fill it and keep it like any other card. So form 7 is basically donor pledge. Okay. Form 8. In case if you have a deceased donor, which is brain dead or circulatory death donor in your hospital, remember we said the near relatives have to give consent, right? So where do they give consent? They give consent in form number 8. Okay. Earlier it used to be different form for adults and different form for pediatric patients. But now whether it is an adult donor or pediatric donor, it's all same consent form from the near relatives. Okay, it's form 8. Form number 9. Aarti, did you the one who asked the question? No, not you. Somebody asked the question of unclaimed bodies. You. Okay. So this is what it is. Form number 9. Basically, for example, if it is an unclaimed body, which is very often in hospitals like PGI MER, which is a government institute where we get unidentified bodies, and if the person has been certified brain dead, the law says after second brainstem death certification, wait for 48 hours, 2 days basically. Make all the efforts to find out the identity or trace the relations. Okay? Even after 48 hours, if you are not able to identify the person and if there is no sign of relatives coming, then it says the head of the institute can give the permission for organ donation in the place of near relatives. Okay? That's what it says. In case of custodial deaths, for example, prison deaths, the prison superintendent, he becomes the authorized person. In case of places like orphanage homes, not adult old age homes, because old age homes are different stories. They know who their relatives are. So that can't be counted in. Whereas orphanages, where they basically do not have anyone. So there the orphanage head becomes. So they all sign in form number 9. So unidentified bodies or custodial deaths are like places like orphanages. These people can sign form number 9. Right? Is it clear? Okay. But custodial death and all, like if it is immediately after brainstem death, it can be signed. But only if it is unclaimed body, you have to wait for 40, because we need to. That's the reason we often see in the paper, no, like 6 feet tall, fair complexion, wearing red shirt. Why are they doing it? Because they are trying to make the effort to find out who this person is, right? So all these efforts, we have to contact the local police station, file a complaint, give all these measures. In spite of it, 48 hours, if we are not able to find out who this person is, then the hospital head can take up the position and he can give the consent. Okay? So to my knowledge, to be honest, no unclaimed body donation has happened in our life. because like we have a lot of potentials to do with the known identity. If we could try, because like people do not want to get into unnecessary trouble, but law has provisions for this, right? And remember, we talked about brainstem death certificate. 4 doctors have to come, do a battery of tests, twice it has to be done. Where it all gets documented, it is in form number 10. Okay, so all doctors come, they do the test, sign, again go, after 6 hours come back, again do the certification and sign the paper. Form number 11, we are going back to living donation again. Remember, like 1, 2, 3 and all, only the donor said, I want to give my organ to this person, this person, this person, and I am medically fit and the relationship has been established, our competent authority gave the permission, whatever it is. But there was no place where me as a donor and the recipient, we came together for a mutual agreement, right? So form 11 is basically a joint application from the donor and the recipient. Often when you go to hospital, they say affidavits. Basically, affidavit is this, where like they are coming together and stating, I so-and-so wanting to donate my kidney to so-and-so who's related or who's my spouse or who's my friend. And that person says, I so-and-so suffering from this disease, wanting to get a transplant from this person. So that's what it is. Form number 11 is basically joint application or mutual application from the donor and the recipient. Okay. It's a bit of mess. 1, 2, 3, consent from living donor, living related, spouse, unrelated. 4 is medical fitness. 5 is genetic relationship certificate from the head of the laboratory. 6 is competent authorities approval for spousal transplant. 7 is pledge. 8 is donor family consent. 9 is consent in case of unclaimed body. Form number 10 is brainstem death certificate. 11 is mutual application between the donor and the recipient. Okay. Out of 21 form, we are cleared with the first 11 forms. 10 more forms. Okay. Remember, we said I want to apply for transplant license. How do I apply? Form number 12. Whether it is whatever organ or tissue transplant. Basically, I want to do a transplant. I take form number 12. Okay. And remember, we talked about HORC, Human Organ Retrieval Center. I don't want to do transplant. I'll just retrieve the organs. So there is a separate application, which is form number 13. And if you want to set up a tissue bank, take form number 14. In the tissues, every tissue is covered in that. Heart wall, bone, skin. Only for cornea, they made it as a separate form. Corneal donation or corneal transplant or corneal bank, form number 15. Basically, 12, 13, 14, 15 are applications. 12 is for transplant license. 13 is for organ retrieval center. 14 is for tissue bank, except cornea. 15 is anything to do with cornea, you apply in form number 15. So that's the difference, okay? 12, 13, 14, 15. Okay, you applied, they come for inspection, they give you permission, right? They give you license. How do they give you license? They give you back form number 16, that is your license. They'll say, this is the certificate of registration of Fortis Mohali to do the kidney transplant from this state to this state. So form 16 is certificate of registration, basically your transplant license. So every time you go to unrelated transplant to authorization committee, along with all the papers that you are submitting, donor, recipient, blah, 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 whatever it is, you have to submit your license copy every time to say that this hospital has a license. So every time it has to be attached. Then after 5 years, again you have to apply for renewal. Now they will give you back again renewal certificate. This time they won't give you 16, they will give you 17. Form number 17 is the renewal certificate. Basically like this is given to Fortis Mohali as a renewal certificate of kidney license for next 5 years. Okay, 16 and 17 are similar, but when you get it for first time, you get it in 16. After that, it will come in 17. Okay, again, form number 18, I know it will be too much of confusion, but you will get it, okay. Form 18 is, remember every unrelated transplant, we said it has to go to where? Unrelated transplant? Authorization committee. And we said they will give you permission, right? How do they give you permission? They give you permission in form number 18, okay. So form number 18 will say, we authorization committee give hospital blah, blah, whatever it is, to do the transplant between this donor and this recipient. Okay, that is the form number 18. And competent authority gives permission for 2 transplants. One is spousal, which is form 6, right? What is the other one? Near relative. That was never told so far, right? So that comes in form number 19. I don't know why they split like this, 6 somewhere, 19 somewhere, but this is how they had put down. Okay, so form number 19 is again from competent authority giving the permission for living related transplants. Other than spouse, they give permission in form number 19. Okay, form number 20, which is the domicile certificate. Again, the law is very clear that it has to be obtained only for unrelated transplants, but unfortunately, most of the states will ask for every transplant. Basically, this is required only when the donor or the recipient moves from one state to the other state. For example, if I come from Tamil Nadu, come to Punjab for donation or transplant, I need to take my domicile certificate. That's what the law says. But not for all transplants, only for in case if my recipient is unrelated, only then it says bring 20. But unfortunately, on the ground practices, for every transplant, if you are moving out of your state, bring form 20. That's what they practice, okay? So there is a little contradiction on ground practice and the legal provision. So in case whether the donor moves or the recipient moves, they need to take the domicile certificate, because how do I know this patient is actually from West Bengal? This donor is from West Bengal. The state has to give. If you ask me, how many of you are having nativity certificate? I have my nativity certificate. So what's the difference between this domicile certificate and nativity certificate? If you read the form, it will clearly tell you, because nativity certificate is a common purpose. You can give it anyway for any purpose, right? Whereas form 20 will tell you this is done for the purpose of donation and transplant, so that the person, whoever is signing, will be at most cautious. It's not like, okay, you pay 100 rupees, I'll give you my nativity certificate, because he has to understand the liability that is on him, right? So that's the reason form 20 is basically your domicile certificate, which has to be filled by the Tahsildar, and this is only for the mere purpose of donation and transplant. You can't use the certificate anywhere else. It's to establish your legal address, your domicile address, okay? So that is form 20. The last one is form 21, which is, for example, now India has become super good in medical advancements, and we invite medical tourism. Countries like Sri Lanka, Nepal, people do come here for transplants, right? Like they either, now I'm not talking about disease donation, living donation. They bring, because their country may not have facilities, or they want to go for extra facilities, so they come. So the donor and recipient come. What you know, max you will know this patient requires a transplant. And you will have their passport, and you know that they have come on a medical visa. That's all you know. Other than that, you will not know anything, right? So we can't take up the responsibility. So what we do is, like any other donation, we process the paper and we give it to their embassy. For example, the Nepalese embassy, we'll give it to them. Or Singapore embassy, we'll give it to them. See, we got 2 people from your country stating that this and this, and this person want to be a donor, this person want to be a recipient, and these are the papers. You'd give me the permission. So they give us the no objections, because they are not our nationals, right? So how do we know whether it was like a false passport, like all those stuff, we really do not know. So their embassy will go back and check, and they give the no objection certificate to us. That we will give it to the authorization committee. See, I got all this clearance, now you give me the permission. Because any foreign national, we have to get permission. Even if they are related, we still have to get permission from the authorization committee, but it could be hospital or district or state. But it has to be approved by the authorization committee. Okay, so these are the provisions. So once, along with all those papers, form 21 also, you give it to authorization committee, they will give you form 18. Okay, you do this transplant. So this is how it works, okay? I know it will be too heavy to learn on one day, especially at a stretch, but let's just do one activity for about 15 minutes. The more quick you guys do, the soon we can go home, okay? So I just want you guys to divide into around 7 to 8 groups. Just divide yourself. Just maybe 2 rows together, just form a group. Because whatever I have said now, it won't remain in your head unless otherwise you go through the forms and try to make an attempt of finding it out. So just form, like wherever you are seated, just form a group. All the groups got the forms? All of you got each set? If you come to the previous group, then you will get confused. Please remember who your group members are because the forms are within themselves. Okay? Right. Here.
They all are mixed.
Yeah, you mixed. Yeah, it is mixed. I will tell you what to do. Just take this. You.
We don't know, please come back.
1 minute, 1 minute, 1 minute, 1 minute. Neha, you just split them and give it to them. 1 minute, I'll give you the instructions. You keep this. This is for your group. This is for your group. Only 5 of you. Okay. I mean, like these 2 rows, right? Wait, I'll give you. Come and give you the instructions. Here, these two rows are one group. Okay, and here. All of you into one group. Where is who? Who's who? These 4 meaning this row and this. Okay, you 4 and the. Okay, right. Can you please move to this side? Okay, because you have to discuss here. And you guys are one group. Is it right? Okay, right. Because if you don't sit properly, then you will not get the forms properly. Okay. Can I have your attention, please, all of you? Okay, see, for example, each group has got 21 forms. You guys, each group, for example, the people sitting, unfortunately, the 5 people, you must be getting like 4 forms each at least. Okay, right? So, can I have your attention, all of you? Please listen to me 1 minute. Each group got set of 21 forms. You will have 21 forms in your hand. Okay. For example, if you think this is form, go through you read the content. If you think this is form number 2, and I have given you the sticky note, right? Please do not write it on the same paper because we can reuse them for the next batch. So in the sticky note, you write this is form number 2. And this form is used for, if you think form 2 is consent from the deceased donor family, then you write form 2 consent from deceased donor family. So basically, the number of the form, whatever I just taught, and the purpose why we use. Those things need to be written on the sticky note and stick it on this. Okay? In case if your batch members are messed up, then you will have repetition of forms because it shouldn't be happening, but I'm not sure how you guys are seated. Okay? Clear? Is it clear to all of you? Right? Okay, 10 minutes, just go. You want a sticky note? Sticky note, sorry. Sticky notes are required. There will be some more in the... Don't give it to us. It is your group work. Put it within your own group. Please don't give it to us. Please keep it within your own group. And this is a group activity you need to discuss. If one group gets 2 forms of same, that means somebody has done a mistake. Here. Obviously, one set will have only one form 1, form 2. So if you have 2 forms, that means somebody has done a mistake. Take 10 minutes, figure out and write it. They should have stapled. This is... Where is our copy? See, this is how I wanted them. Oh, they have... See, if it is pinned like this, then this is one form. Now that it would have gone to somebody else because it's not pinned, right? So they will think what form is this. Some forms are only 2 pages. Some forms are 3-4 pages. So we had stapled them and told them to pin it in the same way and give it to us in the same way. You're not referring to your law book. Oh, that's a mistake I have done. Okay. Not complete. See, they haven't. How are you saying this is not complete? This is, see, this must be the front page.
Okay.
And this is the two-page form.
Okay,
So who's
second.
signing?
Okay.
Look at the See, only if at all one or two forms should have been stapled. We didn't staple. When they got it printed, photoshopped, they didn't print it, photocopied it. So that alone, please forgive us. Oh, it's stapled. Meaning for organ transplant meaning?
मतलब ये वाला फॉर्म है ना, ये वो वाला फॉर्म फिल करते हैं, फॉर्म नंबर 12
She has form 12. If anybody else has filled it as form 12, obviously one of you is wrong. Correct? So please discuss within your group because this set should have only one form 12. So that's the reason I'm saying please discuss. You pick up a group representative so that they will know like 1, 2, 3, 4. You better pick up a group representative. Pick up a group representative so that you know if there are two forms, you will figure out. How is it going? Okay. Better pick up a group representative so that if there is a repetition, she will help you out. If there are two form 2s, then obviously someone has made a mistake, right? See whether you have form 1, form 2, form 3. Oh, somebody has made a meticulous notes. Who's your group representative? Oh, she is. Okay, I'm not collecting. She has to collect. Please see whether they have to your knowledge, see whether it is put out together properly. Done? Less confusion in this group, I guess. Three form 11s. Huh? It won't be same. If you read carefully, you will figure out. Unless otherwise they made a printing mistake and messed it up. Show me. Even if you don't write down the form number, which might be confusing, at least read the content and write the purpose. Even if you don't remember the form number, it's fine still because it's just one session. But at least get the purpose right. Read the content and get the purpose right. Done? Huh? Okay, good. So this group is done. So representative has checked. You have only one form, only 1, 2, only 1, 3. Have you guys checked it? Checked it or not? Done? Okay, one group has done. That means the time is over. Shall we go for discussion? Which group has finished? This has finished. That group has finished. Okay, that group. What about this group? You guys are finished? No? And you guys haven't finished. And those two haven't finished. Okay, another 5 minutes you should be finishing because I want to go to my room. Sorry? You also want to go? Okay. Even as I said, even if you don't get the form number, it's still okay, but get the purpose. Why are we using that particular paper? Please write it properly. If you think it is a medical certificate, fitness, then write it as medical fitness for the donor. Okay, I'll listen to the group representative alone. Sorry? Some form is missing? Can't be. Okay. Who has form 1 here? Are you in the printing something has gone wrong or what? Okay, let's just get the discussion going. Nobody got form number 1? Okay, let's just get started discussing, okay? Okay, this group, I am standing in this group which has got no form 1. That's what their claim is, okay? Let me just look at the form. Show me. I'll just show you this. Show me your form. Show me your form. Show me that form. Give me a form. I think really something has gone wrong in the printing. Give me other forms. Why are you holding these many forms, Pao? In Tamil, Pao means poor. Okay. I'm so sorry they have messed up with the forms. Here, no. Where's your form? You give it to her. I'm terribly sorry. I think in the photocopying business they had been messed up, I guess. No, distribute because like we just took one set and that's the reason we say like don't mix with the group. But anyway, Neha, can you please get me one full set there? I will tell them. Maybe they would be able to figure out with this explanation. See, just check your form if it has something. For example, what is form number 1? What is form number 1? Prospective near relative donor. Okay, so what is the clue? If you just look at the form, please carefully look at your form. In your form, if it is written, for example, in the first page, I authorize removal for therapeutic purposes and consent to donate my dash organ to my relative. And within brackets, it's written, specify son, daughter, father, mother, brother, sister, whatever it is. So that means, anybody has got this form? So that is form number 1 because it says, I want to donate this organ to this person who is related to me. So that is form number 1 which has to be taken in near relative. Okay. Similarly, form 2, the clue is, if you just look at the back side of the form, it will say, a certified copy of a marriage certificate. That's an easy clue, right? Because only in spousal we ask for marriage certificate, right? And it also says letter from whoever it is certifying factum and the status of marriage. So form 2 will have this clue. So this is basically consent from living spousal donor. How many of you got form 2? These many form 2 are. Okay. Seriously, something has gone wrong with photocopying. No, that side I'm saying, like that group, 2-3 of them, yeah. Okay, form 3, did anyone find the clue? Form 3. Anyone got, who got form 3? Any group, randomly. Okay, what is the clue? Can you tell me the clue? Just keenly look at your form. Okay, see the clue is in the first page it's written details of last 3 years income and vacation of the donor. Correct? Remember I said in the unrelated transplant we need to ensure that there is no financial discrepancy between the, so that is the clue. So this is form 3 which is living donor unrelated consent form. Okay? Okay, who got form 4 and can you please tell me the clue? This group got form 4 correct. Tell me the clue and Yeah. Form 4. Anybody got Form 4? Form 4 is what? Exactly. Form 4 is medical fitness. So this will say, the doctor says that it is certified that the said donor is in proper state of health, not mentally challenged, and is medically fit to be subjected to the organ donation. So that's the clue. So this is filled by the doctor, treating doctor, certifying the fitness of the donor, which is Form 4. Okay? Who got Form 5 and what is Form 5? Genetic relationship. Okay, what is the clue? What is the clue? Signing authority. It is written to be signed by the head of the laboratory. Nowhere else the lab's head signs. So that is Form 5, genetic relationship. Okay. What is Form 6? Signature of the competent authority in the case of spouse. So if you just look at it, the form will say, see, these are small clues, okay? If you read it, you will get it right, but the clue is signed by competent authority. It says, in case the clinical condition mentioned above is such that whatever it is been proved with the documentary evidences such as marriage certificate, marriage photograph, and all those stuff. So this is Form 6, competent authority certificate. What is Form 7? Donor pledge card. Okay, what does it say? What does it say? Clue? Signature of the pledger. Yes, it says that in the presence of mention, I would like to authorize the removal of following organs. That's what it says. Okay. After being declared brainstem dead. So after being declared brainstem death, I would like to give approval for these organ retrieval. So that is pledge form, form number 7. What is Form 8? What is Form 8? Yes, near relative of the? Okay, deceased. What is it basically? Consent from the near relatives for organ and tissue donation after death, meaning either brain death or circulatory death. It says, clearly it says, I, in the presence of persons, like whatever it is, it says, if you look at the form, point number 4, it's written, I hereby authorize or do not authorize removal of his or her body organs. Okay? And if you see down, signature of near relative or person in lawful possession of the dead body. So that's a clue. So that is form number 8, which is consent from near relatives either after brainstem death or circulatory death. What is Form 9? Yes, consent in the case of unclaimed bodies. And it says, if you look at the form, having known that no person has come forward to claim the body of the deceased after 48 hours. So that means that is the unclaimed body, consent from the medical head of the hospital. Form 10, brainstem death certificate. Even if I wake you up from your sleep, please don't mess up with Form 8 and 10. It has to be absolutely clear to you. Form 10 is brainstem death certificate. Form 8 is consent from the family. Please never ever make a mistake. Okay? So if you could see, there are 4 doctors: medical administrator, authorized specialist, neurologist, neurosurgeon, medical officer treating the patient. And it says, like, we have, after careful examination, we hereby certify that this person is brain dead. Okay? So that's the reason I said, please read the form, read the form. Unless you read it carefully, you will not be able to figure out. What is Form 11? Mutual application or joint application from the donor and the recipient. Easy clue, it says signature of the prospective donor, signature of the prospective recipient. Only this form will have both the signatures. Right? Remember I said this is the one place where both of them come together. What is Form 12? Application from the hospital to carry out transplant. Okay, this is application. So it says it is to appropriate authority And it says, we hereby apply to register as for names and organs and all those stuff, okay? Right. What is Form 13? Form 13, organ or tissue retrieval centers, not transplant centers, okay? So it says, we hereby apply to the registered as an institution to carry out. The easy thing is, if you look at the second page, there will not be any fee, because remember the retrieval centers, they have no benefits, right? They are not doing any transplant, so they can't make any benefits. So in the application paper, they have no fee mentioned. Whereas if I am applying for transplant license or tissue bank or corneal bank, whatever it is, there is some amount of fee mentioned, 10,000 or 5,000. Whereas non-transplant centers, retrieval centers, there is no fee, because the hospital does not get any profit by treating that patient, because it's just done for somebody else. Okay, that's the reason, that's a clue again. What is Form 14? Tissue bank. No, not corneal. Form 14 is tissue bank other than cornea. Any tissue bank other than cornea. Form 15 is cornea. The form straight away starts with eye bank, removal of balls. So it's just with the cornea. Form 16, license from the appropriate authority. If you look at it, this is to certify that dash hospital or a tissue bank to do this, okay, and signed by the appropriate authority. That is Form 16. Form 17, renewal. If you look at it, this is with reference to the application from this hospital for renewal of, see, it is clearly written, for renewal of certificate of license, okay. What is Form 18? Form 18, authorizations committee's approval for unrelated transplant. Remember, every unrelated transplant has to be certified by someone, correct? So it says this is to certify as per the application Form 11, because Form 11 only both A and B sign together. So if you look at the backside, it will say, all this designations and all this stuff are written. Its permission is withheld or permission is not granted. Permission is granted to do this transplant. That's a clue, okay? Form 19, near relative consent from the competent authority. Competent authority's approval from, so it clearly says signature and stamp of the competent authority, and above it says they are related to each other, okay? And Form 20, domicile. It clearly says see, first line itself says verification of domicile status for donation of whatever it is, okay? So this is domicile certificate. Form 21, foreign embassy. Last one, it says signature of the senior embassy official, which comes from the foreign embassy. Each form has got its clue, just that you guys need to read it. Even if you don't get the name, please get the purpose right. You can't give Form 21-2 in your brainstem death certification. That makes no relevance, okay? So please go back home, read through the forms at least to get yourself equipped. And if you have any queries, please come back to us tomorrow, okay? Bye-bye. Thank you. Please collect your forms and give back to us.
Board? Are you enjoying? So today is just a warm-up. So actual game will begin from tomorrow. Okay, so this is just a warm-up. I know it sounds very complicated to look at those 20 forms. It will appear, because it appeared to me also as a surgeon. But Believe me, the day you see your first donation or first transplant happening, that day is going to change your life. These forms, there are hardly 4-6 forms which you need to remember. You don't need to remember all the forms. So gradually, once you start interacting with the families, once you come into the trade, you will realize which form is important. Anyways, so we have a lot of surprises also on days to come. I just want to know how many are outstation candidates. How many people have traveled here? 1, 2, 3, 4, 5, 6, 7. And from which places? Just people who are coming from outside. Which places are you from? Faridabad, Shimla, Delhi. It's good to see somebody from Delhi because Delhi is the hub of the transplant. Faridabad. Yeah, exactly. Which place are you from?
South Delhi.
South Delhi. Which hospital?
She works for Mohan Foundation.
Mohan Foundation. Okay. Somebody from the back? Sorry? Kolkata. Wonderful. So thank you all so much for staying back with us, and I know it's a very exhaustive program, but the batting will begin tomorrow. Tomorrow you are going to love it. So keep your brains open, have a good meal tonight, sleep well, and see you all tomorrow at 9:30. 9:30, are we beginning at 10? So please be here by 9:45. Okay? Thank you.